Okay, there are some major important pharmacology topics which we will be discussing through our life. So what are these important topics? So already as we have posted earlier, what was that? That was about the topics which we are going to discuss. But along with that, in this live, guys, I would like to teach you people one of the important aspect. What is that? How the questions might be asked for your exam and what are the important MCQs to be highlighted from the exam. So all these things we are going to learn, and please remember there's one thing I can guaranteely tell you people. So the upcoming for FMG exam, in that I can assure you that the 50% of the questions would be covered from this session itself. So I want you to follow this session very keenly, very interestingly, and this is a very important and very much score making subject, pharmacology, right? So let's start the discussion of pharmacology. So in the pharmacology, guys, always we will have one important thing, that is your general pharma, and all of you will hate it as soon as I say general pharma. So we are sleepy, so we don't want to learn this much. So I'm going to make it simplified as much as possible for you, and you people are going to enjoy it. That much I can thoroughly guarantee, right? So let's start with the pharmacology. So in the pharmacology, as I have told you people, what is the first important discussion we are going to do? That is your general pharma. See, when we are learning about general pharma, there are multiple approaches to it. What do I mean by this? See, some people would like to teach the general pharmacology in the end. Some people like to dedicate the general pharmacology in the starting. I would like to start with your general pharma, right? Now, when you're talking about general pharmacology, my dear students, it's very easy, but only thing is that you need to have your mind broadly open. What do I mean by this? So general pharma will teach you some of the very interesting things. What is that first important thing? All of us know one thing called drug. What is a drug? It is a chemical. When it is taken into the body, which will have a therapeutic or maybe some altering effects which can be present in the body. It is a simplified definition, I call it. Now, in this drug administration, say I give you a tablet, you swallow the tablet. I give you an injection, either you might take an intramuscular or a intravenous injection. So, first important thing which we need to understand is route of administration. Route of administration. So, what do I mean by route of administration? Easy for you to understand, guys. So, how exactly you are going to administer the drug? So, all the routes of administration is divided into two types: paraenteral, and there is one more thing called as enteral route of administration. So we have two routes. One of them is parenteral, another one is. Now, what do I mean by this parenteral? Parenteral is any route of administration which is not using the gastrointestinal tract, but enteral, which using your, what is that? GIT. What is that? GIT, gastrointestinal, being used. So enteral route of administration. So what are the two openings we have in the GIT? Of course, one to eat the food, one to defecate. Exactly speaking, what is that? Oral cavity. So we can administer the drug orally, and there is one more opening, that is anal, that is rectal opening. So we are going to administer it rectally. So we have two route of administration called as per oral, and there is one more thing called as per rectal administration. Now guys, please understand, per oral and per rectal administration, in both of these things we are using intestine for the absorption of the drug. That is why we call it as a enteral route of administration. Now parenteral. So parenteral, we have IV route. Good. We have very good IM route. Very nice. Very nice. Okay. Yes, PDF will be available, of course. Okay. Now, apart from that, we have subcutaneous. Very good. We have one important thing. All of you people will get confused. That is only called as sublingual route of administration. So, guys, what is this sublingual route of administration? Basically, you are administering the drug under the tongue. What happens when you give a sublingual drug? What is going to happen? Directly, drug will get absorbed into the neck vein. What is that? Neck veins. Now, what are these neck veins? Basically, your jugular vein. So, once you give the drug sublingually, it is neck veins. From there, it will reach the circulation. So, it will enter the neck vein and directly it will reach the circulation. It will reach the circulation. Now, if you notice here, so though we are using, what is that, sir? That will be your, what is that? Oral cavity, but the drug is going into the systemic circulation. So, that is why I want you to understand that is a paraenteral route of administration. So, by now, you people should have a clarity. What is that? That is your all the drugs which are administered using GIT for the absorption, called as enteral. Point number one done. Point number two, or anything else use the administration route, para-enteral route of administration. Okay. Now, guys, let's continue to the next aspect. So, there are some other important routes of administration. That's the intra articular. So when you are administering the drug into a joint, for example, we have some drugs which are administered into the, what is that, meninges. Basically that is your anesthetics which we are going to use, that is only as intrathecal administration, right? Now during these things, guys, I want you people to understand there is one important aspect. What is that? For sublingual, they might ask you people sometimes the examples of the sublingual route of administration. The classic one is your nitroglycerin. Classic one is a nitroglycerin. And in some countries, some hormonal pills also manufactured in form of a sublingual pills. But one classic for your exam need to be remembered is nitroglycerin. How to administer nitroglycerin? Sublingual. Very nice. So let's continue to the next aspect. See, guys, see, it's very easy in the routes of administration. This is very vague, like, very simple to be understood, right? But when you go to the next important aspect, whatever the drug you give, right? So what happens to that? Let's start with the most important chapter, that is only called as pharmacokinetics. Pharmacokinetics. So to be frank, this route of administration in the exam point of view, it is less important, but pharmacokinetics is a big chapter and very important, and quickly we are going to go through. And whenever I say this is an important point, dear students, what you need to do, make a note of it, because that's going to be 100% sure but MCQ people. So please be ready for that, right? Now pharmacokinetics. So what is pharmacokinetics? That is effect of effect of body on the drug. So basically what you are looking at, basically you are looking at effect of the drug which is received, effect of the effect of the body onto the drug. I'm sorry, effect of the body on the drug. Okay, so what exactly your body will do to the drug, we are going to call it as a pharmacokinetics. So what and all your body can do? The first important thing, your body can absorb the drug. Absorption. Okay, apart from absorption, okay, what it can do after absorption, see, drug came into the body, then drug has to get distributed all over the body. We call it as a distribution. Okay, now apart from that, after distribution, what will it do? It will do its work. Okay, it will do its work. But the important thing is that distribution is what? Distribution is a all over the body, the drug is getting distributed. Then you are going to look at metabolism of the drug. Is that metabolism of the drug? Metabolism of the drug. And the last one to be said, what is that? That is your what is that? That is your excretion. The excretion. Very good. ADME. Very good, Deva. But the thing is that, guys, I want you to understand absorption. This is a first aspect. What is that first aspect? The first aspect is absorption. So what is the absorption? Let's learn. So for that, guys, how exactly absorption occurs? For the absorption of the drug might get occurred with the help of a passive diffusion. It's a simple process. Okay, the absorption of the drug can happen with the help of, what is that? With the help of active transport. So it is going to need some transporter, it is going to need some transporter for the absorption. Then there can be the most confusing part, that is your pinocytosis. What is that? Pinocytosis. Now when you're learning about pinocytosis, so pinocytosis is nothing but cell drinking, all of you learned that. So when you're learning about pinocytosis, my dear students, pinocytosis is cell drinking. Through this route, drug can be absorbed. That is what I'm trying to tell you. And the last and most confusing for you people, that is your phagocytosis. What is that? Phagocytosis. Now the question will be what? Hello. So what exactly the question? Question will be like this: all of the following are the methods of drug absorption except, and most of the students will make a mistake right here. Where is that, sir? In the phagocytosis concept. What happens? Phagocytosis means cell eating. Sir, we studied it in microbiology. It doesn't mean you studied in microbiology. It doesn't mean the same root of what is that? absorption cannot be present for the drug. There is no rule like that. So let's go to the next important aspect. What is that? Factors affecting what? Factors affecting the absorption. This is also very important aspect. So what are the factors affecting the absorption? So when we are learning about factors affecting the absorption, guys, look here. What are the important aspects? The first and most important, what is a drug? Drug is a chemical. When it is a chemical, we need to look at something. What is that? That is your molecular weight. Molecular weight of the drug. Okay. Now, what do I mean by molecular weight of the drug? Remember like this: size matters. How does size matter? The larger the drug, lesser the drug absorption. Larger the drug, lesser the drug absorption. Okay. Now, pinocytosis. I'll explain again. Pinocytosis is a cell drinking. Okay. So basically, it's a little bit similar to that of phagocytosis, in which substances can be engulfed into the cell. That's it. Okay. Now, molecular weight. If you have a molecular weight, if it is more, means the drug is larger. If the drug is larger, automatically what's going to happen? If the drug is larger, absorption will be decreased. Absorption will be decreased. If the molecular weight is more, it will decrease the absorption. Okay. If molecular weight is less, automatically it will increase the absorption of the drug. It will increase the absorption of the drug. So this is the fact about your molecular weight. So apart from the molecular weight, there are other important aspects. So what are those important aspects? See, guys, what exactly is that? The chemical nature of the drug. I would like to tell you people what is the nature of the drug. Nature of the drug. So what do I mean by nature of the drug? So nature of the drug is nothing. Guys, listen to me. All the substances can be acidic, substances can be alkaline. Though substances, if they are acidic, or substances they are alkaline, so what will happen to absorption? Let's understand. Okay. Now, nature of the drug. Drug can be, what is that? One thing, that is your acidic drug. Okay. Now, if there is a acidic drug, my dear students, understand, acidic drug will have a increase of absorption. Where exactly? In the acidic media. So wherever we have that acidic environment. What do I mean by acidic environment? Let's take out GIT. In the GIT, we have stomach, we have intestine, we have other parts. In the stomach, we have an acidic pH, but in the intestine, we have an alkaline pH. So based on this, some drugs will be better absorbed from the stomach. Why? Because stomach has an acidic pH, and if I have an acidic drug, the drug will be better absorbed. From where? If acidic drug, of course, from the stomach. If alkaline drug, from the intestine. So absorption is better in the acidic media. So if there is a alkaline drug, is it alkaline drug, so there is an increase of absorption in the alkaline media. So most importantly, guys, understand the media where exactly drug is being absorbed. That also matters. So please understand about this one: acidic and alkaline drug. Okay. Apart from that, is there anything else for the factors affecting the absorption? So there are other factors such as your GIT factors. What is that? GIT factors. Okay. So gastrointestinal tract factors. What do I mean by gastrointestinal? The factors which will affect from the GIT, but they will affect the absorption, such as gastric empty. What is it? Gastric empty. Okay. So when you're talking about gastric emptying, based on the nature of the drug, gastric emptying might affect the absorption. Okay. For example, GIT pathologies, they will also affect the absorption. Okay. Apart from that, the next important aspect, the next factors are your pharmaceutical. See, so far we understood about other biological factors and all. We are going to understand pharmaceutical. Pharmaceutical factors. Now, pharmaceutical factors. So, if I tell you people this term pharmaceutical, you people are going to use that. That is very easy. Pharmaceutical factors are nothing but we are talking about the drug itself. What do I mean by this? For example, we have powders. Okay. We have powders. The next one we have is syrups. Okay. Then we have capsule. Now, which one will be absorbed faster? faster and take a guess. Let's see. Okay, I'm waiting for you to respond. Syrups are there. Okay, sir. Then I have powders, sir. I have capsule. Among these three, which is the better one you feel? So Kiran Gopal says powder. What about others? Okay, syrup. Devanjan says powder. Okay, syrup. What makes you think syrup, powder? What is the difference? Guys, please understand. Very good, very good. So most of the confusion is between your syrup and the powder. Okay, okay, okay. Very nice. The answer goes to your. The correct answer is your syrups, guys. Correct answer is your syrups. What do you mean by syrups are the correct answer? Because look here. Syrup is in a liquid form. So in the liquid form, the drug is already dissolved. If the drug is already dissolved, it can absorb very easily, very easily. So that is what I am trying to tell you people. Syrups have a better absorption. So syrups have a better absorption than powder. Powders have a better absorption than a capsules. Okay. Now capsules. Yes. Yes, Dr. Manish. Okay. Now capsules. Now, when you're talking about capsule have a different method of advantage. Okay, the different method of advantage is that the capsules can be used for the slow absorption of the drug. Okay, so that is a totally different aspect. But when you're looking at a rate of absorption, very quickly happens in a syrup. Basically, the liquids will get absorbed very fast. Now, we understood about absorption. Apart from that, there is one last thing, that is only your solubility of the drug. Is that solubility of the drug? What do I mean by solubility of the drug? The solubility of drug, I mean to tell you people, is very simple. This drug can be usually two things. What is that? Lipid soluble. Lipid soluble. There can be one more possibility, that is your water soluble. Water soluble. Okay, now listen to me very carefully. What are the two types? Lipid soluble, water soluble. Now you people will tell me, what is that? Lipid soluble will have better absorption or water soluble will? Tell me. So all of you will tell one answer only. What is that one answer? Let's see. Lipid soluble or water soluble, which is better absorption? Okay, so all are telling me lipid soluble. So guys, listen to me very carefully. Water soluble. Please understand, it's very easy. That is your lipid soluble have better absorption. Lipid soluble will have better absorption. Why better absorption? Because lipid soluble drugs can easily cross the cell membrane. Easily cross the cell, because our cell membranes are made out of three substances: protein, lipid, carbohydrate. Okay, now in that lipid, that is your phospholipids. Now these phospholipids, guys, phospholipids will have this particular importance. What is that? The drugs which are lipid soluble will be absorbed through this phospholipids, so will have a better absorption. Now water soluble drugs will require, most of the time water soluble drugs require a transporter. Require a transport. Now you people will answer this question. Let's see, which of the following is highest in the cell membrane. Now you people should answer me this, okay? Now don't rush to the answer. Don't rush to the answer. I will give you the option. Don't rush to the answer. I have wrote the question, so some people will be rushing to the answer. Don't rush to the answer. I'll give you four options. Option A, protein. Option B, lipid. Option C, carbohydrate. Option D, none of the above. Okay, I need an answer quickly. Let's see. Protein, lipid, carbohydrate, none of the above. Okay, okay. All of most of you are telling me, what is that? Lipid. Wow, wow, wow. Very nice, very nice. So when I made this question, what makes you people think? So when I know that it is a directly, if I am telling you cell membrane has lipid, everyone knows. Everyone knows that, right? If everyone knows that, I wouldn't put a trap for you. So I have put a trap. Clearly, the answer is protein. Clearly, the answer is So the 55 percentage of the cell membrane is made out of protein. Now, why you people made a mistake here? I'll tell you that also. Because all of you people learnt one thing. What is that one thing you people learnt? That was proteins are about less. Because you people used to think phospholipid. What is that? Lipid bilayer membrane. So from that lipid bilayer membrane, what you have studied, you used to tell that lipids are what? Lipids are very rich. But the answer is proteins, guys. Proteins is the correct answer. Okay, one myth busted. One myth busted. Can you mark this question? I'm not joking. This can be very important MCQ. Now, if I am only putting a trap for you, don't you think examiner knows the trap for you? Definitely, he'll put a trap there. Got it? So we are just getting started. Okay. Throughout the session, I'm gonna give you all the surprises. Too many. Okay, don't worry. Now, enough of absorption. Yeah, bored, right? Let's go to the next one. Sir, absorption. How long? Okay, let's go to the next one. What is that? After absorption, what should be there? Distribution. Okay. Now, distribution is very easy. What is this distribution? So, distribution, in the distribution itself, I would like to teach you people one of the important concept called bioavailability. But before going there, distribution is what? The drug reaching desired site of action. So, what happens here? So, distribution of the drug, what is going to happen from the site of administration to where? To one of the most important location, to the tissues. So the distribution, if it has to occur, the most important, again, the factors are very important. See, distribution factors are very much important. Look here, what are those? The first and most important factor of distribution is solubility of the drug. Sir, already you told about solubility. Yeah, I told about solubility. See, in pharma, this is a, what is that? Some factors will be present for both absorption and distribution. Okay, so listen to me very carefully. Solubility, if it is a lipid soluble, it will cross all the membranes, such as for example blood brain barrier, for example blood placental barrier. So if it is a lipid soluble, it will cross the barrier such as blood brain. If it cross the barrier, it will reach wide range. If it is a water soluble, definitely the distribution. Again, size matters, I told you people, right? So what do I mean by this? Molecular weight of the drug. Apart from that, is there anything else, sir? Yes, there is one important thing. This is the important concept. Plasma protein binding. Plasma protein binding. Now, plasma protein binding capacity. Very easy to understand, very interesting, and most important thing. Look here. What do I mean by this? Let's consider this is one. Okay. Now, inside this blood vessel, what do I have? Blood is the basic question. So, this blood, what I have? Here I have it. Right? Now, this drug is bound to the plasma protein. What is a plasma? Now, listen to me very carefully. The drug came into the body through the route of administration. From there, the drug was absorbed. Now, this absorbed drug is inside the blood vessel. Okay. Now, in the blood vessel, the drug was going like this. It saw a beautiful girl. That beautiful girl was plasma protein. Okay. Now, to this beautiful girl, drug went and got attached to the beautiful. Now, after the drug got attached to this beautiful girl, what will happen? He won't let go. The drug will not let go of this beautiful girl. Who is that? Plasma protein. So, plasma protein is there, to the drug is bound. Now, if the drug is tightly bound, is very much attached to that plasma protein, automatically he will not get separated. Means plasma protein binding, that will affect the drug distribution. How exactly? If there is a higher plasma protein binding. Okay. If it is a high, automatically what will happen to distribution? He will remain in the blood vessel only. If he is strongly remaining in the blood vessel only, he is not going into the tissues. So desired site of action, it will not reach. So what I am trying to tell you people, if the plasma protein binding capacity is higher, it will lower the distribution. Now, apart from that, the next important aspect, what is that? If the plasma protein binding is less, now that will lead to what is that? Increase of the distribution. But is there any use? What are the uses of the plasma protein binding? Okay. Now, the uses of the plasma protein binding, see, if it is strongly bound, it is dissociating slowly. If the drug is dissociating slowly, now this makes the advantage. What is that? See, Drug came into the body. Now the drug is increasing. What is that? It is increasing. See, that is increasing. One of the most important aspect. What is that? Duration means more long it is bound. The drug is slowly getting removed into the tissues. So automatically it will increase the increase the duration of action. It will increase the duration of action. Okay, now apart from that, drug will remain in the body for a longer period of time. Means drug can be stored in the body. So it is a sense of saying drug can be stored in the body. Okay, now if plasma protein binding is there, there is one more thing. What is that? That is only called as one of the most interesting concept, that is called as displacement. What is a displacement? Okay, now I told you people, what is that? There is a plasma protein. This is a beautiful girl. He was bound to a drug. Okay, now what I'll do, I'll send in one more handsome guy here. So there is a new drug. Now once new drug comes, he will come and bind with the plasma protein, and he will kick the old guy out. Now this drug will become alone. So if there is a displacement, what will happen? Suddenly the drug will become free in a large quantity. If more quantity of drug becomes free, that might lead to toxicity. Displacement can lead to toxicity of the drug very easy. Displacement can toxicity of the drug is. So throughout this, what is the take home message? If you know that there is some displacement reaction occurred with the help of drug by any drugs, now this condition you need to be very careful. Because that might lead to toxicity very easily. Very good. Okay. Now, let's go to the next important aspect. That is only your EF. What is that? EF. What do I mean by EF? That is only your bioavailability. Now, what do I mean by bioavailability? Guys, bioavailability is very easy for you to understand. Bioavailability is very simple. What do I mean by this, guys? The quantity of drug reaching systemic circulation in unchanged form. Definitely you people are getting bored when I tell you the definition. Unchanged form, I'll explain you people, very easy to listen to me. What happens? Let's consider you gave a drug. What is that drug? Let's take one acidic drug or anything. Now you gave one drug X, whoever it may be, drug X. Now this drug gets absorbed and it will go to where? It will go to the liver. Now, this drug X, when it comes to the liver, the drug can get metabolized. Okay? After metabolism, whatever the remaining drug will go to the circulation. So what do I mean by this? I mean by this is very easy. The remaining drug, whatever is going to the circulation, means, for example, in the starting, if I give 100 mg of the drug, now in the end, I'm getting only 60 mg of the drug. Now this 60 mg of the drug is only reaching, I'm going to call it as a bioavailable drug. What do I mean by this? The drug which is going into the circulation, how much? 60 mg in an unchanged form. This is only your bioavailability. Okay. Now, when you're learning about bioavailability, so you need to understand the measure of bioavailability. Measure of F, that is your bioavailability. How exactly you are going to measure that? Okay. Okay. So once you need to understand that is what is that measure of bioavailability. It is used with the help of some concept called as area under the curve. Now what do I mean by area under the curve? Let's take one simple method here and understand. Now look here, guys. Here what I'm going to tell you people, here will be time. And here I'm going to tell you, I'm going to write what is the plasma concentration. Okay. Now, when you're looking about time and the plasma, for example, at 0 point of time, I gave a tablet. Okay. After 10 minutes, the drug is here. Means what do I mean by this? I mean by this is, for example, at given point of time, for example, let's take 1 hour. After 1 hour, the plasma concentration was this. So what happens is that you gave a drug orally, start to absorb. With time, what will happen? The quantity of drug will be increased in the plasma concentration. It will reach up to a peak, means the maximum. After that, what will happen? Drug will start to get metabolized. Slowly, the quantity of drug will start to go down. Okay. So at this point of time, the concept. Now look here. The point. This one is maximum concentration. So you'll need to look at two factors here. What are the two factors? The one factor is your, what is that? That is your the time taken for the drug to reach a maximum concentration. We are going to call it as a T. We are going to call it as a Tmax. The Tmax. So Tmax we are writing in this line. So we call it as a Tmax. Okay. Right. Now in this line here we are going to call this as a Cmax. What do I mean by Cmax? The maximum concentration. The maximum concentration. Cmax. So they might give you a graphic picture and ask you people what is the time taken to reach this particular. So I'll put a graph like this. Okay. And I'll point it as A. So what is the time taken for this drug to reach A point? We will call it as a Tmax. We'll call it as a Tmax. Now understand the concentration where it is reaching the Tmax. We call it as a concentration max. But here I want you people to understand there is one more thing. So at this some level we have something called as MEC. Now, what is this MEC? This is a very important MCQ, that is minimum effective concentration. Minimum effective. So, what do I mean by minimum effective concentration? So, listen to me. For example, Cmax of a drug. Cmax of a drug is 50 mg per ml. Let's consider random drug, random number. The maximum concentration, how much it can go? 50 mg per. Okay, very good, very good. Now, listen to me here, maximum. But the concentration of 30 mg per ml itself, start of action. Start of action. Now, what do I mean by this? Let's understand. I gave a painkiller, right? I gave a painkiller. The maximum it can reach is 50. Maximum it can reach is 50. But at the 30 itself, pain will start to decrease in the patient. So at minimum, what is the minimum concentration that has to be present in the blood vessel so that effect will be seen? That is only called as MEC, which is also called as minimum effective concentration. Minimum effective concentration. So this is the most important aspect which you need to understand, MEC, right? So measure of bioavailability. Now, if you notice here, guys, this area, whatever which is present under this curve, we are going to call it as a area under. So area under the, now this will be called as area under the curve, right? Now this area under the curve which I have depicted is more of oral drug administration. Now what is that AUC? AUC for IV. Now, this can be picture-based question. In the last exam, the general pharma related questions were more. So, please understand how does a AUC for a IV looks like. It would look like this. Now, understand at 0 time, in the starting itself, what did you do? You gave a drug IV. If you give a drug IV, the large quantity of drug went into the vein. If the large quantity of drug went into the vein, at 0 point of time, the maximum concentration will be there. So, this would be the starting point. Now, from there, with time passes, the drug concentration will start to fall down and your curve might go like this. So if you look at here, this is a curve where at the 0, this is 0 time. 0 time is the point where you gave a injection. So at this point of time, a large quantity of drug is present. At 0 itself, we have your highest concentration of the drug. With the time, the drug quantity is going down. Now, whatever area which is present under this curve, we are going to call it as a AUC for the IV. So, they might ask you a question by giving a picture. Above picture depicts which of the following routes area under the curve, that might be IV or oral. So, the first one I told was oral. Okay. So, once you understood about this, there is a last important aspect. What is that last important aspect? That important aspect, guys, there is one important question. Look at this MC. Which of the following, which of the following, which of the following conditions have conditions have high high distribution for water soluble drug, for a water soluble drug? Okay, this is a question. Option A, congestive heart failure. Option B, what is that? That is your NPHS mutation. NPHS mutation. Option C, that is your chronic liver disease. Option D, all the above. Yes, guys, tell me the answer. Yes, of course, below MEC there is no mechanism of action. Now, I'd like to see the comments. Tell me the answers very quickly. Let's see. Yeah. So, what is the relationship here? I am asking you people, water soluble drug should have a highest distribution in which of the following condition? So, this is my question. Okay. Some people, Yashwant says that is your CHF. Okay. What about others? Others are not even answering. Tell me quickly. Take a guess. If you don't know the answer, you need to take a guess. What to take a guess? So, when you don't know the answer, A, B, C, D, C. In FMG exam, do you lose any mark? No, right? If you're not losing any mark, then why you are being worried about it? You need to take a guess. Tell me. Yeah, guys, please. Okay, somebody says C. Okay. What about others? Others says, like literally we didn't understand the question. Okay. Oh, very good. CLD. Okay. Now CLD, I'll tell you what you thought. You people thought, okay, drugs he is talking. If he is talking about drugs, that means it is metabolized. Most of the drugs are metabolized in the liver. So let's answer as a chronic liver disease. Right? The answer is not that one also. Now, the correct answer, my dear students, the answer is all of the above. Answer is all of the above. Why all of the above? In all of these following conditions, we have one common factor, that is your edema. That is your edema. In the edema, there is an increase of distribution. Increase of distribution of what? Of your one of the interesting drugs, that is your water soluble drugs. Water soluble drugs. So please understand, the water soluble drugs will have what is that? That is your better distribution during edema. Why? Because during edema, all the body tissue, all over the body, the fluid is accumulated in the tissue. If fluid is accumulated, what will happen? The drug can be dissolved in the water. Now it can go into the tissues and accumulate very easily. Okay. So be ready. See, I knew. Now, most of you people are thinking, sir, what the hell is this NPHS mutation? We have no idea. Okay. Now, listen to me very carefully. NPHS is a gene in which what will happen? Nephrotic syndrome will occur. NPHS1 and NPHS2 gene mutations will lead to nephrotic syndrome, congenital nephrotic syndrome. Now, congenital nephrotic syndrome patients will also, any nephrotic syndrome patient will have a edema. In the patients with edema, again, the water soluble drug will have a better. Got the point? Okay, let's continue the next one. What is the next one? So once we understood about distribution, my dear students, let's go to the next important aspect, that is your metabolism. The metabolism. Now, once we need to understand about the metabolism, metabolism is very important. Metabolism can also be called as biotransformation. biotransformation. Okay. Now, what is this biotransformation? Let's see. Now, what happens is that during a biotransformation, see, very simple, drug came, okay. Now, once drug came, now the next important aspect, what happened? Distributed. Now, drug has to get metabolized. Now, if drug has to get metabolized, how exactly it will occur? Let's understand what and all can happen. Now, we have an active drug. We have an active drug. The drug is active outside of the body itself, comes into the body, it will do its action, become an inactive drug. Inactive drug or inactive metabolite. See, after metabolism, we call it as a metabolite, inactive metabolite. Very good. Now, the next important thing, what can happen is the drug is inactive. The drug is inactive. Okay. It comes into the body, and the drug becomes active. Drug becomes active. We call this concept as a prodrug. We call this concept as a prodrug. So, when you're learning about prodrugs are what? Prodrugs are a group of drugs which are active in the body, but they should be activated in the body, which are inactive outside of the body. Outside of the body, inactive, comes into the body, they will undergo the effect of some enzyme, become an active drug. We call it as a prodrug. Now, in the prodrugs, you need to give me some examples. Give me some examples, guys. Let's see. Okay, what are the examples for prodrugs? All of you to learn. One of the most important drug you should all know. What is that? That is your L-dopa. What is that? Your L-dopa. That is your levodopa. What is that? Levodopa. Levodopa. Okay. Now, apart from levodopa, there are other drugs such as ACE inhibitor. ACE inhibitors. Classically, we have NL. You have enalapril. Now, this enalapril is a inactive drug. The inactive drug becomes active in the body. Okay. Now there are other substances. There are so many other products. Okay? These are the two important things I wanted to remember. Let's go to the next one. What is that? The inactive to active understood. The most and interesting aspect, that is your active drug. Active drug becomes active metabolite. This is an interesting concept. Why? See, all of the examiners knows that you people will remember. What is that? What is that? That is your prodrug. He is gonna ask you active drug becoming a active. So active drug becoming an active metabolite is a very important question. That is examples. Can you give me some examples? Very good, very good. What is that? That is your diazepam. Diazepam, the most important metabolite. So look here, diazepam will get converted into one of the active metabolite called as oxazepam. Oxazepam. This is the important metabolite among others. This is the most important metabolite you people should know. Diazepam becomes oxazepam. This is the most important active metabolite. Okay. Now, please listen to me very carefully. This might be a MCQ. Why this is a MCQ? See, listen to me very carefully. Now, this diazepam becomes a active metabolite called as oxazepam. Because of this, you need to know these drugs, especially benzodiazepine. There are other benzodiazepines also which give rise to other active metabolites. Among which you need to know diazepam. So diazepam, when you are using, now these metabolites are also excreted by the liver, and this drug can go to toxicity very easily. So you need to be very careful when you are using, what is that, benzodiazepine in elder patient. Elder patient, because easy toxicity and easy excessive sedation can occur in the patients of elderly age. The next important aspect, that is your codeine, guys. What is it? Codeine. What is that? Codeine. Codeine gives rise to active metabolite called as, oh, morphine. Okay. Now listen to me. Codeine is right now not widely used in where, but codeine earlier it was used for treatment. Codeine earlier it is used for treatment of, what is that? Dry cough. What is that? Dry cough. Now this dry cough treatment after taking it, it will go get into morphine. Morphine is a opioid. Even though codeine is also a opioid, but morphine is having higher addiction tendencies. That can lead to one of the dangerous aspect, that is addiction. These are the two important drugs I want you people to remember: active drug to active metabolite. Okay. Once you understood about metabolism, most common site of metabolism is the liver. So in the liver, what exactly happens is that there is something called as RT Williams, RT Williams classification, RT Williams classification of the reaction, RT Williams classification of the liver reaction. So liver metabolizing the drug, that metabolism is classified with the help of RT Williams classification. RT Williams classification says that there is a phase 1 reaction, okay, and there is one more thing called as phase 2 reaction. How many phases? See, when I say phase 1, automatically your answer should be there is one more thing called as phase 2, of course. Now, what is a phase 1? Now, phase 1 reaction, all of them are usually simple reactions. They are very easy to remember also. Now, the question comes to you people. See, easy reaction, if you tell to examiner, it will get out. So, you need to understand. What you need to understand? Phase 1 reactions are your microsomal reaction. So, all these microsomal reactions to occur in the liver, they are your phase 1 reaction. Okay, and there is a phase 2 reaction. What is that phase 2 reaction? They are your non-microsomal reaction. Okay, now among these you can also call it as what is that? The phase 1 reactions are usually synthetic reaction, means they are going to synthesize some, but here non-synthetic reaction. What is it? Non-synthetic. Okay, now what exactly this phase 1 reaction? For example, you talk about oxidation. The phase 1 reaction. You talk about cyclization, the phase 1 reaction. Okay, you talk about decyclization. Decyclization is also a phase 1. For example, you talk about simple reactions such as hydrolysis. All these very easy and basic reactions are your normal reaction. Now, non-microsomal reactions such as glucuronidation. Glucuronidation. Now, glucuronidation reaction is a reaction in which what happens is that the water-soluble substance are being generated. Why water-soluble substance be generated? Because see, what is the target of the metabolism? Drug has to be reached. So, you people are getting confused. Administration, distribution, metabolism. After metabolism, drug has to be eliminated. So, if the drug has to be eliminated, how it has to be? Water-soluble. So after which reaction? With the help of one of the reaction is glucuronidation. After glucuronidation, what will happen? This fat soluble drug will become into water soluble drug. Okay. Now, see why phase 1 reaction called as a functionalization reaction. See, we already established one thing here, doctor, that is your synthetic reactions, right? If there is synthetic reaction, means this is not the reaction in which complete drug might not be metabolized. For example, we discussed about earlier, what was that? That was your, remember here, what is that? Prodrug. In the prodrug, again, the reaction occurred where exactly? The liver itself. In the liver itself. But the concept you need to understand is that the drug was inactive, in which what happened? The drug became active, right? So here the drug is becoming functional. So that is why we can call it as functionalization reaction also. So phase 1 reactions are not ultimate end of the drug. Got the point? Okay. Now let's go to the next important. Glucuronidation. Glucuronidation is a reaction. What is that? That is what happens here is that, what is that? Here fat soluble substances will get converted into water soluble substances. We have other reactions such as methylation. Okay, apart from that, for example, there are other drug reactions: sulfur 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 reaction. We can also call it as a sulfization, which we can also call it as sulfur reaction. Okay, now this special reaction the special reactions which has that is your non-microsomal action, non-microsomal reaction. Now, methylation. There are some drugs which undergo methylation reaction. Anybody tell me the drugs which undergo methylation reaction? Let's see. It's not more about, it's less about the site, rather it's more about your this functional, the drug becoming functional. Okay, anybody tell me the drugs which undergo methylation? So the drugs which undergo methylation, example of the drugs undergo methylation, undergo methylation. Okay, methylation, and there are some other drugs, and there are some other drugs. Examples of the drugs undergo acetylation. Acetylation. Okay. Now methylation, there are many groups. There are many groups of drugs which are less important, but the examples of the drugs undergo acetylation very important. These see, here we have drugs. There are few antibiotics which undergo methylation reaction. Okay, but here the drugs which undergo acetylation are very important. What are those? They are your ship drugs. What is your ship drugs? So this is standard mnemonic we use. What are those? Sulfur drugs. Sulfur drugs. Okay, for H for hydralazine. H for hydralazine. Okay, now apart from that, I for isoniazid. Isoniazid. P for prokenamide. 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 Then D for dapsone. D for dapsone. Okay. Now, please understand hydralazine, isoniazid, prokenamide, and dapsone. These are the drugs which undergo which reaction? Acetylation. Now, please understand about this concept. What is that? The same drugs can also lead to one important problem, that is your drug-induced SLE. These drugs can also lead to drug-induced SLE. Among those most important, I want you to remember hydralazine. Hydralazine, classic example which can induce the drug-induced systemic lupus erythematosus. So far we discussed about metabolism. Right? Now, metabolism is done by the liver enzyme. So once there is a liver enzyme, one of the most important things that is only called as inducers. Now, inducers definitely 100% there will be an MCQ. There will be MCQ. Now, what is this MCQ? Look here, enzyme inducers. Basically, they increase the liver enzyme activity. They increase the liver enzyme activity. Now, my dear students, you people will tell me liver enzyme activity, if they increase, please tell me what will happen to the drug metabolism. For example, I have one drug, drug A. Okay. Now, drug A is an inducer. I have drug B. It has no effect. It has no effect whatsoever. No effect whatsoever on what is that? On your enzymes. Okay. We have two drugs. One drug is drug A, one is B. Now, A is the inducer, B is having no effect on the enzyme. Now, I'll combine them both. What will happen? I'll give to the patient. Now, once I give it to the patient, what will happen? It will increase the metabolism. Agreed. Increase the metabolism of only one drug, all the drug. Increase the metabolism of all the drugs in the body. Increase the metabolism of the all the drugs in the body. So, for example, when you give an inducer, what will happen? It will lead to excessive enzyme activity, which might lead to, so increase the metabolism of all the drugs. Automatically, if all the drugs get metabolized, it will lead to therapeutic failure. Therapeutic failure. So what I'm trying to tell you people is that, for example, if you combine any enzyme inducer, that can lead to therapeutic failure if doses are not adjusted properly. We will understand that with a classic example. But before going there, let's understand the drugs. What is that? Griseofulvin. Griseofulvin. Okay. We have phenytoin. We have phenytoin. Okay. Apart from phenytoin, we have one more drug called as rifampicin. Rifampicin. Okay. Yes, for smoking. We have one more effect, that is smoking. Then we have carbamazepine. We have carbamazepine. Carbamazepine. Okay. Then we have one more drug, that is your phenobarbital. Phenobarbital. Okay. Now all these drugs are your enzyme inducer. How to remember? GPRS. CP. What is that? The mnemonic, classic mnemonic used used everywhere. That is your GPRS cell phone. So with the GPRS cell phone, what you can remember? That is your the drugs which are enzyme inducer. Very good. GPRS cell phone. Okay. Now grisafulvin, phenytoin, rifampicin, smoking, carbamazepine, phenobarbital. Now what exactly happens is that a 23-year-old recently married recently married female came to hospital with UPT positive but on OCPs. But on OCPs. She was started. She was started treatment of PTB 3 months back. UPT can be explained. UPT can be explained by. Let's look at the option. Option A, isoniazid. Isoniazid. Option B, rifampicin. Option C, ethambutol. Option D, all that. Okay, guys, tell me the answer. So the answer is what? 23-year-old recently married female came to the hospital with a UPT positive. Urine pregnancy test was positive. Okay, but she was on the OCP. If she was on the OCP, there is less likely or impossible that she must be pregnant. See, it's not impossible, but less likely that she can get pregnant. But the important aspect is that she was started with the pulmonary TB treatment. So TB treatment consists of what? 4 drugs: isoniazid, rifampicin, ethambutol, pyrazinamide. Among these drugs, which can explain the condition? This can be explained by your correct answer. Very good. Rifampicin. What rifampicin does, sir? The rifampicin will induce the metabolism. Rifampicin will induce the metabolism of other drugs. Now, this is a repeat question which was asked very recently. So be careful, guys. This is a very important question. Okay. Now, let's go to the next important. Where there is an inducer, there should be an inhibitor. What is that next important aspect? We are going to understand enzyme inhibitors. What is that? Enzyme inhibitors. So, what are the inhibitors? These enzyme inhibitors are the group of drugs which inhibit the liver enzyme. Now, when we are talking about this inhibitor, so inhibitors are very easy for you to understand. These inhibitors, guys, we have the drugs such as ketoconazole. What is it? Ketoconazole. Okay. Now, there one drug, antifungal drug, that was your bisoprolol. Here one antifungal drug, ketoconazole. Now, some people will tell me, sir, we will remember it with mnemonic. I'll tell you people one major problem. If you remember pharmacology with mnemonics, there is a major issue. What is that major issue? That major issue is that at the end of the day, you will forget. See, P is present in a mnemonic. Okay, P for what is that? Pyrazapine, pilocarpine, phenytoin, phenobarbital. You will not be able to understand which drug is which one during the exam. So don't remember complete pharmacology with the help of mnemonics. Please do not do that. Okay. Now, there is one drug, ketoconazole. Okay. There is one more drug, that is your cimetidine. What is that? Cimetidine. Now, cimetidine also causes one side effect. Also causes one side effect. What is that side effect? Can anybody tell me? Okay, I'm waiting for the answer. Let me continue the other drugs. There we had a anti-epileptic drugs. Here also we have one more drug, that is your valproate. Okay, there we had one anti-TB drug. Here also we will have one more anti-TB drug. What is that anti-TB drug? Isoniazid. Isoniazid. Okay. Now, the side effect is your gynecomastia. Gynecomastia. Okay. Now, gynecomastia is a side effect. This is a side effect caused by your cimetidine, again, which is a very important MC, which was asked earlier, not even earlier times, around 2019-20 it was asked. Not very old question. Okay. Now, again, this question can also come up for you people. How exactly? See, in recent times, the question cannot be direct, so it can be clear. A patient was taking treatment of TB, taking treatment, also was on benzodiazepine for anxiety, for the now suddenly after anti-TB treatment, overdose of benzodiazepine occur, can be caused by which drug? Can be caused, that is the option A, ketoconazole. Now don't rush to the answer. Ketoconazole. Option B, valproate. Option C, isoniazid. Option D, Refam. Okay, tell me. Let's see. See, acute alcohol, we are not looking at enzymes here. That is totally a different story. Acute alcohol will have a totally different spectrum of symptoms. Okay, don't confuse. Okay, Devanjan says C. What about others? Others are like, sir, we are confused. Maybe ketoconazole, maybe valproate, right? Okay, Mohammed says C. Any other answers? Only two people are telling the answer. Rest other. Okay, everybody says C. Very good. The answer is C because you people might answer as a ketoconazole, but don't answer ketoconazole. Here we are already clearly telling anti-TB drug was also taking benzodiazepine for the anxiety. Now we give a once isoniazid is given, suddenly overdose might occur due to enzyme inhibitor action. This can be a MCQ which can be asked again. So be very careful. Okay. Now we understood about the inducers, we understood about the inhibitors. The next important aspect, that is your excretion of the drug. Excretion of the drug. Now when you want to understand the excretion of the drug, most common route, that is your kidney. Most common route is your kidney. Okay, now in the most common route is kidney, guys, understand one of the important aspect. What is that? Most common route is your kidney, but the most important, there is elimination. This elimination of the drug will occur with the help of something called as zero order kinetics, and there is one more thing called as first order kinetics. First order. Now what is this zero order kinetics? Zero order kinetics, there is a constant, all of you know, constant amount is eliminated. Constant amount is eliminated. What do I mean by this? For example, I have 100 mg of a drug in the blood. Okay, now you people might have by hearted think blindly. What is that? That is the calculation. Do not calculate. See, there is no rule that always 100 mg will only be there. No, there is no rule that always 100 mg of the drug will be present in the blood, right? So you don't just remember the numbers. Remember this one: constant amount is eliminated. Constant amount is eliminated. What do I mean by constant amount is eliminated? Now look here, guys. For example, this 100 mg of the drug, after 1 t half, after 1 t half, for example, the drug becomes some 80 mg of the. So here how much is removed? 20 mg is removed. Okay. Now the next T half will occur. Now here what will happen, 60 mg it will become. So if you notice again 20 mg, there is a fixed quantity. Here is not about the percentage, here is about a fixed quantity of the drug is eliminated. So for this, the classic examples are the drugs which eliminate by zero order. So there is one classic example. See, God is very brilliant, I can say. Why God is very brilliant? Because the classic example you need to remember is your alcohol. Sir, there are other drugs also. Na? What are those? We have something called as 0 watt power as a mnemonic. See, among those, except for alcohol, other drugs can follow sometimes first order kinetics also, sometimes mixed order kinetics also. So there is a fixed always one substance which will undergo, what is that, zero order kinetics, alcohol. Just imagine how brilliant God should be. Once a person drinks alcohol, all of a sudden complete alcohol cannot be metabolized because only fixed amount will be removed. So this is your alcohol. Now first order kinetics. So in the first order kinetics, what happens here? Constant fraction of the drug is eliminated. What is it? Fraction of the drug is eliminated. Here for example 100 mg of the drug is there. Now this 100 mg of the drug after 1 T half, for example 1 T half, it will become 50 mg. Now if you notice here what happened, 50% of the drug is gone. Now next 1 T half will occur, it will become 25 mg. Okay, so what happened here again, 50% of the drug is being removed. So whenever fixed percentage of the drug is eliminated, that will be your zero, that will be your first order kinetics. Now zero order kinetics, the classic example I want you to is alcohol, but please do not put yourself in a position where you'll remember other drugs, but I'll give you the examples. Zero order kinetics, other examples such as warfarin. Again these drugs, again I'm telling, these drugs there is no fixed rule that they will always follow zero order kinetics. Yes, mostly they follow zero order kinetics, but they can shift first order kinetics also. Okay, then there is alcohol. There is one more drug, aspirin. There is one more drug, aspirin. Okay, then we have for example one more drug, that is tolbutamide. Okay, then most important aspect, what is that? That is your phenytoin. That is your phenytoin. Okay, so all these drugs undergoes your, what is that? That is your zero order kinetics. But remember that is fixed one is alcohol. This concludes all the important questions, all the important MCQ parts related to your pharmacokinetics. Okay, ethanol is basically alcohol. See, that is only edible alcohol. So please, all of you remember one thing. So how many of you during lockdown, when you are not getting alcohol but you wanted to drink alcohol, how many of you drink hand sanitizer? None of you. Why you didn't drink hand sanitizer? Hand sanitizer was available now. It smells like alcohol only. It is alcohol only. It has methanol. We could have drank it, right? Why we don't drink it? Yeah, tell me. Let's see how many of you can answer. Why didn't you drink hand sanitizer during lack of alcohol during the time of, what is that? During the time. Oh, because we have brain. Yeah, we have brain. What did your brain tell? Yeah, brain would have told, na, bro, it smells like vodka. Let's drink it. But no, you didn't drink. Why? Because remember, methanol is it's not about distilled nothing. Okay, listen. Methanol is such a substance which will create a toxic metabolite called as formaldehyde, which is a toxic to your eyes. It can lead to eye damage. Okay, so if you don't get alcohol, it's okay to have withdrawal symptom, but don't drink hand sanitizer because it is toxic to your eyes. It can lead to loss of vision. Eyes gone. Very good. This is only called as hooch tragedy. Hooch tragedy. From forensic, you could people would have studied. Okay. So whenever we say alcohol, we are talking about consumable alcohol in the pharmacology, except for one place where we are talking about disinfectants. Okay. In other places, it has interaction with alcohol, means We are talking about ethanol only, ethyl alcohol, which is a drinkable alcohol. All right. Very good. So this is a story of your pharmacokinetics. Why I took so much time in the revision session for your pharmacokinetics, because there is a lots and lots of use and lots of understanding required. So that is why. Okay. So guys, so far we discussed about pharmacokinetics. You people might be thinking, why did I give a break very quickly? The reason behind it is very simple. I don't want to saturate your brain, because you need to take the information of upcoming topics. So that will be very easy after general pharma's most important topic, that was your pharmacokinetics. Let's go to the next important aspect, pharmacodynamics. Pharmacodynamics is very easy for you people. So what is pharmacodynamics? Pharmacodynamics is a very easy and interesting thing. Now, so far we studied about one thing. What is that? Effect of the drug on the body. We are going to study about the effect of the drug on the body. Okay, earlier we studied about effect of the body on the drug, right? That was pharmacokinetics. Now here we are going to study effect of the drug on the body. The body. Effect of the drug on your body. So what and all a drug can do to your body is what you are going to learn in a chapter called as pharmacodynamics. In the pharmacodynamics, it's very easy. So somebody has asked me, what is the difference between ethanol and, so structurally speaking, methanol is made out of single carbon and ethanol is made out of two carbon atoms. Okay. Now methanol is usually used as a ethanol is usually consumable alcohol. Okay. Now let's continue. Now, whatever we are looking here, does it sound like mechanism of action of the drug? So, how any of the drugs can work in the body? So, look at those mechanism. The first and most important mechanism of action. For example, bactericidal. So, you have your antibiotics. So, those antibiotics can kill the microorganism, or for example, bacteriostatic. Okay, so this is one type of example. Apart from that, the drugs can also do other things, such as enzymatic action. That enzymatic action, what do I mean by enzymatic? Usually the drugs will go and inhibit a enzyme, any enzyme. For example, let's take it, NSAIDs inhibit an enzyme, cyclooxygenase are a cox enzyme, that is a enzymatic. For example, you have one action called as placebo. So basically, here we are not going to give the original drug, but patient will think that there is a body. So this is a type of placebo action. There is one more action called as nocebo action. What is it? Nocebo action. So these both actions are, most importantly, they are majorly psychological factor action. Your psychological factor. So in nocebo, what happens? Usually there is no side effect, but patient will think that because of your treatment only there is some problem came up. Okay, that also we can, that is a type of action. Now these placebo and nocebo are not so much important. What is our favorite thing? That is your receptor mechanism action. That receptor mechanism. Now receptor mechanism of action, most of the people feel very difficult. So let's start with very basic understanding of this particular mechanism. So let's start with one cell, right? Let's start with one. Now in this cell, we have a cell. Now on this cell membrane, I have some. Now, for example, I will have two drugs, drug A, and I'll have one more drug B. Now, when drug A acts on this receptor, it will activate, for example, some enzyme. Now, because of this enzyme, there is some. So, because of drug A, what happened? There is a activation of some enzyme and there is a action. Now, this type of activity which occurs inside the cell, we call it as a intrinsic action. Okay. Now, let's take about drug B. Now, drug B, when it acts, there is no action at all, no action inside the cell whatsoever. So, if I have a drug and add this drug on that receptor, it will go and bind. It will go and bind to the receptor, but there is zero action. So, whatever action occurs inside the cell Based on that, the receptor mechanism is divided. Based on that receptor mechanism. For example, we have some drugs called as agonist. We have one more drug called as antagonist. One more drug called antagonist. Now, when you look at a receptor action, you need to look at two factors. What are the two factors? One of them is called as affinity. One of them is called as affinity. The another one called as intrinsic activity. What is that? Intrinsic activity. So, whatever the activity occurs inside the cell, okay, and one more thing, affinity. Affinity means what? Ability to bind. Now, look here. I had two drugs, drug A one. I had one more drug, drug B. Now, if I gave a drug A, there is an intrinsic activity present. So now drug A went and bound to the receptor, and because of that there is a intrinsic activity. Means drug A is binding to the receptor. Sir, okay, and there is some intrinsic activity. Yes, sir, the intrinsic activity present. But let's give the number of this intrinsic activity as plus 1. See, this plus 1 and minus 1 which I am going to use it is just for a understanding. Okay, the numbers which we are using is just for a understanding. So now look here, antagonist. Now antagonist, let's take drug B. Now drug B is also binding to the receptor, but there is no intrinsic activity, right? So means it will go and bind with the receptor, that is antagonist, but there is no intrinsic activity which I'll give. So agonist is such a type of drug which will go and bind with the receptor, agreed, okay, but it will have a strong intrinsic. Antagonist is such a substance, no intrinsic. So based on that, we have one more type of substance called as inverse agonist, and there is one more substance called as partial agonist. See, any of the drug, if it is working through a receptor, all of them will have a affinity, ability to bind to the receptor. So affinity is present for both of them. But let's start with a partial agonist. Partial affinity is present, but intrinsic activity, partial means what? A little bit. So the intrinsic activity will vary from 0 to plus 1. We are using 0 and plus 1, right? So 0 to plus 1, somewhere in the middle the activity means agonist will have a maximum activity, partial agonist will have a little lesser activity. Simple. Now inverse agonist, it will reach the effect but totally reverse effect. See, if intrinsic activity is 0, antagonist, rest every other thing agonist. Intrinsic activity is 0, agonist, 0 agonist, 0 agonist, 3 agonist or antagonist, 0 antagonist, 0 antagonist, but any other thing is there, then we are going to call it as a agonist, such as here 0 to minus 1 intrinsic activity. 0 to minus 1 intrinsic activity, totally reverse or a negative activity, but still activity is present inside the cell. We call this mechanism of action. Now in the mechanism of action of the receptor, let's understand the receptors types. Now, when you understand the receptor types, there are multiple ways to classify. I'm going to take one simple way to classify. The first and most important receptors are called as GPCR receptor. Basically, they are using G protein, their mechanism of action. In this, they will have multiple subtypes. One of them is called as G. In GS receptor, S for stimulate, means it will go and stimulate an enzyme called as adenyl cyclase. So if it is stimulating adenyl cyclase, it usually lead to what? Increase of CAMP. Now most of you might be confused here. You have a ATP. That ATP will get converted into CAMP. ATP will get converted to CAMP with the help of an enzyme called as adenyl. Okay. Then that is stimulating the enzyme. Okay. Then we have one more type. There is called as GI. They are going to inhibit the adenyl. Simple as that. They are going to inhibit the adenyl. Agreed. Now let's go to the next important. What is that? There is one more thing that is only called as GO receptor. They basically increase the calcium in the cell. They increase the calcium in the cell. So they will increase the intracellular calcium. There is one more type of receptor that is only called as GQ receptor. Now GQ receptor will increase something called as IP3, inositol 3 phosphate, or they will increase the substance called as diacylglycerol. These substances will also intrinsic. If you notice here, after receptor is stimulated, either one substance came, CAMP, or calcium, or IP3, or DH. Now, all of these substances are called as secondary messenger. All of these substances are called as secondary messengers. So, these are the subtypes of the G protein coupled receptor. A, GQ, GO, GS. Okay. Now, let's go to the next important. There are next important receptors. We have the next important receptor called as ion channel receptor. Ion channel receptor. Now, what is this ion channel receptor? Now, this ion channel receptor operates with the help of something called as ligand. With the help of something called as ligand. The most important thing, if you consider this is one cell, so here I have a ion channel receptor. If I stimulate this receptor, it will allow the entry of some, for example, let's take chloride ion. Now, what happened? I stimulated the receptor, because of that chloride ion came. So, this ion channel receptor facilitate the movement of the ions in or out of the cell. We call it ion channel receptor. Now, ion channel receptor, all of you remember one classic example, that is your GABA receptor. Your GABA receptor. When you look at a GABA receptor, now GABA receptor, what type of receptor? They are the receptors which will allow the chloride ion movement. Allow the chloride ion movement. This is your ion channel. Now, apart from that, there is something called as nuclear receptor. Nuclear receptor. Now, when you are talking about a nuclear receptor, please understand nuclear receptors are the receptor level of a nucleus. If you consider this as cell, okay, inside the cell, what do you have? Nucleus. On the nucleus, I will have some. On the nucleus, I will have some receptor. Now, these receptors will have. So, these type of receptors are called as nuclear receptor. The examples are, for example, we have something called as PPAR receptor. That AR receptor. Paroxysmal proliferative activator receptor. Then we have something called as thyroid hormone, thyroid receptor. Then we have something called as vitamin. Which vitamin? That is your vitamin D3. Your vitamin D3 receptor. All of them will have a nuclear receptor. Now, apart from that, there is one more type of receptor. Those receptors are called as enzymatic receptor. Enzymatic. Now, basically, these receptors has to work. They work with the help of enzymes. The classic two examples you need to remember. There is one receptor called as tyrosine kinase receptor, tyrosine kinase type of receptor. So, the tyrosine kinase receptors will work for some hormones such as prolactin, okay, such as insulin. Okay, then there is one more thing, that is your growth hormone. Growth hormone. Okay, so look here, the classic way to remember them is your PIG. So pig is a way to remember your tyrosine, right? But most importantly, the question will come to you people like this: all of the following except act via what is a tyrosine kinase receptor. Tyrosine kinase receptor. Kinase receptor except. So this, one second. So these receptors, there will be question all of the following except question. Okay, option A prolactin, option B your insulin, option C your growth hormone, and option D will be your glucagon. So now you people will remember what is that mnemonic pig. So if you remember the mnemonic pig, what will happen? They'll get confused, because whether it is growth hormone, whether it is glucagon, that will become a question. That will become confusion. So the correct answer for you people is your glucagon, because glucagon does not act via tyrosine kinase. Okay. There is one more type of example for this receptor, that is only called as Janus kinase receptor. Janus kinase receptor. Janu, Janus kinase receptor are also called as JAKs. They work in a called as JAK-STAT path. They work in a place called as JAK-STAT. So this is the importance about your receptors to remember, right? So once you understood about this, let's go to the next. important aspect, the next important aspect we are going to understand the autonomic nervous. So far what you discussed is your general pharma. There are very few questions, but very confusing ones, and major confusion of your pharmacology. If you know autonomic nervous system, the 50% of pharma will become very easy. Okay, let's start with that. Now, autonomic nervous system is divided into two types. One of them is your sympathetic nervous system. Another one is your parasympathetic. Okay. Now, sympathetic and parasympathetic nervous system. Guys, please understand. Consider this is a brain. Okay. From the brain, what is coming out? Spinal cord. Okay. Now, all the parasympathetic nerves, they will arise. They will arise from the cranium. From the or all the parasympathetic nerves arise from the sacrum. Sacrum. That is why we call it as a craniosacral outflow. Cranio. So either they start from the cranium. Okay. So what are the cranium which work as a parasympathetic? What are the cranial nerves which work as a parasympathetic? Anybody? Please tell me. The cranial nerves which act as a parasympathetic are your 2, 7, 9, 10, among which I want you people to remember at least 10. That is your vagus nerve. At least vagus nerve. Okay. So there is a 2 also has a effect on the craniosacral outflow, and there is a majorly there is a third cranial. Okay, third and second both, but most importantly 3 also can. Okay, so for you people I will remove all these 3 and I want you to remember 10th cranial. Okay, 10th cranial nerve is a very important. Now, sacral outflow. Now, when you look at a sympathetic nervous system, either sympathetic nerves arise either from where? Either from the lumbar area or from the thoracic, either from the thoracic area. So, there are two areas sympathetic nerves are coming from: thorax and lumbar region. That is why we call it as a thoracolumbar out. Thoracolumbar out. So when you look at a thoracolumbar outflow, not lumbosacral, that is thoracolumbar outflow. Okay, thoracic are from the lumbar region, thoracolumbar outflow. Okay. Now, when you look at this cranial nerves, so cranial nerves which work as a parasympathetic nerves, the sympathetic nerves either arise from the spinal cord, either arise from the spinal cord itself, either arise from the thoracic region or from the lumbar region. Okay. Now, when you understand about thoracolumbar outflow, now let's understand the effects of the each of them. Let's understand effect on the eye. Effect on the eye. So sympathetic nervous system is active whenever, for example, you are running, when you go to fight, or for example, if I push you into a dark room. When you go into a dark room, the first basic requirement for light means, so you entered a dark room, you want to look around the object. If you want to look at an object, what is required? Light is required. So what your people will do? People will start to dilate. It will lead to mydriasis. So sympathetic nervous system will lead to mydriasis, and parasympathetic nervous system to meiosis. What is meiosis? Constriction of the pupil. The pupil is getting smaller. Mydriasis is a dilation of. How to remember? Mydriasis. The word is bigger, pupil is also getting bigger. So if pupil dilates, more light can enter into the eye. So better. That is the target of your nervous system. Do that. Okay. Now the next important aspect. This is about the eye. Let's go to the next important. What is that? Let's go to the oral cavity. So oral cavity, what exactly you need? Oral cavity, guys, you need to understand saliva. So when you are running, your mouth becomes first sympathetic is active, the salivation will be decreased. Okay. Now, if you notice here, I told you people about saliva. Saliva is decreased. The same way in the eye also there is one secret called as lacrimation. Lacrimation. So let's look at the lacrimation together. Okay. Now, when you want to call about lacrimation, lacrimation is nothing but what? Lacrimation is nothing but here. So lacrimation will be decreased. So if you notice here, with the sympathetic activity, all the secretions are decreased, but lacrimation will also be increased. Salivation will also be increased with parasympathetic. So whenever your sympathetic is active, secretions are decreased. Parasympathetic active secretions are increased. This is a way to remember. Now, if in these both cases, if lacrimation is decreased, it will lead to dry eye, that is only called as xerophthalmia, and it will lead to dry mouth, that is called as xerostomia. Xerostomia. Xerostomia means what? Dry mouth. Now, apart from that, let's go to the next important aspect. That is your respiratory system. Respiratory system. In the respiratory system, you need to look when you are running. What happens? Your respiratory rate will be increased. Okay, increase of the respiratory rate. So please listen to me very carefully. So you are running, your body needs more oxygen. If your body needs more oxygen, what your bronchus has to do? See, bronchus is a pipe, right? So this is a pipeline. If pipe dilates, pipe will become bigger. If pipe becomes dilated, what can happen? More air can enter. For that purpose only, your body will do what? Bronchodilation. 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 Okay. Now, when you're talking about parasympathetic, what? Rest and digest. When you're sleeping, suddenly sleep. Imagine in the can you sleep like this with a elevated respiration? No, you cannot sleep. So your respiratory rate has to go down because your body's oxygen requirement is less. So what will happen? Parasympathetic activation decrease the respiratory rate, and also it will also cause, if you elevate the parasympathetic activity, it can lead to severe also bronchoconstriction. So basically what I'm trying to tell you, during parasympathetic activation, bronchoconstriction is present. If you excessively activate a parasympathetic, severe bronchoconstriction. Clear? Very good. Let's go to the next task. What is that? Guys, you understood about the respiratory system. You understood about the oral cavity. Let's go to your cardiovascular system. In the cardiovascular system, look at a heart. Now, when you are running, your heart is more blood. Means if you are running, your body needs more blood. Your heart is pumping faster, which will lead to increase of the heart rate. Along with the increase of the heart, will also lead to increase of force of contract. Force of, because your heart is trying to pump more blood, more blood. So for that purpose, increase of the force of contraction. Now your heart is working more, right? If your heart is working more, very good question, very good. If your heart is working more, now what your heart will need? Heart is a cardiac muscle, made out of cardiac muscle. Now cardiac muscle, if it is working more, it requires more oxygen. Automatically, it will increase the O2 demand. O2 demand. So if you are running, if you are doing any physical activity, O2 demand of the heart will be increased. O2 demand of the increased. So if you look at a parasympathetic, it will decrease the heart rate, it will decrease the force of contraction, and it will also decrease the O2 demand. O2 demand. Okay. Now let's go to the next important test. What is that? That will be your sexual activity. Now, what about sexual activity? Two important things. One of them is your ejaculation, and one more thing is your erection. Hmm. Tell me now. Erection is under the influence of which nervous system? Erection and ejaculation. Erection is under which ejaculation under? Let's see. This is a very important question which can be asked, and you people should not make it. Sir, ejaculation occurs under the influence of. What about this erection? So, guys, ejaculation. Now, guys are thinking, oh, we need to answer carefully, right? Let's see. So, guys, ejaculation occurs under the influence of sympathetic nerve. Erection occurs under the influence of parasympathetic. Very good. Correct, Devan. Correct. So, erection and ejaculation. Now, many are thinking, okay, I will increase my parasympathetic nervous system activity. Okay. Now, let's go to the next important activity. What is that next important thing? Let's go to the GIT, gastrointestinal tract. Okay. Now, if you're talking about gastrointestinal tract, very easy for you to understand. What is that? In the GIT, guys, in the GIT, there is one thing called peristalsis. There is one thing called as motility. That is only peristalsis. There is one thing called as sphincter tone. Okay. Along with that, there is secretion. Three things. What are those? Motility, okay, sphincters. Okay. Now, then motility, sphincter, Then there is one more thing, secretion. What other? These other. Now, under the sympathetic activity, and under the parasympathetic, what will happen? Let's see. So, when you look at a GIT, in the GIT, so think about this, guys. Think about this very carefully. When you are running, if I give you biryani also, will you be able to swallow it properly? When you are running, no, you will not be able to swallow it. Why you will not be able to swallow it? Let's start here. Sphincters are closed. Sphincters are closed. If sphincters are closed, I eat the food, upper esophageal sphincter is closed, I ate the food will not pass through the GIT. So what can happen? Aspiration can happen. Means, so during running, sphincters are closed. Sphincters are closed. Okay. Motility. So if sphincters are closed, automatically food is not going inside. If food is not going inside, food movement will be there or not there? Food movement will not be there. Automatically it will be decrease of the motility. If you are not eating food and sphincters are closed, is there any point of doing a secretion? No. So secretion will be decreased. Simple. Now parasympathetic. So parasympathetic, what happens? In parasympathetic is a condition where you are resting happily, you can eat food and digest it. So automatically motility will be increased, sphincters are open, so you are able to swallow and you need to digest. So that is why what will happen? Increase of the secretion. That is why parasympathetic got its name, rest and digest nerve. Rest and digest nerve. Clear? Very good. Very good. Let's go to the next aspect. What is that next aspect? That is your urinary bladder. What is that? Urinary bladder. Now, when you're talking about urinary bladder, I understand balloon. What do I mean by balloon? So, look here. This is your urinary bladder. This is the neck of the urinary bladder. This is on the sphincter. Okay. Here you have a muscle. That is your detrusor. Okay. Now, easy to understand what exactly happens. Guys, when you're running, will you be able to urinate? Now, many people will be confused. I'll give a very easy way to understand. Now, whenever, if at all, guys can correlate this way. Okay, so imagine a situation where you walk near a toilet, but the toilet is having a big line of 1 kilometer. Big line of 1 kilometer. Okay. Now, guys who are standing in the end, okay, they'll be jumping. Why they'll be jumping? Because they're trying to activate their sympathetic nervous system. What happens during a sympathetic, guys? During a sympathetic nervous system activation, sphincter will be closed. Sphincter will be closed and muscle will be relaxed. Detrusor muscle relaxes, sphincter is closed. If sphincter is closed and muscle is relaxed, automatically what will happen? The urination will be decreased. So detrusor muscle will relax, okay, and sphincter will be closed. Sphincter will be closed. But the same thing when you imagine exactly in where? In a situation, in a parasympathetic, muscle will contract. Okay, sphincter will be open. Sphincter will be open. So muscle is contracting from the top, sphincter opening from vertically urination. So this is the story of your effects of the autonomic nervous system. Sir, why we need to know the effects of the autonomic nervous system? You will understand it now. But before going there, let's understand our basics. Guys, if you notice here, I started one nerve. Okay, the nerve ended here. Here I have a ganglia. Here I have a, okay. So this ganglion only I am going to call it as autonomic. Now, when you look at the autonomic ganglion, so whatever the nerve fiber which is present before your ganglion, we call it as a preganglionic fiber. Any nerve fiber after ganglion, we call it as a postganglion. Okay, so here also again preganglionic fiber and again postganglionic fiber. So remember this much: in the parasympathetic nervous system, preganglionic fibers are long and postganglionic fiber. Okay, so this is a very important thing. Okay, so according to some places you might apply the vice versa, but physiologically speaking or anatomically speaking, there are multiple types of sympathetic ganglion that might give you a little confusion. So I would recommend you people to remember this much: parasympathetic ganglion, preganglionic fibers are long, postganglion are short. Okay, so this is the story of your autonomic ganglion. Now, if you notice here, let's consider this nerve, this autonomic nerve is innervating your heart, is innervating your heart. Now, one nerve is ending here and another one is starting here. Between these two nerves, there should be a neurotransmitter. And again between the organ and organ the nerve, again there should be neurotransmitter. So anywhere in the autonomic nervous system at the level of ganglia, be it parasympathetic, we require what? Neurotransmitter. At the level of what is that? That is your organ, we require a neurotransmitter. So at the level of organ, which is after the ganglion, we call it as a postganglionic neurotransmission, and there is a before the ganglion. Here we call it as a preganglionic neurotransmission. Okay, that is a story. Now, when you need to understand about the neurotransmitters, so you have sympathetic nervous system, you have parasympathetic nervous system, you have a preganglionic neurotransmitter and a postganglionic neurotransmitter. Now, let's understand what happens. Now, preganglionic sympathetic neurotransmitter, my dear students, is your acetylcholine, and same thing with your parasympathetic. So, for both of them, you have sympathetic and parasympathetic. At the level of a ganglion, you have, which is that neurotransmitter acetylcholine, but sympathetic postganglionic neurotransmitter, usually your adrenaline, noradrenaline, and there is one more substance which can also work, that is your dopamine. All three of them are called together catecholamine, are called as catecholamine. But here in parasympathetic, the postganglionic neurotransmitter is also what? Acetylcholine. If you notice here, complete parasympathetic operates by acetylcholine. We call it as a cholinergic. That is why we call it as a cholinergic system, which is basically operated completely with the help of your acetylcholine. Here, now let's understand here postganglionic. Here there are some exceptions. Here there are some exceptions. So wherever we have an exception, there might be a confusion. Remember, there are few places where it is a sympathetic neuron, but neurotransmitter is not your adrenaline, noradrenaline, dopamine. Rather, it will be your exception places where it will be acetylcholine. In which places? Places like your sweat gland, places like your sweat gland, okay, places like your adrenal medulla. In these places what will happen? In these places acetylcholine will be the neurotransmitter. So if you understand here, there is one important aspect, that is exceptional case acetylcholine is the neurotransmitter in places like sweat gland, adrenal medulla in the also, right? So if there is a acetylcholine, see, if there is some chemical receptor has to be there, right? Let's study about the receptor. So wherever there is a acetylcholine is present, we require cholinereceptor, right? Listen to me very carefully. Acetylcholine act on which receptor? They are called as cholinereceptors. Okay, so these cholinereceptors are divided into two types. There is something called as M cholinereceptor. There is something called as N cholinereceptor. Okay, now M cholinereceptors are called as muscarinic receptors. Are called as muscarinic. N cholinereceptors are called as nicotinic receptor. Nicotinic receptor. Now, what do I mean by nicotinic receptor? Very easy. Guys, listen to me very carefully here. For example, I invite all of you to one party. I invite all of you to one. Now, what happens here is that in the party, so there is some 50 people. There are 50 people who is drinking alcohol. 50 people are drinking alcohol. 50 people are not drinking alcohol. Here, everybody, 50 people are drinking, for example, juice. 50 people are drinking alcohol. And all the 100 people are having one common. What is that? They all are having food. So the same way, these M cholinereceptors will be stimulated specifically by one chemical muscarine, like people who are drinking alcohol. These nicotinic receptor will be stimulated exclusively by nicotine. So the people who are drinking juice, but all the 100 people are eating what? Food. The same way acetylcholine will stimulate both of them, muscarinic receptor and the nicotinic. So when you need to understand about this, let's go to the next important aspect. What is that? Next important aspect. So muscarinic receptors are divided into one M2, M3, okay, M4 and M5. So what are the locations and what happens? So all these five muscarinic receptors, all of them are present in the central nervous. M4 and M5 present only in the central nervous system. So what do I mean by this? M1 to M5, all of them are in the CNS. M4 and M5 present only in CNS means M1, M2, M3, they are located somewhere also. What are the places? The places, M1 is located in the parietal cell. Parietal cells are located in the stomach. If you stimulate a M1 receptor, see M1 receptor is working through acetylcholine. If they are working through acetylcholine, automatically cholinergic system. What is the effect of cholinergic on the stomach? That is it will increase the acid production. Increase the acid production. Okay, M2 receptor, they are located on your heart. So what exactly happens here? In the heart, my dear students, in the heart, which receptor is located? M2 receptor is located. If I stimulate a M2 receptor, M2 receptor is working for the system parasympathetic. What is the parasympathetic effect on the heart? Decrease the heart. Okay, M3 receptor. Now remember, eyes also there is a effect of parasympathetic. Mouth there is a effect. There is a effect in the stomach. There is a effect in the bladder. There is a effect in all the places. So all other places. What are those others? Other places such as such as glands, such as smooth muscles, all of them there is your M3 receptor. Okay. Now M1, M2, M3 are. Now when you understand about M1, M2, M3, M1 is a parietal cell, M2 is located in the heart, M3 is located in the other places. Now nicotinic receptors. Nicotinic receptors are represented by N. By N. N for nicotinic receptor. N for nicotinic receptor, they are divided into two types. They are called as NN receptor. There is one more thing called as NM receptor. Now, NN receptors, guys, they are located in your autonomic ganglia. Autonomic ganglia. Autonomic ganglia, as soon as I say, so you need to understand autonomic ganglion is present both in the sympathetic and parasympathetic. Both sympathetic ganglion and parasympathetic ganglion will have your NN receptor. Now, let's go to the NM receptor. NM receptors are located in the neuromuscular junction. Neuromuscular. Okay, so this is the story of your what is that acetylcholine receptor, a cholinone. Okay, so if parasympathetic activity has to occur, all of the activity goes by this. Here, everybody, able to follow me, guys? Able to follow me? Let's see. Okay, so if at all we are looking at this receptor, let's go to the next aspect. What is that? The next aspect, guys, let's start with the first group of drugs. They are only called as cholinomimetics. Cholinomimetics. Cholinomimetics are also called as cholinergic agonists. Are also called as cholinergic agonists. Now, what are these cholinergic agonists? Guys, cholinergic agonists. Now, we need to understand one important aspect. These cholinergic are a group of cholinergic, very good. Cholinergic agonists are a group of which will increase the parasympathetic activity. In a basic terms, they will increase the parasympathetic activity. So how exactly they are going to work? What are the uses? What are the side effects? Let's go to them. Okay. So since we are doing a quick review here, I'll be giving you people very much important MCQ. Okay. So let's start with that. So all these cholinomimetics, to understand, let's start with a cholinergic. In a cholinergic neuron, look here, this is a cholinergic neuron. Inside a cholinergic neuron, guys, so this is a presynaptic neuron or a presynaptic membrane. We call it as a postsynaptic. Right? Whenever the nerve is stimulated, it will allow the entry of calcium. This calcium will cause the release of the acetylcholine. But I want you to understand this release of the acetylcholine. We call it as a exocytosis. Exocytosis. So this exocytosis occurs with the help of a protein called as snare proteins. What is that? Snare protein. Now, these snare proteins will help the acetylcholine. So, these snare proteins can be inhibited by your botulinum. Botulinum. So, botulinum toxin, what is the mechanism of action? They inhibit the snare protein, which will decrease the release of your acetylcholine. Here, everybody, continue. Now, this acetylcholine can act upon, for example, if there is a M cholinereceptor, M cholinereceptor. If there is a N cholinereceptor, N cholinereceptor. So, postsynaptic membrane can be an organ, postsynaptic membrane can be a neuron, postsynaptic membrane can be a muscle. All of them are possible. Now, look here, this acetylcholine is metabolized by an enzyme called as acetylcholine esterase. Acetylcholine esterase is an enzyme which will metabolize the acetylcholine into acetate plus choline, acetate plus choline. Okay. Now, this choline can be used again for the main fine. But I want you to understand this acetylcholine esterase is an enzyme which is present in the cell which is present in the acetylcholine. Okay. Now, let's start with the cholinomimetics. So, we have some drugs called as direct acting drugs. What is it? Direct acting drugs. There is one more drugs called as indirect acting. Indirect. Now, direct acting drugs and indirect acting. Look here. Direct acting. What are these? These direct acting drugs basically they are agonist. They are agonist. Agonist to what? Agonist to one of the most important agonist usually to M receptors. Usually to M receptor. What do I mean by agonist to M receptor? Means directly go bind with the M cholinergic and stimulate those. Okay. Now, indirect. What is the mechanism of action? Yes, this is a very important aspect. Mechanism of action. They will inhibit acetylcholine ester. So let's go back and see. If I block this enzyme acetylcholine ester, I have blocked which enzyme? Now what will happen? Automatically acetylcholine will not be. If it is not metabolized, acetylcholine quantity will be increased, right? So now more acetylcholine, more activation of all the receptors whichever possible. So what is that? Inhibition of acetylcholine esterase, increase acetylcholine, increase parasympathetic, right? So these are the indirect acting. Now, when you need to understand indirect acting, they will inhibit the acetylcholinesterase, which will lead to increase of the acetylcholine, which will increase the parasympathetic activity. Agreed. They will also stimulate the N receptor. Okay. Now, when you need to understand indirect activity, they are going to bind with the acetylcholinesterase. That is why they are also known as anticholinesterase. Now, anticholinesterase drugs, most of the people will get confused thinking that they are not anticholinergic, rather they are anticholinesterases. They are working as a cholinomimetics, my dear. Working as what? Cholinomimetics. Now, now, what are the direct acting drugs? Direct acting drugs, we have drugs such as carbachol. We have drugs such as carbachol. We have one more drug called as ethanacol. Ethanacol. Then we have one more drug. What is that one more? So we are talking about anticholinesterase. Anticholinesterases are which group of drugs? Cholinomimetics. Group of drugs, cholinomimetics. Now we have carbachol. Okay. Then apart from that, we have one more drug. That is your methacholine. That is your methacholine. Okay. Apart from that, we have one more drug called as pilocarpine. What is that? Pilocarpine. So these are the drugs. Or your what is that? Direct acting. And let's talk about indirect acting. Indirect acting drugs. We have drugs such as neostigmine. Neostigmine. We have a drug called as pyridostigmine. Pyridostigmine. Okay. Apart from pyridostigmine, we have one more drug. That is your physostigmine. Physostigmine. Okay. Okay. Apart from physostigmine, we have one more drug called as galantamine. Now, don't panic by looking at the names. I'll teach. Okay. Now, apart from galantamine, what else we have? Apart from galantamine, one more drug called as rivastigmine. Rivastigmine. Apart from rivastigmine, we have one more drug called as donepezil. Donepezil. Okay. Apart from that, there is one more drug called as. Now, please listen to me. Among all these drugs are very separate ones. Why I wrote them here? These are used for Alzheimer disease. Used for Alzheimer. But Alzheimer disease, the drug of choice is a very important question. What is the drug of choice? But drug of choice for it. The drug of choice for Alzheimer. The answer should be your donepezil. The donepezil. Now, donepezil is the drug of choice for Alzheimer disease. Then we have one more that is your tacrine. Your tacrine, but rivastigmine not used for the drug use is donepezil. Clear, everybody? Will you answer this question? Drug of choice for Alzheimer disease is your donepezil. Okay. Now, guys, let's understand the uses of this drug. So, uses of these drugs, I will put every use in one place. You will understand very easily. So, this is a very important one. What I am trying. The uses are very, very important. First and most important, post-operative urinary retention and ileus. What happens is that when we do a surgery, after surgery, person has to restore the bowel movement and person should be able to urinate. See, you did a surgery. After surgery, some people, what will happen? Urine will not come out. So, in which what happens is that parasympathetic activation is not there. So, if you focus and understand, if you stimulate parasympathetic contraction of the detrusor contracts, urine will come out. So, can I use this drug? Yes, cholinomimetic in the parasympathetic activity. So, contracting the urinary bladder, increase the urination. So, can I use it? Yes, I can use it in the urinary retention. And ileus means what is that? In which the intestine motility is not restored. Intestinal motility is not restored. This condition for both of these, the best drug I can use, you need to remember, that is your bethanacol. Bethanacol. Bethan. Now, how to remember bethanacol? Bowel and bladder. For bowel and bladder dysfunction after surgery, we are going to use what is the drug? Bethanacol. Okay. There is one more thing. That is your most important use. Alzheimer we already said. Okay. Apart from that, Sjogren's syndrome. What is it? Sjogren's syndrome. Now, Sjogren's syndrome is a very, very important asked frequently, and you need to understand. For Sjogren's syndrome, the patient will have a dry mouth. Okay, there is a dry mouth. Okay, mouth has gotten dry. If mouth is dry, what will happen? Why this mouth will dry? Because Sjogren's disease is an autoimmune disorder. Autoimmune disorder in which there are two antibodies can be anti-Rho antibody and anti-Law antibody. Okay. Now, these condition, what happens is that all the glands undergo fibrosis. Now, salivary gland undergo fibrosis, salivation will. If parasympathetic is activated, what will happen? Salivation will be increased. So, for Sjogren's syndrome, dry mouth treatment, use a drug called as Sevamylin. What is it? Sevamylin. Is it? Sevamylin. Remember. Okay. Apart from Sjogren's syndrome, my dear students, we can use them, that is in the myasthenia gravis. Is it? Myasthenia gravis. Now, what is this myasthenia gravis? The best drug is pyridostigmine. The best drug is pyridostigmine. Now, why pyridostigmine? Because pyridostigmine, no crossing of the blood-brain barrier. If it will not cross the blood-brain barrier, what happens here? See, when I use a anticholinesterase drug, it will increase the acetylcholine. If acetylcholine increase, it will stimulate the NM receptor. In the myasthenia gravis, what happens is that destruction of NM receptor. If NM receptors are destroyed, the treatment will be, what is that? Increase acetylcholine. If you increase acetylcholine, increase stimulation of your NM receptor. So that is the reason. So in myasthenia gravis, pyridostigmine is a better drug because see, all the muscles are located in one thing. Apart from that, the one more thing, the reason is long acting. So for this reason only, we are going to use pyridostigmine. Pyridostigmine drug. Hope everybody able to understand. Now, apart from myasthenia gravis, where else we can? Apart from myasthenia gravis, there are some other uses. You need to know them. These drugs, especially pilocarpine, used in the glaucoma patient. Now, glaucoma treatment is a different strategy, but can use agreed. Okay, so these are the very important uses. So myasthenia gravis, Alzheimer, myasthenia gravis, Sjogren's syndrome. Apart from that, you need to remember post-operative urinary retention and IBS. The last and most important possible, there is something called as methacholine challenge test. Okay, now I want you people to answer me. Methacholine challenge test used in the diagnosis. Tell me, guys. Let's see. I'm looking for your comments. Methacholine challenge test is used for what is that? That is which disease diagnosis? Tell me. So Kiran Gopal says asthma and others says nothing. Come on, guys, give me an answer. Myasthenia. Okay. Any other answers? So the correct answer is used in the bronchial asthma diagnosis. Bronchial asthma diagnosis. Disorder, bronchial asthma diagnosis. Here, everybody. So this is the most important aspect. Methacholine challenge. There is one more diagnostic method, that is your tensilon test. Tensilon test. So tensilon test we use a short acting anticholinist. Anticholinesterase. So this short acting anticholinesterase, which is that short acting anticholinesterase, that is your edrophone. Edrophone. Okay. You use a edrophonium. So there are only two possible. So what is that? The patient influence test is used for which disorder? First thing, myasthenia gravis. Now in the myasthenia gravis patient come to you complaints of weakness, complaints of drooping of eye, etc. Now after giving edrophonium, symptoms improve. Symptoms symptoms improve. If symptoms improve, we call it as positive positive penicillin test or a positive. If there is a negative, means no improvement of the. Now if there is no improvement of the symptom, that is negative. If there is a positive, that is a diagnosis of myasthenia. Now what is this? No improvement. There is no improvement. We are trying. That is usually cholinergic. Usually the diagnosis cholinergic. Now apart from cholinergic crisis, it can also be some other disorders, such as for example Lambert-Eaton. There will be hydrophonium. Okay? So this is the story of your and cholinergic. Once we understood about the cholinergic, let's go to the next important ones. They're called as anticholinergic. Anticholinergic. So what is this anticholinergic? So at the end of anticholinergics, I'll teach you people about that. That is your combination of neostigma for the snake bite and OP. Okay? Now, anticholinergic. When you're learning about anticholinergic, guys, anticholinergics are also called as cholinergic antagonist. Cholinergic. Now, this cholinergic antagonist, my dear student, they will do what? They are going to block the parasympathetic. They are going to block the parasympathetic. So, if they are blocking the parasympathetic, Let's see. So when they're blocking the parasympathetic activity, let's start with one organ in the central nervous system. In the central nervous system, if you block M receptor, if you block M receptors, what will happen? So if you block that will be done with the help of a drug called as your hyoscine. 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 Now, hyoscine is also called as scopolamine. Scopolamine. Now, scopolamine is used for the treatment of what is a disorder? Can anybody tell me? Scopolamine, where do we use? Scopolamine is used. Please tell me. Scopolamine is used for the treatment of motion sickness. Motion sickness. Motion. Now, actually, exactly in the form of a transdermal patch. In the form of a transdermal patch. And for example, you are talking about motion when person is going, for example, what is that? For example, some forest area, trip or something. Now, when do we apply this patch? Is it before starting of the trip or after the symptoms? So this should be very important. Before start of the symptoms. Before start of the before even symptoms will get started, apply. That is your scopolamine. Okay. Then apart from that, central nervous system. Let's come to the next place. What is that? Eye. In the eye, my dear student, what will happen? What happens is that they will block the M receptor, especially M3 receptor. If M3 receptors are blocked in the eye, that will lead to what? I told you people, parasympathetic nervous system, contraction of the pupil, meiosis. Now, if I block it, mydriasis. So, it will lead to mydriasis. Okay? Now, mydriasis will occur, but along with that, that will also lead to cycloplasia. Cycloplasia. What is cycloplasia? It is a paralysis of the muscle. Paralysis of the ciliary. Okay. Now, mydriatics used in the eye. What are those drugs? Now, listen to me very carefully, guys. It's very easy for you to understand. We have atropine. We have atropine. We have homatropine. We have homatropine. Okay. We have one more drug, cyclopentolate. Cyclopentolate. Okay. There is one more drug called as tropicum. Now, what are the MCQs from here? Now, very easy to understand. Atropine is a long acting. Atropine is a long acting. And tropicamide is a short acting. A short acting. So, since it is a short acting drug, it can be used in adults. It can be used in adults. So, for what? For the purpose of fundus. For example, if you want to check retina. For example, if you want to measure the so you can use for the examination of the eye. You are going to use which drug? That is your tropicamide is used in the adults. In the children, atropine is used. In the children, atropine is used. Can anybody tell me why atropine is used in the children? Because strong ciliary muscle. Strong ciliary. In the children, there is a very strong ciliary muscle. You need to give a very powerful agent. That powerful agent, my dear student, atropine. That is why the long acting the eye. You give atropine in the children, but tropicamide is used in the adult because weaker ciliary muscle in children. And most importantly, we need the duration. Short period of time is used in the adults. Why? Because it is a short action. It is a short action. Okay, so you need to focus here. Mydriasis with cycloplasia means whenever you use anticholinergic drug, blocker, automatically cause a cycle. Let's go to the next aspect. What is that? In the respiratory tract. The respiratory. When you look at a respiratory, guys, if you block a M3 receptor, it will lead to bronchodilation. Bronchodilation. Why bronchodilation? Very easy. Sympathetic bronchoconstriction that used to happen with the help of M3. That used to happen with the help of M3. Now what I did, I blocked that M3 automatic bronchodilation. So they're used for COPD. Used for COPD. And if they're used for the COPD, now what other drugs we have? That is your ipratropium. Ipratropium. and thiotropium. Thiotropium. Now, ipratropium and thiotropium. Most important question. Well, so there are two drugs. Now, among these two drugs, which is a long acting? Remember, the long acting drug is the thiotropium. Long acting drug is thiotropium. Now, sir, if I'm using a drug in COPD, can I use it in the asthma? Of course, COPD and but most importantly, I want your attention to be paid. For the COPD, the best drugs usually used are your MT blockers, ipratropium and thiotropium. Long acting. COPD is chronic obstructive pulmonary disease caused by. Clear, everybody? Okay. Now, apart from that, let's go to the next important. That is your heart. Now, in the heart, my dear students, we have M3 receptor. If I stimulate a M3 receptor, what will happen? It will decrease the heart rate, which already. If I block a M3 receptor, it will increase it. So, if a patient having use, where it will use? It is increasing the heart rate. Use is what? Used for bradycardia. Used for bradycardia. Apart from bradycardia, it is also used for AV block. AV block. What is the drug on the heart? The drug is your tropin. So, in the heart, there is one small change. Make it in the heart, we have M2 receptor. Now, M2 receptor, we are talking about atropine. We are talking about atropine. If you look here, on M2 also there is action by atropine. One also there is, M3 also there is. So, atropine has all the. Okay. So, heart, M2 receptor. Okay. Now, the next important. Let's go to your parietal cell. Parietal cell, which has a M1 receptor. If you stimulate a M1 receptor, increase the acid. Very good. If you block a M1 receptor, it will decrease the acid. That's it. Simple as that. If it is decreasing the acid, it can be used in peptic ulcer. But do we use it in? We don't. Why? Because we have a superior drug. So, if they are used in peptic ulcer disease, M1 blockers. These M1 blockers, the drugs are your piranzapine, and there is one more drug called as tilenzapine. Got it, everybody? Here. So, this is the most important aspect. Tilenzapine. Now, there is other ones. M3 blockers on the GIT. If you block the M3 receptors on the GIT, we have a drug called as dicyclomine. What is that? Dicyclomine. Okay. There is one more drug, clidinium. Is that clidinium? These two drugs are M3 blockers in the GIT. Basically, they are used for spastic. Okay, so among these, I want you to remember some of the most important aspects. What is the best drug used for a AV block? They're going to ask you, you need to mark it as best drug, not the best. Okay, okay. For AV block, best treatment is pacemaker. Best treatment is pacemaker. So, best treatment is your pacemaker, best drug is your. Okay, now M3 blocker. M3 blockers in the GAT. Let's go to the next aspect. What is that? Let's go to the next important location. That is a urinary bladder. So, urinary bladder, guys, please listen to me very carefully. Confusing aspect. Consider this is your bladder. In the bladder, which receptors are there? M3. So, if I stimulate a M3 receptor, bladder will contract. Bladder will. If bladder contracts, urine will come out. This much. If I have a patient with hyperactive, hyperactive bladder means urination. For that patient, what I have to do? I need to block this M3 receptor. So exactly in the urinary bladder, where do we? A patient who is having which disorder? Hyperactive bladder. Hyperactive bladder. Now for the hyperactive bladder, we have drugs such as oxybutyn, 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 Apart from oxy, we have one more drug called as dorifenas. Okay, we have one more drug, dorifenas. We have one more drug called as solefenas. There is one more drug called as prospe. Now, if I want to tell people to remember two drugs actually. What are the two drugs? Dorifenas and your oxybutyn. These two. Now, there is one more drug, solifenas, voltarate. Okay, among this. Now, the question is like this: which of the following drug not used for hyperactive? Option A, oxybutyn. Option B, imipramine. Option C, dabagrone. Option D, nortrip. Tell me guys. Waiting. Now I want to teach you people a very interesting new concept. Okay, so for that purpose only, I want to I want you people to answer this question. Okay, tell me the answer. So somebody says D and somebody says imipramine. I am asking which of the following is not used. Very careful. Which of the following not used? Okay, tell me. Let's see. Take a guess. Now, if you don't know the answer, A, B, C, D, anything you can answer. But I want you people to answer. Just give me an answer. Yeah. Only two people is guessing. What is that? D and imipramine. C. Okay. Any other answers? So please remember which of the following drug not used is nortriptyline. Which of the following not used is nortriptyline. Nortriptyline is not used. Imipramine is a tricyclic antidepressant used in hyperactive bladder. It is a beta 3 adrenergic drug. Beta 3 acting drug, it is also used. Okay, this is a M3 drug, M3 blocker, also used. So remember, though it is, this is one important aspect, imipramine is a tricyclic but still used for what is that? Hyperactive bladder. But nortriptyline, though it is what, it is a tricyclic antibiotic, but which is not used. I want you to, can you remember this much? So, what are the drugs we use for hyperactive bladder? Repeat with me: oxybutyn, tolterodine, solifenacin, dorifenacin, trospium. All these come under one group. M3 blockers used for hyperactive bladder. Then tricyclic antidepressant used is imipramine. Then there is beta 3 adrenergic drug, that is your mirabegron. These are the three drugs which are widely used for your, what is that? Hyperactive bladder. Here, this is a story of your hyperactive bladder and your cholinergic antagonist. So, cholinergic antagonists, these are the most. So, once you understood about this cholinergic antagonist, then we will be shifting towards your adrenergic. What is that? Adrenergic. So, before starting adrenergic, so we need to understand important aspect. That important aspect of what is that about the adreno. Right? So adrenergic drugs, to understand that, let's start with a very important basic, that is your adrenergic. Now listen to me. We have one amino acid called as tyrosine. Now this fellow tyrosine will get converted into dopamine. Now from dopamine, what will be released? That will be your noradrenaline. And from noradrenaline, what can be formed? Adrenaline. Okay. Now, whenever I stimulate this neuron, what will happen? Adrenaline, noradrenaline is now they will go and stimulate the postsynaptic membrane, alpha and beta alpha. Okay. So, adrenergic receptor, complete your adrenergic system works with the alpha. And now, you people will have it. So, what is it? That is your sympathetic system. So, let's start with the adrenoreceptor. Basic concept is your adrenoreceptor. Now, when you want to understand about the adrenoreceptor, see, guys, this is a quick review. So, I'm not going into much details of adrenergic neuron. Rather, we are going into most important. Okay. Now, let's start with the adreno. Now, when we're talking about adrenoreceptor, we have something called as alpha adreno. Called as alpha adreno. Now, when you're talking about alpha receptor, this alpha receptor can be subdivided into alpha 1 receptor. There is alpha 2. Now, let's start with the alpha 1 receptor. Now, when you need to understand about the alpha 1 receptor is further divided into alpha 1A, alpha 1B. Okay. There is one more thing called as alpha 1D, but which is less important for you people. Remember this much: is alpha 1A and alpha 1B. Okay. Now, alpha 1A and here they are. Alpha 1B is located in the blood, and alpha 1A is located in the urinary blood. Alpha 2 receptor. Now, alpha 2 receptor is located in the presynaptic presynaptic. Now, in presynaptic membrane, what do I mean by this? Look here. Where exactly we have which receptor? Here, the alpha. Now, when you're talking about the alpha 2 receptor, so this is a postsynaptic, presynaptic. Now, alpha 2 is which type of receptor? Presynaptic. If I'm telling you a presynaptic receptor, every time adrenaline is released, this adrenaline can go and stimulate which receptor? Alpha 2. Once alpha 2 receptor is stimulated, what it will do? It will decrease the release of neurotransmitter. It is more like a negative feedback mechanism. More like a negative feedback mechanism. What happens is that the release of the neurotransmitter will decrease as a result of the presynaptic alpha 2 receptor. Okay. Now, there is one more. Alpha 2 receptor also located on the blood vessel. Okay. So, let's understand all of this. Now, whenever sympathetic activation is there, alpha 1 and alpha 2 receptors get stimulated. What are they? When alpha 1 gets stimulated, my dear student, alpha 1 stimulation will lead to urinary bladder sphincter contraction. Urinary bladder sphincter contraction. What do I mean by this? Stimulate a sympathetic nervous sphincter will be closed. Exactly how exactly you are getting it? As a result of alpha 1. Then there is one more thing. What is that one more? In the blood vessel, there is a vasoconstriction. There is a vasoconstriction. So automatically it lead to increase of the BP. Lead to increase of the BP. Now, alpha 2 receptor on the blood vessel, again they will also increase the BP. But you need to understand there is presynaptic receptor. Presynaptic receptor will decrease the release of the adrenaline, noradrenaline. Less adrenaline, noradrenaline. Decrease of the sympathetic activity. If there is a decrease of the sympathetic activity, automatically there will be decrease of the blood pressure. So if we stimulate alpha 2 receptor at which level? At a neuron level, there will be what? There will be decrease of the BP. Okay, let's go to the next type of receptor. That is your beta adreno. Beta adrenoreceptors are divided into what? Beta adrenoreceptors are divided into beta 1, there is beta 2, and there is beta 3 receptors. So what are the three types? Beta 1, beta 2, beta 3. Now beta 1 receptors are located in your heart. Beta 1 are located in your heart. Apart from the heart, beta 1 also located in the kidney. Beta 1 also located in the kidney. Now the next important beta 2 receptor. Beta 2 receptors are located in the bronchus, blood vessel and your uterus. And beta 3 receptors major location is adipose tissue. Apart from that, there is a evidence suggests that there is your bladder, that is why beta 3 drugs are used for the hyperactive bladder. Now, once you know this much, guys, beta 1, beta 2, beta 3 receptors, now we need to understand the adrenergic agonist. So, when we need to understand about the adrenergic agonists are a group of drugs. What they will do? They will increase the activity of sympathetic nervous. If sympathetic nervous system is activated, what will they do? They will lead to sympathetic activation. If there is a sympathetic activation, there will be excessive sympathetic activity, means heart rate will increase. Okay, there is a respiratory rate increase. There is a bronchodilation. So we are going to use them as a therapeutic purposes, right? So when you need to understand about these drugs, so let's learn about this important aspect. What is that important aspect, guys? This is very easy for you to understand. So before going even to the drugs, all these adrenoreceptors can be stimulated by adrenaline. They can be stimulated by noradrenaline. Now let's understand the effect of adrenaline, noradrenaline first. Then we'll go to the other. Adrenaline will stimulate alpha 1, alpha 2, beta 1, beta 2. Okay. Now noradrenaline will stimulate alpha 1, alpha 2 and beta 1. No action on the beta 2 receptor. This is a very important aspect to remember, right? So if we need to understand this, this is about adrenaline, noradrenaline. Okay. Sir, why you are telling all this? Let's put all this into one important place, that is only your vasomotor phenomenon. Vasomotor phenomenon of sales. What is this vasomotor phenomenon? So please understand this. Normally what happens, and that's 100% will be present. High likely, that much important. Okay. Now what do I mean by this? Vasomotor phenomenon. To understand that, if we stimulate beta 2 on the blood vessel, so most of you people are thinking now, what exactly I'm the effect I'm talking only and only where exactly on the blood vessel, my dear. Where exactly on the blood vessel. So on the blood vessel, if beta 2 is stimulated, it will cause vasodilation. Vasodilation. Okay. Now, in the blood vessel, if alpha 1 is stimulated, it will lead to vasoconstriction. Now, there is a contradictory information. Why, sir? Look here. Adrenaline will stimulate alpha 1 also and beta 2 also. So, one is increasing the BP, one is decreasing the BP. So, this complication is solved by this scientist Dales. He gave us one clear-cut explanation. That explanation in on the blood vessel. This occurs exclusively on the blood vessels. So, in the blood vessel, adrenaline at a high concentration, will activate alpha 1 receptor, lead to increase of the BP. Okay. Adrenaline at a low concentration will stimulate beta 2 receptor. Beta 2 receptor will cause vasodilation, which will lead to decrease of the blood pressure, which will lead to decrease of the blood pressure. So adrenaline at high concentration, alpha 1 increase BP, at low concentration beta 2 decrease. Okay. So exactly what happens if adrenaline injected, what will happen? Initially this was the flat line of BP. Initially BP will be raised, later BP will come back to the normal and BP will fall down, and this is the story. So in this stage where there is alpha effect and here there is a beta 2 effect, this is only a vasomotor phenomenon of sales. But what is the MCQ? If adrenaline is given, if adrenaline is given in presence of a alpha block, okay, if there is a presence of a alpha blocker, what is going to happen? So if there is a blockade of the alpha receptor. Now if blockage of the alpha receptor, what is going to happen? Automatically your adrenaline will act on your Beta 2 adrenaline act on your beta 2 receptor. If adrenaline act on the beta 2, automatically it will lead to decrease of the BP. This is a very important question. If adrenaline is given in the presence of alpha blocker, the end summary is the decrease of the BP. This is a very important MCQ which has been asked. So please remember, adrenaline given in the presence of alpha blocker, BP will fall. BP will fall. Clear? Now, this can even be noticed evidently in one more place called as pheochromocytoma. We will come to that later. Now, let's go to the next aspect. What is that next aspect? Guys, so if adrenergic drugs are there, let's talk about first important drug I want to talk about is your adrenaline. What is that? Your adrenaline. Now, adrenaline, what are the uses of the adrenaline? So, adrenaline directly to go to alpha receptor. If alpha receptors are directly stimulated, what will happen? If beta receptors are directly stimulated, what will happen? So, for that purpose, let's go back and learn about the effects of each receptor. Right? In the alpha, we studied, but in the beta, look here, in the heart, if beta 1 is stimulated, it will increase the heart rate, it will increase the force of contraction, and it will also increase the O2 required to demand, as we discussed autonomic nervous. In the kidney, if beta receptors are activated, especially beta 1 is activated, that will stimulate your RAS system. That will stimulate your RAS system. Here, now, in the bronchus, it will cause bronchodilation. Okay. In the blood vessel, it will cause vasodilation. In the uterus, it will cause uterine relaxation. These are the effects. So, effects of the beta receptors in the body. So, let's go back here. When we are talking about adrenaline, adrenaline is used for your anaphylactic shock. Now, in the anaphylactic shock, the pathology is increase of histamine. There is an increase of histamine. This increased histamine will lead to bronchoconstriction and vasodilation. So, dilation. Okay. So, these are the two problems. Now, how can we treat it? Exactly opposite treatment. What are the opposite treatment? Opposite treatment is very simple. The patient is having anaphylactic shock. The problem is bronchoconstriction and vasodilation. If you give adrenaline, automatically exactly opposite effect will be yielded. That is the use of your anaphylactic shock. That is your adrenaline. Now, adrenaline, there is having one more use. But it can also be used in cardiac arrest. Cardiac arrest. Okay. It can also be combined with the local anesthetic. But this effect will be dose dependent. And what are the doses we will learn about. So we were talking about adrenaline. When we were talking about adrenaline is a drug which is not just a drug but also present in the human body. Now, when we need to understand, we have to understand about adrenaline, right? So we have something called as anaphylactic shock. We have something called as cardiac arrest, and it is also used with a local anesthetic. Remember, combined with local anesthetic. Why do we combine with a local anesthetic? The MCQ will be asked, why do you combine? Because adrenaline will prolong the action, prolong the duration of action of what? Of your local anesthetic, right? So we have three different uses. So automatically the question will be, what are the three different dilutions or three different dose dependent actions? So we need to understand. Guys, listen to me very carefully. Now, this adrenaline can be diluted into 1:100. So when it is diluted as 1:100, where do we use it? Earlier I haven't mentioned it. So where exactly we are going to use it? For the bronchial asthma. Right? So in the bronchial asthma, we are going to use it. Okay. Now listen to me. In bronchial asthma, the dilution is 1:100. Now for example, 1:1000. 1:1000. Where do we use it? We use 1:1000 in which disease? In the anaphylactic shock. Where do we use it? Anaphylactic shock. Right? Now, apart from that, there is one more thing, that is 1 is to, that is your most important thing, that is 1 is to 10,000. 1 is to 10,000. We have one dilution. Okay. Then apart from that, 1 is to 10,000, and there is one more thing, that is 1 is to 1 lakh. That 1 lakh might vary. 1 is to 1 lakh, let's keep here. Okay. Now 1 is to 1 lakh, let's keep here. But the important aspect is what? 1 is to 1 lakh, this dose will vary. So this dose, where do we use it? This is used for the local anesthetic combination. Okay. Now when we are looking at a 1 is to 10,000 combination, 1 is to 10,000 is used for the cardiac arrest. Cardiac arrest. If you notice here, you can remember it like this. Inhalation 1 is to 100. Okay. For example, anaphylactic shock 1 is to 1000, where we are using, what is that? Intramuscularly. How do we use it? Intramuscular. And 1 is to 10,000 for the cardiac arrest, usually used IV route of administration. And there is one more thing. What is that? That is your 1 is to 1 lakh, that is used for the combination with the local anesthetic. Alright. Is there any break of voice still? Guys, respond. All right. Let's continue. So we understood about adrenaline. Okay, we understood about the dosage forms. Okay, that the dose, not even exactly dosage form, let's speaking, specifically speaking, dosage dilution. Okay, then let's go to the next aspect. Now adrenaline is such a drug, we understood about it. Let's go to the next important, that is your noradrenaline. What is it? Noradrenaline. Now when you're talking about noradrenaline, has no effect on the beta 2 receptor, has no effect on which receptor? On the beta 2 receptor. When there is no effect on the beta 2 receptor, so you need to remember noradrenaline, no significant change, no significant change of, heart rate. You need to remember this. Though we are talking about noradrenaline, so though it is nothing related to beta 1 receptor, but though it is beta 2 related action, but still the end summary will be, what is that? No significant change of the heart rate. All right. So if there is no significant change of the heart rate, how this works? This works like this. For example, adrenaline. What happens? It is a type of potent, a very strong vasoconstrictor. So it is a potent vasoconstrictor. Now this potent vasoconstrictor will activate alpha 1 receptor, will lead to increase of the BP. If there is an increase of the BP, it will stimulate one receptor called as baroreceptor. It will stimulate something called as baroreceptor. If it will stimulate a baroreceptor, what will happen is that it will stimulate in turn vagus nerve. The end summary is vagus nerve. If vagus nerve is activated, it will try to decrease the heart rate. All right. But noradrenaline, what is that? Noradrenaline will stimulate which receptor? Beta 1 receptor. What is the effect of beta 1 receptor? To increase the heart rate. So if you notice here, the significant change will be there. One is trying to increase, one is trying to decrease. The end summary will remain as a no significant change of the heart rate. That is why noradrenaline, no significant change of the heart rate, but noradrenaline only and only acts upon what? Increasing the BP. If it is increasing the BP, this drug will be used only and only for one condition called as shock. Now, as soon as I call it shock, shock doesn't mean mental shock. So don't confuse. Throughout medical field, you need to remember shock means what? Shock means low blood pressure. So low blood pressure, we need to elevate the blood pressure. For that purpose, we can use noradrenaline. So if they haven't mentioned the type of the shock, then you are going to proceed to what is that? That is your, what is that? That is your noradrenaline.
So guys, let's discuss inner details of other topics today, and along with that, now please pay attention to this particular thing what I'm telling you. So throughout the discussion, I will be telling you people some points as the repeated questions which are asked. So I want you to note those questions because those are very important and they will be asked again and again, because see, you need to understand the trend of the exam before even starting the topic. Please understand the trend of any exam. Good evening everybody. So the trend is like this. Now, when you look at a trend of any exam, now we need to understand what are the frequently asked questions and frequently asked topics. That's your first thing to be paid attention on. Second thing, what are the clinically important aspects from any given topic? If you know these two things, you can master a subject. So that is very important, right? So many people are thinking, sir, everybody will tell this idea, but nobody will tell us what to do, right? So again, once again, good evening everyone. Now listen to me. I'll tell you one basic idea. So many people would be telling you, study these 4 pages, study these 4 lines, study this particular page of the sentences. Okay. So please don't go for that. Please don't go for that. I would tell you people to understand what is that. That is, whenever we tell you this particular mechanism is important, whenever I tell you this particular thing can be applied in other subject, that is the point where you need to catch on. Okay, but if you leave that particular point, then go and remember other things that will be of useless, right? So that is the first thing. Second thing, how you can remember complete pharmacology. So how to remember pharmacology? The technique is very, very simple. What is that? Don't remember the names of the drugs in the first itself. So put the names of the drugs for the ending of the discussion. Okay, what you need to do first. Okay, if I tell you a group of drugs, so what you need to do? Definition. Then how do they work in the body? Okay, then the next thing, what is that? What is the use of the drug? Then if you go and remember the names, then it will be very easy. Okay, so let's start, right? So yesterday we were talking about adrenaline and as well as noradrenaline, right? So simple as that, adrenaline has a beta 2 effect also, noradrenaline has no beta 2 effect. Based on this, there is one clinical importance which will be applied, I told you people, that is on the vasomotor phenomenon of Dales. Now in vasomotor phenomenon of Dales, the question will be like this for you people. A patient was given a adrenaline in the presence of a alpha blocker. What will happen to the blood pressure? This is a standard MCQ. Blood pressure will be decreased. Blood pressure will be decreased, right? So with that much being said, let's go to the next important aspect. What is that? There is one drug called as isoproterenol. What is that? Isoproterenol. Isoproterenol. Now, isoproterenol, what is this drug? This is a type of drug which is having only beta 1 and beta 2 agonist property. Beta 1 and beta 2 agonist property. So these are the three things which you need to understand: catecholamines and catechol derivatives, adrenaline, noradrenaline and isoproterenol. These three drugs, what are those three drugs? Adrenaline, noradrenaline and isoproterenol. Now among these three drugs, as I have told you people, you need to remember isoproterenol is a non-selective beta agonist because it is stimulating both beta 1 and beta 2 receptor. Got it? Got it? Okay. Now, nowadays we don't use this drug, but usually earlier time it was used. It was used for treatment of bradycardia. Treatment of what? Bradycardia. Okay. Now, this is a story of your adrenaline, noradrenaline and isoproterenol, but this is not the major focus here. The major focus will go to you people with specific drugs. So, let's learn them, right? Now, when we need to understand that, very, very simple and very, very basic. What is that? That is your first thing. Alpha agonist. What is that? Alpha agonist. Now, my dear brilliant students, alpha agonist, you people will tell me alpha agonist. So, before going there, you people should tell me alpha 1 and alpha 2 locations. Alpha 1 receptor located in the blood vessel. Very good. Very good. Alpha 1 receptors are located in the blood vessel. If you stimulate alpha 1, they will cause vasoconstriction. They will cause vasoconstriction leading to increase of the BP if systemically applied. Right? Okay. Now, gestational diabetes. So let me, Dr. Hussain, let me clarify this. For the gestational diabetes, metformin is not used. The only best drug for the gestational diabetes is insulin. Clear? Now, listen to me guys. So, it will cause vasoconstriction and increase BP, but understand alpha 1 agonist, understand what and all we can get the effect. There are other effects also. What are the other effects? One of them, they will cause nasal decongestion. What is that? Nasal decongestion. Nasal decongestion. Along with the nasal decongestion, my dear students, they are mydriatic agents. What are those? They are mydriatic agents. What is that? Mydriatic agents. Okay. Now, these mydriatic agents, what are these mydriatic agents? So, they will cause dilation of the pupil, but without cycloplasia. What is that? Without cycloplasia. Now, cycloplasia, I told you people yesterday. What is cycloplasia, my dear students? Paralysis of the ciliary muscle. Very good. Now, whenever I use these drugs, they will cause mydriasis. But if you notice, without cycloplasia, so they will cause the dilation of the pupil, but there is no paralysis of the smooth muscle, so paralysis of the ciliary muscle. So the question will be like this: which drugs will cause mydriasis without cycloplasia? Let's pay attention again. Without cycloplasia, they are your alpha 1 agonist. So what are the drugs we have? Understand, we have a drug called as phenylephrine. What is that? Phenylephrine. What is that? Phenylephrine. Phenylephrine causes mydriasis without cycloplasia. Now, please understand nasal decongestion. Nasal decongestants, we have drugs such as oxymetazoline. There is one more drug called as xylometazoline and oxymetazoline. Metazoline drugs are your nasal decongestants, and phenylephrine is your, what is that, my dear students? That is your mydriatic agent without cycloplasia. Phenylephrine, some cases, earlier times, there was a tablets which were used to be available for the nasal decongestion itself. Okay. Now, please understand, the MCQ will be like this. So, mydriasis without cycloplasia, the answer is phenylephrine. Question number 1. The second one, mydriasis with cycloplasia, then that will be your anticholinergic drugs. Among those, for children, atropine. For adults, what is the name of the drug? That is your tropicamide. These are the 3 important MCQs which you need to remember. Clear, everybody? Very good. Atropine is used, but other drugs also there, right? Now, let's continue. Alpha 1 agonist, we understood about this. Now, alpha 1 agonist, guys, once we know about this, let's go to the next important aspect. What is this? Guys, this is the one of the most important aspect, that is your alpha 2 agonist. Now, when I want to teach you people about alpha 2 agonist, please listen to me. Alpha 2 receptor, if I stimulate this alpha 2 receptor, what it will do? It will decrease the release of your adrenaline, noradrenaline, that is basically neurotransmitters. If they were decreasing the release of the neurotransmitter, they will decrease the sympathetic activity. That means they will decrease the blood pressure. They'll decrease the blood pressure. If they're decreasing the blood pressure, they can be use of the alpha 2 agonist. The use of the alpha 2 agonist, you people will tell me. So if blood pressure is decreasing, where do we use? Please tell me. Let's see. Let me look at the comments. So, of course, the use will be wherever if something is decreasing the BP, of course, it is used in the treatment of hypertension. Very good. That is in the hypertension treatment. Now, guys, please understand here. What is that? If they're used for hypertension, what are the drugs? So, there are 2 drugs. What are those? There is a drug called as clonidine. There is one more drug called as alpha methyl dopa. So there are 2 drugs, alpha methyl dopa and clonidine. Now among these 2 drugs, if I have to pick one drug for the pregnant female, see, for pregnant female, if she gets a hypertension, the drug of choice is labetalol. Okay, the drug of choice is labetalol. I'm not going to confuse you people. Drug of choice is labetalol. But apart from labetalol, alpha methyl dopa is also safe in pregnancy. So which means you can use alpha methyl dopa in a female with a pregnant female with a hypertension. That is the story of your alpha 2 agonist. This is an important aspect. So apart from that, my dear students, you need to understand these 2 drugs you understood. Okay. Now, apart from this aspect, these drugs also used in the glaucoma. What is that? Glaucoma. Okay. Drugs such as brimonidine. Okay. So, brimonidine is a drug which is an alpha 2 agonist. See, if you can understand here, alpha receptors are present in the presynaptic membrane of the neuron, blood vessel, as well as other locations. That is in which particular areas? In the particular areas such as there are some centers of the brain which is responsible for the addiction. Even there also clonidine is used. That is an in-depth aspect to it, but the most important exam-oriented aspect, alpha methyl dopa brimonidine is used in the treatment of glaucoma. This is the story of your, what is that? Very good, alpha 2 agonist. So once alpha 2 are done, what is left out? Of course, beta are left out. So beta is very interesting. Okay, so beta is acting upon the heart. So that is very, very much important for you people. Let's look at that. Beta agonist. What is that? Beta agonist. Okay, my dear students, when I want to teach you people about beta agonist, what are the receptors we have? Let's look at them. Beta 1 receptor. Beta 1 receptor. They are located in your heart. Okay, sir. If they are located in your heart, it is like your, what is that? If you stimulate the beta 1 receptor, in the heart, it will increase the heart rate. Okay, it will increase the force of contraction. It will increase your O2 demand. All of you know it. But the most important aspect here, guys, please pay attention. So beta 1 effect on the heart. How to remember? You can remember it like fighting with your girlfriend. Whenever you fight with your girlfriend, what is going to happen? She will start to argue, then your heart rate will rise up. Like that only, heart rate will increase with the stimulation of beta 1 receptor. So, my dear students, where do I have to increase the heart rate? Agreed, in bradycardia. But where do I have to increase the force of contraction? In one condition, in a heart failure condition. So, beta 1 agonist. Beta 1 agonist, we have drugs such as dobutamine. What is that? Dobutamine. Now dobutamine is used, a drug of choice for your acute heart failure. Now many people will jump into the comment section saying that, sir, dopamine also can be used. Agree with you, my dear. Dopamine can also be used. The best drug, if I want to prefer, this is selectivity to beta 1 receptor, then let's prefer beta 1 agonist, that is dobutamine. And there is one more drug, as you people going to say, that is your dopamine. What is that? Dopamine. Now dopamine at which type of thing? See, dopamine has a dose dependent action. What is that? Dose dependent action. At which type of doses? At the doses of medium doses. Which is about 2 to 10 microgram. So this is a story of your heart failure related drugs which are used for acute heart failure. Now remember, beta 1 agonist are which type of drugs? If I was the question examiner, I would make a question in totally different way. A patient who presented with the symptoms of acute heart failure was given a dobutamine. This can be explained by which effect? Remember, that effect is positive inotropic effect. What is that? Positive inotropic effect will be achieved as a result of your dobutamine. This is a very important MCQ. Please understand what is that positive inotropic effect. What is that? Positive inotropic effect. So this is a very, very important aspect for you people to be remember. Positive inotropic effect. So that will positive inotropic effect which will increase, what is that? Increase the heart rate. Along with that, increase the force of contraction. This is a very important aspect to be remembered, guys. So with this much being said, we are done with the beta 1 agonist. But beta 1 receptor not just located in the heart but also located in the kidney. There in the kidney, leading to what? Leading to the activation of the RAS system, which we will learn today in the antihypertensive drugs. Just keep watching. All right? Okay. So in the case of right heart failure, what is a drug of choice? My dear, the presentation matters. Okay. So if I have a patient with a chronic heart failure, be it a right heart failure, be it a left heart failure, I would prefer, what is that? Digoxin. If it is a chronic heart failure. If it is acute heart failure, I would prefer dobutamine. If not, medium dose of dopamine. Got the point? Okay. Now, once we understood about beta 1, Now let's proceed to the next aspect. What is that next aspect? So if beta 1 agonist is done, beta 2 agonist, oh my god, beta 2 agonist is every medical student's favorite. Why? Because saba laba, there is one saying, right? So we will use that only, but let's understand. Beta 1 agonist, we are having, see, beta 1 agonist, we are having dobutamine and dopamine. Beta 2 agonist, we have saba and laba. Let's learn about it. Beta 2 receptor, they are located in your bronchus, they are located in your bronchus, they are located in your blood vessel, they are also located in your uterus, If you notice the common point among these three things, the common point is smooth muscle. What is the common point? Smooth muscle. Now all of you have learned saba laba. I'll ask you a simple question. The simple question will put a trap for you. So this beta 2 agonist act with the help of which protein kinase? Let's see. Comment. Take a guess. Okay. Even if you don't know, why am I here? To make you people learn. Let's learn. Let's consider this is one smooth muscle cell upon which I have which receptor? Beta 2 receptor, my dear students. What is that? Beta 2 receptor. Now, beta 2 receptor, what is there? If I stimulate a beta 2 receptor, what is going to happen? What is going to happen? What is going to happen? It will lead to the increase of the CAMP. Okay. Now the CAMP in turn will stimulate one enzyme called as protein kinase A. Protein kinase A. Now this protein kinase A will inhibit somebody called as MLCK. Will inhibit somebody called as MLCK. Now listen to me very carefully, guys. So what I'm trying to tell you people, MLCK is nothing but myosin light chain kinase. Myosin light chain kinase usually cause the contraction of the smooth muscle. If I block that myosin light chain kinase, I'm gonna get the relaxation. So this is an important MCQ which was asked. So beta 2 receptor acts via which protein kinase? Protein kinase A. Protein kinase A. How to remember this, sir? Beta B A B. You can remember A. Protein kinase A works with beta receptor. Clear, everybody? Clear? Okay. Now, please understand what happens. MLCK inhibited means in the bronchus, bronchodilation. Along with that, there is a vasodilation. What is that? Vasodilation. Along with that, uterine relaxation. Okay, sir. If these three are there, now what we are going to get? Let's understand. Uterine relaxation, there is a vasodilation, and there is a bronchodilation. Now, for that purpose, we are going to uses of these drugs. So uses of these drugs, it is used in the treatment of bronchial asthma. If the MCQ says, listen to me very carefully, if the MCQ says drug of choice for asthma, okay, now the answers will be like this. Option A, steroids. Option B, beta 2 agonist. Okay. Yesterday I taught you people some drugs. What are those? M3 blockers. That is ipratropium. Okay. Option D, none of the above. Okay. Give me an answer. Let's see. If the question says like this. Drug of choice for asthma, steroids, beta 2 agonist, ipratropium, and none of the above. What would be your answer, guys? I'm looking for your comments. Beta 2 agonist, somebody says. Okay. Now, why can't we use steroids? Yes, why can't we use ipratropium? Right? Tell me, others. So, please focus here. Okay. See, any other answers, please? Okay, now listen to me very carefully. What is that? I'm trying to tell you people, if they tell you only something like drug of choice for bronchial asthma, no other data is given, no other data like mild, moderate, severe, nothing about it is given. If nothing about it is given, then your answer should be always beta 2 agonist. Beta 2 agonist. Beta 2 agonist are the first line of the drugs which we start for a patient of the bronchial asthma. Got the point? Got the point? Okay. If the question, if I change drugs used in asthma, then all of the above. Drugs used in asthma, all of the above. Got the point, everybody? Okay. Now, apart from asthma, they're used in COPD. They're used in COPD. Now, they're also used in premature labor, preterm labor. Preterm labor. Now, when I'm talking about a preterm labor, the drug which is specifically developed for the uterus is ritodrine. But do we use this drug nowadays? No, we have a better drugs such as tocolytic agents, such as calcium channel blockers. So we are going to use those drugs rather than the beta 2 agonist. But they can ask you which beta 2 agonist is used for the tocolytic or a uterine relaxation. Okay. Now all the drugs are divided into two types. All the beta 2 agonists are divided into SABA, short acting beta 2 agonist, and there is one more way called as LABA, long acting beta 2 agonist. Now SABA, what is that? SABA. Okay, now it's SABA, guys. It's not Shiba, it's SABA. Okay, if somebody with Shiba name sees that, please don't get offended. Okay, now SABA, what is that? We have a drug called as salbutamol. Okay, then any other drug? We have one more drug called as terbutrelin. Okay, so these are the two drugs which you need to remember. Okay, now LABA, what do we have, sir? Long acting, we have one drug called as salmeterol. We have one more drug called as formoterol. Okay, now metro goes all over the city, like that only you can remember. Long acting drugs will contain metro in them. This is one classic way which we have been remembering, formoterol and salmeterol. Okay, now remember we have a salbutamol, we have terbutrelin. These are the short acting beta 2 agonist. But I'm least interested in this. There is one of the most important aspect, the side effects of these drugs, guys. Side effect of this drug, remember, it will cause one thing that is only called as reflex tachycardia. Okay, reflex tachycardia. What do I mean by this? Beta 2 agonist causes vasodilation. If there is a vasodilation, there is a decrease of venous return. If there is a decrease of venous return, heart will try to compensate by increasing the heart rate. That is only reflex tachycardia. Remember, reflex tachycardia can present as a palpitation. Got it? Palpitation. Okay, now apart from reflex tachycardia, is there anything else? Yes, of course. There is one more important side effect, that is your tremors. And it will also alter the blood glucose level. So these are the three important aspects. So how will a MCQ come for you people? A 25-year-old female who was a known case of asthma was given a drug. After that, she was not able to sleep in the night due to palpitation and tremors. Which drugs were given? Beta 2 agonist. Simple as that. This question was asked previously. So I'll repeat the question again. A 25-year-old female who was treated for the asthma was not able to sleep in the night because of the tremors, and one more thing, that is because of the palpitation. Now, what is the drug given? This drug given is beta 2 agonist. This type of questions are asked. This is a trick of the pharmacology. So throughout the theory, what you learned, the end summary is very important key point. All right. See, orthostatic hypotension is not a significant. Orthostatic hypotension, that is significantly seen with alpha blockers. Okay, then next thing, the drug of choice for tremors is beta blocker. My dear students, remember the drug of choice for what is that? Essential tremor. What is that? Essential tremor is beta blocker, that is your propranolol. Okay, not for every tremor blindly we will give beta blocker. For example, patient was having tremors as a result of some CNS disorder. Okay, but in essential tremor there is no such thing. No pathology is found, idiopathic tremor. So in that condition, you're going to give propranolol. Clear-ish? Okay, let's continue. What is that? We understood about SABA, we understood about LABA. Let's go next. What is that next part? So, what is that, guys? We understood about beta 1, beta 2 agonist, alpha 1, alpha 2 agonist. Clear. Now, my dear students, once we know about this, let's go to the next important aspect. They are only were adrenoblockers. Adrenoblockers. I can challenge you people one thing. Adrenoblockers. I can 100% assure you that there will be MCQ. 100% there will be an MCQ, because this is a very, very important topic, because it has a twisted uses and very interesting information. So let's start. Adrenoblocker. If we are blocking adrenoreceptor, we are going to block either alpha receptor or we are going to block either beta receptor. So let's look at each one of them. So first important aspect, let's start with the alpha blockers. So alpha blockers, my dear students, these alpha blockers are divided into what? These alpha blockers are divided into two types. First one is non-selective. They are your non-selective alpha blockers. If non-selective alpha blockers means they are gonna block two receptor, alpha 1 also and alpha 2 also. Alpha 1 also and alpha 2 also. But non-selective alpha blocker, if they are blocking alpha 1 and alpha 2, we have two types. They are called as reversible, and there is one more drug called as irreversible. So reversible and irreversible, there are two types of blocker. Reversible blocker means what is that? For example, I have a drug which will block the receptor for 5 hours. So I have a receptor which is sitting like this. Now I gave a drug irreversible which works for how many hours? 5 hours. Okay. After 5 hours, what happens? My drug will disappear. After drug disappear, what will happen? The receptor will become active. This is a reversible. If irreversible means what? The drug will go and bind with the receptor. Receptor is destroyed forever. Now your body has to synthesize a new receptor for the alpha action. That is the summary. Now you people should pay very much attention, because I'm going to create a trap for you people. Let's see how many of you will catch on to it. Okay. Reversible drug. What do we have? We have a drug called as phentolamine. Now we have a drug called as phentolamine. There is one more drug called as tolazoline. So these two drugs are. Now irreversible. What is that irreversible drug? We have a drug called as phenoxybenzamine. Now you people have to focus here. How to remember these two drugs? Sir, if you notice here, sir, we have a phentolamine and tolazoline. Okay. And if you notice here, phenoxybenzamine. Which name is bigger? Phenoxybenzamine. If the name is bigger, you can remember it with this only. If the name is bigger, the duration of action is longer, because it is a irreversible blocker. So this is a long-acting drug. How to remember long-acting drug? A lengthy name. Okay. A lengthy name. That's what you need to do. You don't have to do all this extra mnemonics and a lengthy name. Okay. Long-acting and irreversible. Now, guys, let's go for the uses of this drug. Uses of these drugs, my dear students, they are very much important and interesting. Why they are very much important and interesting? Because of one reason. What is that one reason? Let's see. Now, these drugs are used for the cheese reaction. Now all of you might be thinking, what is this cheese reaction? Guys, cheese reaction is caused by a compound. This can also be an important MCQ. What is that? Cheese reaction is caused by which compound? Compound called as tyramine. Remember tyramine, not tyrosine. It is a tyramine. It is a compound called tyramine. So for this treatment, we use which drugs? Usually reversible drugs. Reversible. Now, apart from that cheese reaction, these drugs also used in one more place. Called as pheochromocytoma. Now, pheochromocytoma, very good, Rahman, very good. That is tyramine, correct compound. Okay. Now, pheochromocytoma is what? It is a catecholamine secreting tumor. Now, Now, you people might be thinking that, okay, what is the drug we can give? Then definitely, sir, tumor is there. We need a longer action. We are going to use which drug? Irreversible drug. What is it? Irreversible drug. Okay. Now, if you are talking about irreversible drug usage, now, my dear lovely students, pay attention. You give a irreversible drug. Now, irreversible drug will go and block alpha receptor. It will go and block the alpha receptor. If it is going and blocking the alpha receptor, now what will happen? Still you need to understand one more thing. So what is that? Catecholamine producing tumor. So more of catecholamine already present and you give a alpha receptor blocker. If you block the alpha receptor, now adrenaline will act upon stimulate which receptor? Of course, vasomotor phenomenon of Dales. Beta 2 receptor. Which receptor? Beta 2 receptor. If beta 2 receptors are stimulated, then it will decrease the blood pressure. The patient might even go to shock. Now, patient with a pheochromocytoma came to with elevated blood pressure. You give one drug without thinking. Single drug cause the patient into shock. Now, can you let this happen? No, because shock can kill the patient very instantaneously. So you need to avoid this. How can you avoid this? To avoid the shock, best combination is, what is that? That is your phenoxybenzamine. What is that? Phenoxybenzamine. Along with phenoxybenzamine, you need to add one more drug which block the beta 2 receptor also, that is your propranolol. Okay. Now you people might be confused, sir. It will also block beta 1. Yes, of course, beta 1 also, it will block beta 2 also. And we are going to use that property of beta 2 blocking here. That's it. Okay. So what is the summary? We need to combine phenoxybenzamine along with propranolol. That is the best combination for the treatment of pheochromocytoma. If single best drug, of course, sir, phenoxybenzamine. If best medical management is what? Propranolol. Every student would have made a mistake, and if you make this mistake, this can make a difference between 149 and 150. And all my students who are watching this and who are going to watch this, you need to make sure that this combination is used for the treatment of what is that? Pheochromocytoma. Okay. Now, if you want to understand more about these drugs, we will learn especially the side effects. So look here, guys, alpha blocker side effect. We will come to alpha blocker side effect when we will come. Once we learn about alpha 1, very good. What is that? Alpha 1 agonist or antagonist? Of course, alpha 1 antagonist. Now, when you want to learn about alpha 1 antagonist, guys, understand here, alpha 1 receptor is further divided into, yes, sir, alpha 1A, alpha 1B. Okay. Now, alpha 1A is located in the blood vessel. Alpha 1A is located in the urinary bladder sphincter, and your alpha 1B is located in the blood vessel. Alpha 1B is located in the blood vessel. So I'll talk about the shock and all. Okay, let's finish these things. We'll come to that. Okay. Now look here. Alpha 1A is in the urinary bladder sphincter. Alpha 1B is located in the blood vessel. Now, if you block alpha 1B, it will decrease the BP. Okay. If you block alpha 1A, it will make the easy urination. So where you need to easy urinate the patient? In the patient with the BPH, benign prostatic hyperplasia. If I have a patient with the benign prostatic hyperplasia, I need to block alpha 1 receptor. Now listen to me, the drug which block the alpha 1 receptor, the name of the drug is your tamsulosin. What is that? Tamsulosin. Now, tamsulosin is a drug which will specifically block, what is that? Alpha 1A receptor. So, it will be used for the BPH. But if I ask you people, is it a drug of choice for BPH? No. This tamsulosin is the symptomatic drug of choice for BPH. Means BPH patient will have a difficulty in urination. To improve that symptom, we are using tamsulosin. Please don't get confused. To just what? To improve the urination, to treat the symptom. Okay. If I ever ask you people, the drug of choice for BPH, then your answer will be 5 alpha reductase inhibitor. 5 alpha reductase inhibitors such as finasteride. finasteride. Okay, so this is a drug you need to remember. Now let's go to the next aspect. What is that? If I have a patient who is having benign prostatic hyperplasia along with that hypertension, so then what you need to do? All you need to do is that you need to look back here and understand. Look back here, you need to block alpha 1A and alpha 1B. So exactly we are going to use alpha 1A and alpha 1B blockers, alpha 1A and alpha 1B blockers, which can also be called as alpha 1 antagonist. Alpha 1 antagonist. Okay, now alpha 1 antagonist, very good. You people already told me what is that? Prazosin, terazosin. So write down the names of the drugs. We have a drug called as terazosin. Okay, we have a drug called as alfuzosin. Okay, we have a drug called as a prazosin. Okay, now among these things, what is the most important aspect? If I ever ask you the MCQ, BPH with hypertension, your drug of choice will be your, what is that? Drug of choice will be your, very good, that is alpha 1 antagonist such as terazosin, alfuzosin, doxazosin, prazosin. Okay, now you people will tell me which is that drug used for scorpion bite. Remember, prazosin is used for scorpion bite. So this is also an important aspect. If they want to ask you very easy question, sometimes yes, there are easy questions. They'll ask you what is the best drug used for the treatment of scorpion bite. The best drug would be your, what is that? Best drug would be your prazosin. So once we are finished with the prazosin, let's go to the next important aspect. What is that next important aspect? Side effects of alpha blockers. This has been a very trendy question. This was asked very repeatedly, more than 4 to 5 times in last 5 years, maybe last 5 years. Yeah, 5 years or 6 years. Okay, so in that I want you to understand. So alpha 1 receptor blockers, they will cause one side effect that is only called as first dose effect. What is that? First dose effect. Now, first dose effect, many people will get confused. Sir, what is this first dose effect? That first dose effect only what you know already. What is that? Very good. Orthostatic hypotension. What is this orthostatic hypotension story? That is basically a first dose effect which will cause the orthostatic hypotension. What is this orthostatic hypotension? This orthostatic hypotension, patient will be lying down, he will wake up and he will try to walk. When he tries to walk, all of a sudden venous return will decrease, which will lead to decrease of the BP, called as orthostatic hypotension. Usually orthostatic word, we are referring to the change of position. Okay, change of position will lead to decrease of the BP, and that can be observed even with the first dose of the tablet itself. See, remember this. So first dose of the tablet itself can yield this effect. That is why we are going to call it as a first dose effect. First dose effect is what? First dose effect is your orthostatic hypotension. Because why it occurs, I'll give a quick review. We are blocking alpha receptor. If we are blocking alpha receptor, there is no vasoconstriction. Upon when? Upon change of position. If there is no vasoconstriction upon change of position, then automatically it will lead to decrease of the venous return, which will lead to decrease of the blood pressure. So basically orthostatic hypotension develops as a result of which effect? Decreased venous return, as a result of which decrease of the BP, we call it as a orthostatic hypotension. Okay, now of course venous return is not there, blood is pooling where? In the veins. Done. Okay, now let's continue to the next important. So we are blocking which receptor? Alpha receptor. There is one more side effect. If at all examiner want to put you in a trap, this effect can also be seen. That is only your retrograde ejaculation. So retrograde ejaculation is also a very important side effect which can be seen as a result of your, what is that? Which can be seen as a result of your, very good, that is your alpha blockers. So once we understood about, see, these are the two important side effects. So the examiner can ask you like this. All of the following can be seen with alpha blocker except first dose effect, orthostatic hypotension, retrograde ejaculation, and for example some cataract he'll give. The answer will be cataract because all of the following except I have asked. All of the following except I have asked. Got the point? So the same thing only he can make it into three options here. So wherever we have a three option, automatically done, done, or done. What is that? There will be MCQ. Okay. Now let's go to the next. After you block alpha receptor, alpha 1 is blocked. Then we have alpha 2 blocker, alpha 2 blocker. Now alpha 2 blocker, we have a drug called as yohimbine. Now yohimbine is not FDA approved. Not FDA approved. If it is not FDA approved, understand, which is not clinically used usually for the treatment, but there are other uses. Since it is a plant derivative, it is derivative of a plant called as yohimb plant. So this drug usually it is not FDA approved. So but off-label uses are there. Off-label uses such as erectile dysfunction. Okay. Even for the premature ejaculation, even as an antidepressant. Okay. Let's go to the next aspect. What is that? Alpha blocking is done. Let's go, sir. Then go and block the beta blockers. What is that? Beta blockers. Beta blockers. Now, beta blockers are very much important. Why? Because let's understand. First important, beta blockers. We have something called as prototype beta blocker. What is that? Prototype beta blocker. Now, my dear students, prototype beta blocker is what? Prototype beta blocker, which will block beta 1 receptor and also beta 2 receptor. If any drug which has all the properties of that group, we are going to call it as a prototype drug. Now, prototype drug MCQ trap will be put for you people from opioids, which I'll teach you people, don't worry. Okay. So what I'm trying to tell you, prototype drug beta 1 and beta 2 antagonist. Now, prototype drug beta 1 and beta 2 antagonist, the drug we have here, what is the drug? The name of the drug is your propranolol. Okay, propranolol. Now propranolol is a prototype beta blocker. Now let's learn about the propranolol. First important, in one place only, let's learn the uses, okay, side effects and contraindications. So all these three are definitely very important. There can be a MCQ from here, very important. Okay. Now, first important, if it is blocking the beta 1 receptor, we can use it in the treatment of arrhythmia. Okay, it is also used in the treatment of which arrhythmia? That is tachyarrhythmia, but that is not as so much important. Yes, which can also be used for the treatment of hypertension. That also you'll learn from the beta blockers. But my dear lovely students, remember some most very important uses which are very specific to propranolol. The first and most important use, it is used for the prophylaxis. What is it? Prophylaxis of which disorder? Prophylaxis of migraine. Okay. Now, migraine question has been asked repeatedly. They'll ask you all of the following are used for the migraine prophylaxis except the first drug I have taught you people. One of them is propranolol. Then apart from that, guys, it is also used in the hyperthyroidism. Apart from hyperthyroidism, it is also used for the essential tremors. Okay. Now, when you're talking about essential tremors, guys, there is no pathology which is organic pathology. You got the point? So, if you look from the brain till the muscles, everywhere, every nerve, every conduction, everything will remain normal. Still, patient will have the small tremors. We call it as a essential tremors, which is common in the young people. If I want to ask you an essential tremor question, all the complete examination, all the investigation, everything is normal in a young patient with what is that? With your effect of the tremors. Then we are going to call it as a essential tremor. Okay. Now, apart from that, it is also used for the treatment of something called as, what is that? Stage fright or a performance anxiety. What do we call it as? Performance anxiety. What do I mean by performance anxiety? Suddenly, if I ask you to go on a stage and address some 2000 people, you will not be able to do that because you'll start to develop severe palpitation and anxiety. To treat that also, propranolol is used. See, beta blocker, all the beta blockers are used in these two, but in other places, these are the very important uses. So definitely there can be a question, what is the drug of choice for any of these things they can ask you. So please pay attention. Now side effect. Side effect is very easy. Look here. What he has to do? He was supposed to block beta 1, but he's also blocking beta 2. If I block beta 2 stimulation causing bronchodilation. If I block the beta 2, bronchoconstriction. Very good. Side effect will be bronchoconstriction. If side effect is bronchoconstriction, automatically it is contraindicated in asthma patient, and one more patient. Who is that? Of course, COPD patient. Okay, it will also cause, what is that? Vasoconstriction. Vasoconstriction. So if vasoconstriction is there, what will happen? You need to pay attention here. Consider this the hand, right? Now, I have a blood vessel which is coming to my hand. Now, if I cause the vasoconstriction of this blood vessel, what is going to happen? Vasoconstriction, no blood supply. If there is no blood supply, automatically what will happen? This area will suffer ischemia. So you need to understand. What is that? If at all, normally if there is a small vasoconstriction, no problem. But if I have already I have a disease in the blood vessel, to that I will cause extra vasoconstriction. That time there will be totally loss of blood supply, can lead to severe ischemia. So please understand, vasoconstriction, we avoid them in a condition called as peripheral vascular diseases. Peripheral vascular diseases such as, can anybody tell me some peripheral vascular diseases? Two peripheral vascular disease. Chalo batao. Tell me, let's see. Peripheral vascular diseases. Tell me. Burgess disease, very good. Takayasu arthritis, okay. Anything else? Two very important ones. Remember these two things. What are those two things? Atherosclerosis. Then there is one more thing you need to understand. Very good. That is Raynaud's syndrome. Okay, Raynaud's phenomenon and syndrome are little different. That's it. Okay. Now, this is the story of your propranolol. Will you answer? Yes, of course. So please don't make any mistakes. Let's go to the next aspect. What is that, sir? Sir, what is that? We have selective beta 1 agonist. Selective beta 1 agonist. Now here only you are going to face a lot of problem. They will tell selective. Immediately they will bring a side effect as bronchoconstriction. Sir, what is wrong with you people, you might ask? I will teach you people how to remember that very easily. Okay. Now, selective beta blockers. First, let's write down the names. Let's make it a simplified technique to remember. Then we will go for other things. Okay. Now, what is that to remember, sir? So, what is that? They have a drug. What is that? That is only called as atenolol. We have one more drug. That is your betoxolol. Okay. So, don't panic. This is very easy. I'll tell you how to remember. Just okay. Okay. Now, let's go to the next important. Sorry. Yeah. This is a beta 1 blocker. Antagonist. Okay. Now, let's continue. Betoxolol. Then, apart from that, we have other drugs such as metoprolol. Apart from that, betoxolol, metoprolol. Then we have other drugs such as what is that? Can anybody tell me? What is that? Esmolol. What is that? Esmolol. Okay. We have all these drugs. We have acebutolol. There are so many drugs. Now, apart from that, write one more drug here only. Nebivolol. Okay. Now, let's go to the other side. Let's write down here. What is that? Let's write down timolol. What is that? Timolol. Okay. Apart from timolol, we have a drug such as sotalol. Okay. Now, sir, why am I writing these two things separately? Now, if you notice here, remember one thing. What is that? That is this is the technique. What is that? A to M. any drug if its name is starting from A to M. Any drug if it is starting from A to M. M for who? M for me. Myself, who is that? Maruti. From A to M, if any drug's name is starting, all of them are a selective beta blocker. Which selective? Selective beta 1 blocker. But for this one exceptional case. What is that exception? That is exception is nebuvolol. Nebuvolol. Okay. Now, any drug which starts from N to Z, which is beta 1 blocker and also your beta 2 blocker. This is a technique to remember. Okay. So that is what pinodolol. Okay. So all these drugs, whatever comes after N, except for one drug, nebuvolol, all of them will have a beta 2 blocking property. Will you remember that, guys? Done? From A to Dr. Maruti, M for Maruti. You can remember it like that. A to M. Who is that? What is that? Beta 1 blockers, except one case, nebuvolol. Rest every other drug, beta blocker will come into. Any other drug which starts from N to Z, then we are going to call it as a non-selective property of a beta blocker. Easy to remember now? Now, so here only you can understand this betoxolol is used for glaucoma. And timol also used for glaucoma. Betoxolol also used for glaucoma. Timol also used for glaucoma. Now the next important aspect. What is that? Guys, esmolol. Esmolol is a shortest acting drug. That is your shortest acting drug. If any drug is shortest acting, automatically it will be fast acting. Shortest acting drug will be automatically fast acting. That is the story of your, what is that? Selective beta 1 antagonist. Now, when we need to understand about the next aspect, once we understood about the antagonist, let's understand the generalized uses of this beta blocker. What is that? Generalized uses of the beta blockers. So, understand what is that. The one of the most important aspect is that hypertension. Now, the MCQ here. What is the mechanism of beta blocker in treatment of hypertension? Okay, this will become a very important aspect. Okay, I will give you the option. Option A, they will decrease the heart rate. That is how that will lead to decrease of the BP. Option A. Option B, they will decrease the force of contraction. That will lead to decrease of the BP. Option C, they will decrease the renin release, which will lead to decrease of the BP. Option D, none of the above. Now, this is a very important MCQ. This MCQ was asked and can be asked again and again. Let's see, you people can answer it. Okay. So, one student of ours says A and S says C. Any other answers, please? Let's see. Tell me. Okay, A. I'm waiting. This one I want you people to see how much attention you have paid. Okay. Any other answers? Anybody who says none of the above? Okay. So the answer is, my dear students, when I say this kind of specifically, that is definitely what is that? Trap. So answer is C. So those who marked answer is C as a correct answer. Remember, if beta 1 is blocked, the correct answer is, if beta 1 is blocked, that will lead to decrease renin. Most importantly, pay attention to this particular word, renin release. This is the most important mechanism through which BP will be decreased by beta blocker. This is a very important question to be remembered. Will you remember it now? Done? So understand, beta 1 blocker will decrease the renin release, which will decrease the blood pressure. This is a very important aspect. Okay. Why not A? I will tell you, heart rate if you decrease, that will not alter the BP significantly. Okay, that is not the reason. Second thing, if you decrease the force of contraction, still heart is pumping. Okay, it will not significantly decrease the BP. But if renin is decreased, automatically what will happen? BP will be decreased, because RAS system is one of the major regulator of your blood pressure. Got the point? Got the point? Why not A? That is the reason. Okay. So always remember, this is an important aspect. And please, I am requesting everyone, please pay attention and learn here. Beta blockers decrease the renin release. They will not inhibit the renin. They will not inhibit the renin, but they will inhibit the renin release. They will inhibit the renin release. Repeat this and remember, because you might get confused. If you consider this is a blood vessel, and this is the story of your kidney. Okay, now understand, renin will be released into the blood vessel. If renin is already released inside the blood vessel, if you block this renin, that is done by with the drug called as aliskiren. Okay, now if you block here, what is that? Stop the release itself, then your beta blocker. Okay, if renin is already released, that will be inhibited by drugs such as aliskiren and primaskiren. But most importantly here, if renin has not released and we want to prevent its release, then you are using beta blocker. I'm telling again, beta blocker will prevent the renin release, because this is a standard confusion which can happen to any students. Clear, everybody? No, that is what plasma renin levels will not be directly lowered. Okay, see, plasma renin will be less when you use beta blocker, but not directly by inhibiting the release, because directly if they are decreasing the renin level, then you are aliskiren. If directly decreasing the renin level, aliskiren. Directly decreasing the renin level, aliskiren. Indirectly by inhibiting its release, beta blocker. Okay, so both the drugs will decrease the renin level, but one of them stops the release, that is beta blocker. Please, if I have told you this question this many times, definitely you need to understand the worth of this question, why I have been explaining. Okay, chalo, let's continue. What is that? Once we understood about the hypertension, let's go to the next aspect. What is that? They're used in the tachyarrhythmias. Tachyarrhythmias. So tachyarrhythmias such as atrial fibrillation. Even in some other cases of PSVT also we can consider beta blocker, but not the first line. Okay. Now tachycardia. Okay. Apart from that, they are used in the chronic heart failure, but absolutely contraindicated in acute heart failure. Pay attention to this. They are absolutely contraindicated. Okay, so what is that? They're absolutely contraindicated in which condition? Acute heart failure. We'll come to that. Very good. Angina also we are going to use them. Very good. Okay, so there are some non-shockable rhythms, we can consider them. Okay, but not every case. Okay, now look here. In the acute heart failure, if you give a beta blocker, patient might die because heart rate will suddenly go down. But chronic heart failure, why we are using them? In chronic heart failure, it will beta blockers will decrease the heart rate. If they are decreasing the heart rate, what will happen? My dear students, understand, if at all I have 60 beats per minute for one condition, 60 heartbeats, I have 120 heartbeats per 1 minute. Okay, now from one heartbeat to another heartbeat, which has lots of gap. See, one heartbeat, dub, then after 1 second, dub, then after 1 second, dub. That is what? 60 beats per minute. But here what will happen? Dub, 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 dub. What? In 120 beats per minute. Means if you decrease the heart rate, your heart will relax better. That means it will increase the duration of relaxation of the heart, called as diastole. What is that? It will decrease the heart rate. It will increase the duration of diastole. It will increase the duration of diastole. If we increase the duration of diastole, automatically, if your heart is relaxing better, it is getting filled better, so that heart can pump better. So that is what it will increase the filling. So this is the most important reason. See, other reasons, I'll tell you, other reasons also there, but most important reason is decrease the duration of diastole, but other reasons such as decrease the O2 demand can be considered. Okay. Now, the next important aspect. The next important aspect, my dear students, they are used in the angina patients. angina patients. Angina patients, why? Because beta blockers decrease O2 demand of the heart. Here it is a specific reason. So O2 demand of the heart will be decreased. Then angina. Okay. Now apart from angina, these drugs also used in one condition which I taught you people already, glaucoma. What is that? Glaucoma. In the glaucoma, two drugs. What is that? Betoxolol. Then one more condition, one more drug. What is that? Timolol. Clear? Timolol. So timolol, can you use it in a patient with bronchial asthma? Can be used in asthma. True? False? B. Tell me. Option B and option A. One of them is true, one of them is false. Okay, some people says false. Okay, Rahman says false, rest other says nothing. Huh? False, false, false. Very good. The correct answer is false. So, why correct answer is false? Because timolol. Yes, of course. When you put it in the eye, you might be thinking, sir, we put it in the eye, drug is in the eye. What is the problem? The problem is that from the eye, the drug will go into nasolacrimal duct and it will go into the systemic circulation causing bronchoconstriction. So, please avoid timolol in a patient with bronchial asthma. Very good. Okay, so these are the some important uses of your beta blockers. These are some important uses of beta blockers with every use as mentioned as MCQ. Clear everybody? Clear? Able to follow me? So today I hope there are no issues for you people related to voice breaking, cut down, nothing. Let me look at your comments first. Able to follow me so far? Able to understand everything? All right, very great. Perfect. Then let's go. Let's go to the next aspect. So we are done with the autonomic nervous system, but we are left out with one particular aspect. Sir, we blocked alpha receptor, we blocked beta receptor. So anywhere if we are specifically blocking, there should be someone who blocks non-specifically also. Means what? Alpha plus beta blocker. Write down alpha plus beta antagonist. Beta antagonist. Alpha plus beta antagonist. We have two drugs, my dear students. So these two drugs are your carvedilol. Carvedilol. There is one more drug called as labetalol. Labetalol. Okay. Now, what about these two drugs? My dear students, these drugs also again they're used for hypertension. Used for hypertension. But remember, the most important, labetalol is the drug of choice for pregnancy hypertension. So any female with a pregnancy induced, which is called as PIH, pregnancy induced hypertension, the best drug you can give is labet. What is it? Labetalol. So two drugs we learned about safe in pregnancy so far for the hypertension. What is that? Very good. There were alpha methyl dopa and labetalol. Got it, everybody? Okay. Hope everybody understood this. Let's go to the next aspect. What is that? That is your, once we are done with your autonomic nervous system, we are getting into the next and most important aspect, central nervous system. Okay. So when we need to understand about central nervous system, so very easy, very simple life, but only thing is that lots of drugs, lots to remember. I'll make it simplified. So in every topic here also, again, I'll be highlighting here, there will be many concepts are simple, but the questions are to be remembered. The question oriented points are to be remembered. So I want you people to pay attention. When I ask you to repeat, do it with me right now so that you don't have to do it later on in your preparation. Okay. So let's start with the central nervous system. Okay. Now, listen to me very carefully. Central nervous system. In the central nervous system, let's start with the one of the most commonly used drugs, one of the commonest disorders. Let's start with the anti-Parkinson drugs. Anti-Parkinson drugs. My dear students, anti-Parkinson drugs, if you need to understand what exactly happens in the Parkinson disease. So Parkinson disease, what happens is that decrease of the dopamine. Decrease of the dopamine in which area? In an area called as substantia nigra. Substantia nigra. It is a dark area which is present in the brain, especially in which part of the brain? Called as basal ganglia. Basal ganglia. Now, substantia nigra is a part of basal ganglion in which what happened? Decrease of the dopamine. Okay. Now, if you need to understand this, what we need to do? Sir, what we need to do is that consider this is one neuron. This is one neuron. There is one more neuron. Okay. Now, this neuron will produce your what is that? Dopamine. Now, dopamine usually acts upon what? Dopamine receptors. All of us know that. Dopamine receptor. Now, what exactly we need to learn? Sir, what you need to learn here is that either you can increase the dopamine, yes, we can treat it, or directly stimulate the receptor, we can treat it. So, there are two ways, either increase the dopamine and treat the Parkinson, or one more way is what? One more way is that is your very simple way, directly stimulate the dopamine receptor. Okay. Now, let's understand. Guys, about acetylcholine. So let me tell you people, acetylcholine is balance of the neurotransmitter. What do I mean by balance of the neurotransmitter? That balance is like this. Consider this is your acetylcholine, this is your dopamine. Once dopamine level is low, acetylcholine will look like it is elevated. So what you have to do is that maintain those levels equally. Maintain those levels equally. Okay, so this is the most important aspect you need to understand. Okay, now guys, if you need to understand about this, it's very easy. So what exactly we need to do? First, what I did, I gave a dopamine. I gave a dopamine. How did I give? IV. I gave what? IV dopamine. IV dopamine went to where? To a place called as blood-brain barrier. To a place called as blood-brain barrier. Now, in the blood-brain barrier, this dopamine was not able to cross the blood-brain. Dopamine was not able to cross the blood-brain barrier. If dopamine was not able to cross the blood-brain barrier, I developed a drug. What is that? Levodopa. What is that? Levodopa. Now, I developed a levodopa. Now, this levodopa can cross the blood-brain barrier easily. Okay. Now, levodopa will cross the blood-brain barrier. Now, there is under the influence of one enzyme called as dopa decarboxylase. Dopa decarboxylase. Dopa decarboxylase. It will get converted into dopamine. It will get converted into dopamine. Okay. So, one problem is sorted. One problem is sorted. Okay. Now, let's go to the next important. But the problem is that, guys, when I use this levodopa, now in the periphery also, I will have the same enzyme, dopa decarboxylase. Now, dopa decarboxylase will convert the levodopa into dopamine. Levodopa into dopamine. Now, this dopamine cannot cross the blood-brain barrier. So, if I want to make my levodopa to reach the central nervous system, the first thing I have to do is that I need to block this. If I block this dopa decarboxylase, levodopa will increase, automatically it will cross the blood-brain barrier. So, for that purpose only, peripheral dopa decarboxylase inhibitor, we have a drug called as carbidopa. Carbidopa. Now, what is carbidopa's mechanism of action? Okay, yeah, of course. We will come to that. Okay. Now, carbidopa. Now, this carbidopa is an important aspect. Why? Because see, levodopa is not crossing the blood-brain barrier because it was getting converted into dopamine. So, he took a help of his friend. Who was that? That was your carbidopa. So, first important mechanism of action of carbidopa. Carbidopa. The mechanism of action of carbidopa, it will inhibit dopa decarboxylase. My question is that will it cross the blood-brain barrier? Cross the blood-brain barrier. Okay, tell me, let's see. We will come to that CTZ. Now, I'll come to the story of complete dopamine in the CNS when I'm teaching antipsychotic drugs, okay? With the pleasure, I will teach you people how pleasure also plays a role with dopamine. So we need to apply our common sense. What is that common sense? If carbidopa goes to central nervous system also dopa decarboxylase will be inhibited. So please understand, no crossing of the blood-brain barrier. So carbidopa, no sir, no crossing of the blood-brain barrier. Wow, very nice. Okay. Now let's go to the next important aspect. Now dopamine came to the CNS. Now understand, this is your blood-brain barrier. Okay. This is your blood-brain barrier. Now here is your brain. Inside the brain, what goes on? Let's see. Let's consider this is one dopaminergic neuron. Let's consider this is one dopaminergic neuron. So this dopaminergic neuron will have all the drugs working in one place only. Look here. So what do I have? I have dopamine receptor. Usually in the brain, which are those there? They are your D1 or D2 receptor. D2 receptors are located in the brain usually. Okay. Now look here. Dopamine will be released. Dopamine will be released, or maybe from your levodopa you might have got the dopamine. Levodopa you got the dopamine. Now this dopamine, what happens is that it will go and act on the D2 receptor. Now the issue is that this dopamine can be metabolized by two enzymes. Dopamine can be metabolized by two enzymes. One of them is called as monoamino oxidase B. Monoamino oxidase B. Okay. Then there is one more enzyme called as COMT. COMT. This both will metabolize dopamine into its degradation products. Now what I can do, if I inhibit MAO-B, if I inhibit MAO-B, automatically that will increase the dopamine. That will increase the dopamine. What are the drugs? MAO-B inhibitors. Let's see. So MAO-B inhibitors, we have, what is that? That is your, yes, you are correct, Rahman. Let's come to that one by one. Okay. MAO-B inhibitors, we have drugs such as selegiline. What is that? Selegiline. Okay. Selegiline. There is one more drug called as rasagiline. What is that? Rasagiline. Rasagiline and selegiline are MAO-B inhibitors. What is that? MAO-B inhibitors. Then we have one more drug. What is that? If I inhibit COMT, they will also lead to increase of dopamine. They will also lead to increase of the dopamine. What are the drugs we have? We have entacapone. Then we have one more drug. What is that one more drug? So entacapone, as you told, we have one more drug, that is your tolcapone. What is that? Tolcapone. What is that? Tolcapone. These are the two drugs. So let me look at the comments. So not lipid soluble, no hepatotoxicity, so COMT. Yes, of course, COMT blockers are your, what is that? COMT blocker is a tolcapone and entacapone. Now, please understand, these drugs are also used for the Parkinson disease. My dear students, I want you to understand one more thing. What is that next one more thing? See, what exactly is that? That is your, we have a drug called as amantadine. Amantadine. Now this amantadine is a type of antiviral drug. It is a type of antiviral drug. Though it is a type of antiviral drug, this amantadine increase the dopamine availability. Increase the dopamine availability. Okay. Availability, if that is increasing the availability, that can also be used. That also shows the effect. So they might ask you, these are very simple drugs. Amantadine is used for, what is that? Antiviral, and as well as your dopamine availability increase. So Parkinson disease. Apart from that, the last thing what you can do, my dear student, D2 agonist is there, na? Directly we can stimulate the D2 receptor. Directly we can stimulate the D2 receptor. If directly you are stimulating the D2 receptor, so basically you are focusing on one thing. What is that? That is dopamine agonist. Dopamine agonist. Now dopamine agonist, my dear students, what are the drugs we have? So the dopamine agonist, we have drug called as bromocriptine. Bromocriptine. What is that? Bromocriptine. Apart from bromocriptine, we have one more drug that is called as cabergoline. Cabergoline. What is that? Cabergoline. There is one more drug. What is that? Very good. Very good. Pergolide. What is that? Pergolide. What is that? Pergolide. Then we have one more drug that is only called as pamipexole. What is that? pamipexole. Okay, now there is one more drug called as ropinirole. Please don't get too much into your what is that? That is your confusion. I'll tell you what are the things to be remembered. There is one more drug called as ropinirole. But among all these things, remember one of the most important, bromocriptine. Bromocriptine is a very important drug, not for its use in the Parkinson, but also its other uses. And there is one important aspect, that is, you are write down here, new transdermal patch. New transdermal patch available for the treatment of the Parkinson disease is called as rotigotin. Now this rotigotin, my dear student, it is a type of non-ergot drug. Now this non-ergot drug used in the form of a transdermal patch. This is a MCQ here. So which anti-Parkinson drug which is used in the form of a patch form which is available in the market today, that is your rotigotin, which is a non-ergot derivative. Now bromocriptine, other uses, write down. Bromocriptine can be used for the treatment of diabetes mellitus. Apart from the treatment of diabetes mellitus, now cabergoline. Now listen to me very carefully. Bromocriptine and cabergoline both are used for prolactinoma. But the best one for the treatment of prolactinoma is cabergoline. Why? Because cabergoline is a longer acting drug. So please don't get confused. Prolactinemia, we are going to use what is that? Bromocriptine and cabergoline. But the best drug is your cabergoline. Now pamipexole and ropinirole are recently better used compared to the other drugs. This is the story of your Parkinson drugs. Clear, everybody? All right. So once you understood about the Parkinson drugs, then we are going to the next important aspect. That next important aspect, what we will be studying, that we will be starting with your opioids. So before starting opioids, let's take a small break. So I'll give the solution for how to be consistent. And before going to Swapnil Upadhyay's comment, let's go to the previous comment. Sir, what about antimuscarinic usage in Parkinson to minimize the symptom of ACH? We will talk about it right now. Okay. Now, we'll talk about it. Before going there, as you asked, how to be consistent? Very simple. The first rule to be consistent is that you need to determine what is your target. The target is to achieve the exam. Understand, very simple thing. So studying 200 textbooks right now is not going to help you. Studying concisely is going to help you. Okay. So first set a target. The target is what? Exam. Okay. Now, after you set a target, what you need to do? So what you need to do is that first few days you'll feel a difficulty to start studying, or to focus yourself, or deviations. Okay. So please understand, I'm going to tell you something very, very root level way. Okay. So consider you have a problem, financial problem. Consider. Okay. If you have a financial problem, till the day of exam, the problem will be there. After the exam also, the problem is going to be there. Yes, it will be provided. After the exam also, the problem will be there. Okay. So what you need to understand, to solve that problem, you need to have something in your hand. So better go for the exam. So what I'm trying to tell you is that, see, there might be some problem which will be there before the exam also, after the exam also, but the point of the exam will not change. So understand that particular aspect, because you need to prioritize. Your most important priority is to pass the exam. To pass that, the next important key is that you need to be consistent. How to be consistent? You need to determine the target. After you determine the target, what you need to do? The first thing is that, okay, screw every problem in this world. I don't have anything to do with those. My main target is exam. So accept that. Accept that first. To accept that, you'll take time. Not immediately, like I'll close my eyes and I'll tell, okay. No, that is not a technique. Okay. What you need to do, take a time of maybe half day, 1 day. So think about everything. At the end of the day, the major problem will be in front of your eyes is exam. So always focus on immediate problem in front of your eyes. That is your target. So please focus on that particular aspect and go accordingly. The next thing you need to do is that to become consistent, The first few days when you are studying, it will be very difficult. I'll sit in front of a notes and I'll be like, after 2 pages, I'm not able to read. So to overcome that technique, make a timeline of this one. 45 minutes. 45 minutes. Okay. So study for 45 minutes. While you are studying for 45 minutes, don't think about anything. After 45 minutes, you can think about all of your any problem, your girlfriend issue, boyfriend issue, whatever you have, you can think about it. But during those 45 minutes, exclusively focus on study. After 45 minutes, you do whatever you want. Take break. Again, go for 45. So this 45 minutes, why am I telling you people? Because this 45 minutes is an important key factor, because human usually able to focus about 40 to 45 minutes. Utilize that time, immediately take a break. You pay your attention to anything you want, then immediately come back to this. Okay. And one more thing, don't do this preparation of 6 hours straight. Sir, I will sit now and 6 hours straight, I'll sit and study. No, that is not a good idea. What you need to do, you need to divide the timeline. How you need to divide? First, for example, morning you take up your 2 hours of time. Okay. Afternoon you take out of your about 3 to 4 hours of time. Okay. For example, evening. Okay. How you need to take out that? For example, morning before the class, you had some time, go for it. Then next afternoon, you don't have class, do it. Then later come back in the evening and study. So that's how you need to manage. So if you consistently, along with whatever preparation you are doing, apart from the preparation means whatever notes you are studying, apart from that, for your main revision, if you give 6 hours a day, definitely you'll pass, my dear. Okay. That is an important aspect. But without doing that, don't run for the run for the 6 hours. I'll sit and read for 18 hours straight. In 18 hours straight, you'll remember 18 minutes of what you studied. Okay. Rather than that, 1 hour I'll study, I'll take a break. 1 hour I'll study, take a break. 1 hour I'll study, take a break. This will improvise your efficiency like anything. Got it? Okay. So we will come back to our Parkinson. So in Parkinson, what I was discussing to you people about all the drugs used in the Parkinsonism, but let's talk about one important small aspect here, that is your drug-induced Parkinsonism. Drug-induced Parkinsonism. So drug-induced Parkinsonism. Now, this drug-induced Parkinsonism is a very important, because see, we are treating the patient by giving some medication, and those medication will trigger the Parkinson disease. The most important drugs are your antipsychotics. Antipsychotics. Okay. So drug-induced Parkinsonism, what is the cause? One of the important causes is antipsychotic drug. Okay. The next important thing, what you need to do? The next important thing, the treatment for the drug-induced Parkinsonism. So the treatment for the drug-induced Parkinsonism is very easy, sir. What is the treatment? The treatment will be your, for example, we have drugs such as benztropine. Okay. Then we have one more drug that is only called as trihexyphenidyl. So these are the two drugs which are used for drug-induced Parkinson. Done? Okay. Now let's go to the next aspect. We are done with what is that? Drug-induced Parkinson. Guys, wake up and listen to this most interesting aspect. What is that? Opioids. Now, when you are understanding about opioids, okay, now opioids are one of the most important aspect. What is that most important aspect? Opioids are derived from a plant. Okay, so we will provide how to contact me. Don't worry. Okay. Now, first important aspect, opioids. Now, opioids, my dear students, opioids are first naturally derived from the opium plant or a opium plant. Opium plant derived alkaloids. Opium plant derived alkaloids. Okay. Now, these are the opium plant derived alkaloids. Okay. Now, this opium plant, or which is also called as a poppy plant, So you might be thinking, what is poppy? You remember that poppy seeds which used to put in the delicacy of sweets, in all the sweets made all over India, we use these poppy seeds, the white color small seeds. So in many places it's called as kaskas. That plant itself will produce some alkaloids. They are called as opioids. From there, we started to develop the newer drugs and we started to put them into the uses. So first and most important, opioid drugs. Opioids, usually they are opioid agonist. Opioid agonist. What do I mean by opioid agonist? That means they are going to stimulate the opioid receptor. If they're opioid agonist, my dear students, please understand, they're opioid agonist, agreed. So they're going to stimulate opioid receptor. They're called as mu, kappa, and delta. Mu, kappa, and delta. So these are the three receptors which will get stimulated by the opioids. So if these three receptors are there, the effects on the body, it is very important. Effects on the body. What are the effects on the body? Whenever you use a opioid, these are the effects which you are going to get. The first most important effects, write down, those are called as physical dependence, physical dependence, physical dependence. Okay, then there will be one more effect that is only called as meiosis. Meiosis means what? Narrowing of the pupil. So opioid overdose patient will come with narrowed pupil, narrowed pupil. Okay, then there is something called as cough suppression, cough suppression, cough suppression. Okay, then then there is one more effect called as analgesia. What is that? Analgesia. Analgesia means that is to decrease the pain, to decrease the pain. Okay, then there is one more thing, that is only your respiratory suppression, respiratory suppression. Now respiratory suppression and cough suppression might sound same way. For cough suppression, you need to remember one important aspect, that is there is a drug, that is your codeine. We'll come to that. But apart from that, there is one more thing for which people are taking IV opioids and people are getting addicted, that is only your euphoria. What is that? Euphoria. After euphoria, patient will get the sedation. What is that? Sedation. So how to remember the effects of opioids with the help of a mnemonic? So what you need to do, just highlight the first letters, P, M, C, A, R, E, S, called as PM cares. PM cares. So these are the effects. PM cares is the effects which we are going to get as a result of opioids. For C, you can put one more effect here. They will also cause, my dear students, constipation. What is that? Constipation. What is that? Constipation. So these are the these are the effects which you are going to get as a result of your opioids, as a result of your opioids. Okay, now so all the drugs which you have opioids, which I am going to use in the clinical practice, we are going to use these effects. There is there is one thing I want to finish it off here only. For the cough suppression, what is that? Codeine. What is that? Codeine. Codeine is a drug which was used for the dry cough, which was used for the dry cough. Today's timing, in today's reality, we are not going to use your, what is that? Codeine. Codeine is not used because of its excessive addiction property. And where did I teach about codeine yesterday? Please tell me. Let's see. Let's see. Let me look at the comments. I want you people to answer. Where did I teach about codeine yesterday? See, dry cough, we have opioid analog, we have dextromethorphan, which we are using right now. But codeine, I want you people to answer. I told you people about codeine, some one particular aspect about codeine. Codeine, in biotransformation, codeine will get converted. So codeine is an active drug which will give rise to an active metabolite called as morphine. Active drug to active metabolite. Active drug to, it's all right now. Remember, active drug to active metabolite which will be converted from the codeine, that is your morphine. Morphine is the active metabolite of codeine, which is having excessive addiction property, which we don't use it in the clinical practice anymore. Let's continue to the next important. We have drugs. The first important aspect, opioid agonist. Opioid agonist. We have drugs such as morphine. We have drugs such as morphine. Okay. We have drugs such as fentanyl. We have drugs such as fentanyl. Apart from morphine and fentanyl, is there anything else? Yes, there are other drugs also. Other drugs also, such as pentoxazocaine. Okay, then you're also having, what is that? You're also having one of the most important aspect, that is your, what is that, my dear students? That is your, what is that? Your codeine. Codeine also falls into the same class. But why am I writing this? Please remember, morphine is a type of prototype opioid. What is that? Prototype drug. Prototype drug means what? It will stimulate, of course, all the three receptor, mu, kappa, and of course your delta. So if your stimulating all these three receptors, we are going to call it as what is that? Prototype opioid. So prototype opioid, if I ask you people, the most important answer is your morphine. The next important question which was frequently asked just because of this reason only, so the next question is that fentanyl. Fentanyl is a type of synthetic opioid. Fentanyl is a type of synthetic opioid, and remember, fentanyl is available in the form of a patch, available in the form of a transdermal patch. And the most important question, this is the most potent, this is the most potent opioid, so this is a very important question to be remembered. What is that? That is your, please remember, that is your most potent opioid, that is your fentanyl. The question was asked at least 4 times in last 2 to 3 years itself. So please remember this particular aspect. Morphine is a prototype, fentanyl is a synthetic and very strong. Apart from that, we have one more drug, that is your meperidine. Agreed with you. Let's go to the next important agonist uses. Where do we use these drugs? So uses are very important. So my dear students, the first and most important use of these drugs for the pain management. For what? Pain management. What is it? Pain management. Okay, sir, pain management, what you are trying to tell us? So for the pain management of such as trauma, if a patient with trauma, we can use them. Patient with a myocardial infarction, we can use these drugs for the pain management, not drug of choice, but for the pain management. Okay, now remember, these drugs also used in the pulmonary edema, also used, but not a drug of choice. Yes, they are used in the pulmonary edema. Remember, especially which drug, if I ask you people, able to understand morphine, you need to able to tell the answer. So morphine is better used for what? Used for the pulmonary edema. Okay, apart from that, my dear students, these ones are also used for the surgeries. Okay, during the surgery for the analgesia, we can use this drug. Apart from that, there is one important aspect. What is that? These can be used for the painless labor. So there is some techniques which we are doing these days. What is that? Without pain, we are trying to deliver the baby. For that painless labor, we can use it, we can use this drug. But if they are used, they can cause prolongation of which stage of labor? Anybody tell me? Prolongation of which stage of labor? Tell me, how many stages of labor are there? How many stages of labor are there, and prolongation of which stage? How many stages of labor are there? So there are 4 stages of labor. In that 4 stages of labor, which stage will be prolonged? It is lead to the prolongation of second stage of labor. Second stage of labor. Very good. Total 4 stages. According to WHO, after delivery of the placenta, sometime monitoring is there. 4 stages should be there. Okay, so it will prolong the second stage of labor. This can be an MCQ which can be asked, so be prepared. Now, next important aspect. So apart from this, for any pain management such as cancer induced pain, for all those cases, we are going to use the opioid agonist. Now, we have one more thing. They are called as mixed agonist and antagonist. Mixed agonist and antagonist. Now, what is this mixed agonist and antagonist? Now, please understand mixed agonist and antagonist. So we have mu receptor, kappa receptor, delta receptor. In one location, it will be agonist, means in one receptor. For example, it is agonist to mu receptor, but it will be antagonist to, which will be antagonist to other kappa and delta receptor. Like that kind of action, mixed action will be there. So the drugs are there. There are drugs. One of the most important drug you need to remember. What is that? Buprenorphine. What is that? Buprenorphine. This is a very important aspect. And again, you are going to write one more drug. It is pentazokine. So pentazokine, you people might have studied there also, but here also pentazokine having a major activity, that is mixed activity is there. Okay, so please understand. Okay, now please listen to me very carefully. These drugs, where do we use these drugs? Where do we use this drug? They are again used for the pain management. Okay, now there is one confusion. Sir, buprenorphine, can we use it in smoking cessation? No, sir. It is a bupropion. Bupropion is used for smoking cessation. Okay. Then let's go to the next important aspect. We have one drug. There we have one drug, that is methadone. That is methadone, my dear students. Methadone is a opioid used for treatment of opioid addiction. What is that? opioid addiction, opioid addiction, opioid addiction. Okay, remember, opioid addiction treatment, we are going to use a drug methadone, we are going to use a drug methadone. Okay, now let's go to the next aspect. What is that next aspect? So the next important aspect, apart from methadone, we are going to go to the next important aspect, that is opioid antagonist. What is that? Opioid antagonist. What are opioid antagonist? Opioid antagonist is nothing but they're going to block the opioid receptors. So opioid antagonist, we have drugs such as naloxone, and we have one more drug called as naltrexone. What is that? Naltrexone. So we have two drugs, naloxone and naltrexone. These are the opioid antagonist. What are the uses of these drugs? Uses of this drug, they are used as an antidote. See, antidote for opioid overdose, opioid overdose. Okay, so for the opioid overdose treatment, we are going to use this drug, especially which drug? Now I will tell you people, please listen to me. First thing, opioid overdose, what are the clinical features? Okay, tell me the clinical features of a opioid overdose. The opioid overdose, there is a decreased respiratory rate, then there is a meiosis, that is constriction of the pupil. It can go even to a level of pinpoint pupil. Okay, then the next important symptoms which can be present, that will be your loss of consciousness, So opioid overdose treatment, IV, what is that? IV naloxone, why IV naloxone? Because it is a short acting drug, and it is a fastest acting drug. So you need to understand and remember. Apart from that, naltrexone is used for the opioid addiction management. What is it? Opioid addiction management. That is especially which drug? Naltrexone, which is also available in the form of a tablets. Okay, so among this, what are the three important things I want you to remember? These three things, if you know, definitely one of the question will be from here only. Which is the most potent opioid? Fentanyl. Which is the prototype opioid? Which is that? That will be your morphine. Then which drug is used for the opioid withdrawal management? Opioid withdrawal long-term management, we are going to use best drug is methadone. Apart from methadone, we can use naltrexone. And opioid overdose treatment will be naloxone, which is IV naloxone. So the question will be, what is the antidote for opioid overdose? Or they can ask you people, opioid drugs are agonist or antagonist? Because opioid drugs are opioid receptor agonist, the treatment will be opioid antagonist. So this might confuse you people, because all of us studied opioids, so that will confuse. That is why examiner will put a trap for us. So what we need to do, my dear students, opioids are opioid agonist, that overdose treatment is antagonist. Will you be able to solve all this? Everybody clear so far? Okay, now once you understood about opioids, then let's continue to the next aspect. What is that next aspect? So let's go to the next important aspect, my dear students. They are called as antipsychotics. Now when you want to learn about antipsychotics, see, alcohol dependence, yes, we can use them, but there is other steps of management in alcohol dependence, but we can use opioid antagonist. That is not a main antidote, guys. This is not a main antidote. Antipsychotics. Now, when I want to teach you people about antipsychotics, okay. Now, antipsychotics is an easier topic for you to understand, easy to learn. So, look and understand what is antipsychotic drugs. Now, during this thing, you need to understand one of the most important aspect. What is that? What is a psychosis? What is a neurosis? What is a neurosis? What is psychosis? What is neurosis? Tell me. Some people will tell psychosis zyada pagal, neurosis kam pagal. Don't tell me this type of, okay. So what is the difference between a psychosis and neurosis? In both of these people, psychomotor agitation will be there, but one important aspect, that is about insight. What is that? Insight means what? If you tell the person that you are having some mental instability, he is ready to listen to the person that he is having some mental instability. If I tell you, okay, you have some mental instability, so you need to get treatment, that means if he is able to understand, that is called insight. Insight is present in the neurosis. Insight is absent in the psychosis. Insight is absent in the psychosis. Okay, very good, very good, very good, very good. Okay, now the next important aspect, there is a theory that for the psychosis, what is that? There is an increased level of increased dopamine. That is a theory. Increased dopamine can be present in the psychosis. That is a theory. So for that only, we are going to use your antipsychotic drugs. Antipsychotic drugs are divided into two types. What are those antipsychotic drugs? Usually, see, if dopamine is more, what we need to do, the target for us is that to block the dopamine receptor. That was the target. To block the dopamine receptor. That is a target. So if you want to block the dopamine receptors, let's see what you can do. So we have two types of antipsychotic drugs. What are the two types? We have something called as typical antipsychotic drugs. Typical antipsychotic drugs. Then we have one more thing called as atypical antipsychotic drugs. Okay. Now understand atypical and typical. Atypical and typical. Atypical only antipsychotics are the old drugs. Atypical are the newer drugs. Atypical are the newer drugs. So typical antipsychotics, they block the dopamine receptor. They block the D2 receptor. Along with that, they block the muscarinic receptor. They block the histamine receptor. They block even alpha adrenoreceptors. So when you notice here, are they very much specific? No, they are not specific to the D2 receptor. They are very much non-specific, and they will have a other effects as a result of muscarinic, histamine and alpha receptor. So wide range of inhibition was there. So to overcome that, we are developing newer drugs which are specific, but are they selective? They are less they're selective, but they're having less side effect compared to that of old ones. They usually typically block which receptor? They usually typically block T2 receptor. Along with that, they can also affect 5-HT, that is serotonin receptor. Okay, so what are the drugs we have? The drugs we have are, tell me, let's see, typical antipsychotics. How many of you can tell me? We have a drug called as chlorpromazine. Chlorpromazine. Okay. Then apart from chlorpromazine, is there anything else? Yes, we have one more drug. That is not a typical. So we have something called as haloperidol, my dear students. What is that? Haloperidol. Okay, we have one more drug called as droperidol. Okay, so all these drugs, okay, so we have one more drug, that is thiaridazine. So all these drugs are old antipsychotic drugs. Okay, there is a big list, among which I want you people to remember which are those. I want you to remember chlorpromazine. What is that? Chlorpromazine. Now chlorpromazine is what? Chlorpromazine causes one side effect, that is cholestatic jaundice. Cholestatic jaundice. This is a very important side effect. You need to remember. This can be asked as a MCQ. Okay. Now, apart from that, the next important aspect, see, look here, typical antipsychotics. We have a drug called as clozapine. Okay. We have a drug called as olanzapine. Now all these drugs, you need to remember everything. No, there are some specific things which you need to remember, and it will be done. Okay, so we are doing a review. We do it like a review only. Okay, olanzapine. Apart from that, we have one more drug, that is quetiapine. Okay, now all these drugs, what are those drugs? These drugs are atypical. These are newer drug. We have one more drug called as risperidone. Okay, now my dear students, where do we use them? What are the uses of the antipsychotics? All of us know that uses of the antipsychotics, they are used in schizophrenia, psychomotor agitation. Okay, all the psychiatric positive symptom patients, we are going to use them for the positive symptoms. Okay, but the thing is that I want you people to focus here. They will not ask you the use, they will ask you the MCQs. So what are those MCQs? Look here, very easy. The first and most important aspect, what is the best drug of choice for your resistant schizophrenia? Resistant schizophrenia. The resistant schizophrenia, the best drug of choice, what you can give. Yes, tell me, let's see. Let's see, what is a drug of choice for resistant schizophrenia? The drug is your clozapine. The drug is your clozapine. Okay, the drug is your clozapine. Okay. Now remember, my dear students, the side effect wet pillow syndrome. Wet pillow syndrome. What is that? Wet pillow syndrome. Basically, there is a the patient will take the tablet, he'll sleep, the patient will have excessive salivation, because of which what will happen? Pillow will become wet, called as wet pillow syndrome. It is also caused by your one drug called as clozapine. What is that? Clozapine. Again, remember, it is due to 5-HT action, that is serotoninergic action. There is one more thing. Which drug has a anti-suicidal property compared to the other drug? Anti-suicidal tendency, anti-suicidal property. Anti-suicidal property is possessed by your clozapine. Okay, apart from the anti-suicidal property and all these things, for example, if a patient, pregnant female with psychosis, what is the drug of choice? Pregnant female with the psychosis, the drug of choice is olanzapine. What is that? Olanzapine. What is the name of the drug? Olanzapine, my dear. What is that? Olanzapine. It is a safe drug. What is that? Safe drug. Okay. Now, apart from that, the cataract is a side effect. What is it? Cataract. Okay. Now, I'm talking about MCQs related to side effect. Cataract. Then there is one more thing. Cholestatic jaundice. Cholestatic jaundice. Okay. Then there is one more side effect. That is most deadly one. That is only your egg granulocytosis. Egg granulocytosis. So these are the side effects caused by who? What is that? Which drug? Okay. Okay, let's see what is the question. Did tetracycline can be used in pediatric therapy for diarrhea? Okay, cholera. My dear student, listen to me very carefully. Tetracyclines are absolutely contraindicated in children. Please do not use tetracycline in children. Okay. Let's go to the next important aspect. What is that? That is your agranulocytosis. So these three side effects. Cataract is caused by quetiapine. Quetiapine. Okay. Now, cholestatic jaundice is caused by chlorpromazine. Okay. Agranulocytosis is caused by clozapine. Not clonazepam, clozapine. Okay, cholestatic jaundice, chlorpromazine. So these are the most important MCQs you need to remember from the antipsychotic drugs. And most important, pregnant female, that your drug of choice is olanzapine, and here wet pillow syndrome is caused by clozapine, and rest other uses of the antipsychotics you already know it. Okay, so once we are done with the antipsychotic drugs, let's go to your mood stabilizers. Now, what are these mood stabilizers? So, mood stabilizers, most important mood stabilizers are your lithium salts. Lithium. Okay. So, what are the drugs we have? Such as lithium citrate, for example. We have lithium citrate. Now, these lithium citrate mood stabilizers, where do we use them? The uses are your bipolar disorder. The most important use for the lithium salts is bipolar disorder. Apart from that, we can also use them in acute mania. So in both of these conditions, we can use this drug. What is that? Bipolar disorder and acute mania. We can use which drug, my dear students? Lithium. What is that? Lithium. Now, what is the important aspect for us doctors to remember? That is side effects. The side effects are most important one. They can cause ECG changes. Lithium can cause what? ECG changes. Okay. Apart from that, okay, during COVID, the one drug which could have caused ECG changes and widely used, which was that? Let's see. Tell me. The drug which was used during the COVID pandemic, but it could cause ECG changes. Which drug was that? Hydroxychloroquine, doctors. What is that? Hydroxychloroquine, which would cause a severe ECG changes. Okay. Now, Now, listen to me. ECG changes. Apart from that, it is a type of teratogenic. But the most important thing they will ask you as a MCQ is that lithium is toxic to the kidney. What is that? Toxic? Very good age. That is hydroxychloroquine. Okay. Now, teratogenic, but the most important aspect, they will cause nephrogenic diabetes insipidus. Lithium can lead to nephrogenic diabetes insipidus. For that treatment is a drug called as amyloid. Amyloid is a drug which is used for the treatment of your nephrogenic diabetes insipidus caused by lithium induced one. Okay. Now, most importantly, when you give a lithium, you need to do one important aspect, that is only your TDM. We need to do what? TDM. What you need to do? TDM. What is TDM? You need to do therapeutic drug monitoring. So therapeutic drug monitoring to be done for the lithium. Okay. Remember, what is that? Normally, what is that? Treatment level. For the treatment, what you need to have? Lithium should be about 0.8 to 1.2 milli equivalents per liter. Okay. Then, for example, if you are using it as a prophylactic usage, prophylactic means if you are preventing the symptoms of, for example, BPD, then it can vary up to 0.6 to 1.6. 0.6 to 1.6. If it is more than 2, then it is a toxic range. So you need to maintain below here only. Okay. So therapeutic drug monitoring means you are going to measure the drug level. You are going to measure what? Drug level in the body. So the TDM is done for drugs such as, can anybody tell me? TDM can be done for what are the drugs? This question was also asked. TDM is done for drugs such as phenytoin. TDM is done for drugs such as digoxin. Then TDM is also done for lithium. All these conditions. So they can ask you, all of the following drugs require therapeutic drug monitoring except, so if we have 3 drugs, you need to remember even for the heparin, unfractionated one. Okay. Now, once we understood about this, let's go to the next important drugs. Shall we go? Able to understand? First, let me see. Are you people able to understand? Follow me. Yes or no? Okay. Now, if there is a lithium toxicity, guys, lithium toxicity is there, the better treatment we would go for a dialysis. Okay, let's go to the next aspect. The next aspect, what is that? The most important aspect which you need to learn about is anxiolytics. And hypnotics. Now, anxiolytics and hypnotics are very easy but very important. So, what exactly you need to understand? Guys, you have one of the neurotransmitter, that is your inhibitory neurotransmitter. What is that inhibitory neurotransmitter? That inhibitory neurotransmitter you have is GABA. What is the full form of GABA? Gamma aminobutyric acid. Now, GABA is derived from which neurotransmitter? GABA is derived from what? That is, GABA is coming from a glutamate. It will undergo a reaction called as decarboxylation, will give rise to GABA. Okay, gamma aminobutyric acid. Now, it is a type of inhibitory neurotransmitter. How exactly it works, you need to understand. Consider this is one neuron and here is one more neuron. Okay, now, my dear students, this neuron will release the GABA. Will release what? GABA. Will release what? GABA. Okay. Now this GABA will go and act upon the GABA receptor. As soon as GABA receptor is stimulated, it will allow the entry of chloride ions, which will cause the hyperpolarization of the neuron. Okay. Now, okay. Let me change. Okay, now it will cause the hyperpolarization of the neuron. So if there is a hyperpolarization, automatically neuron will not get excited, leading to what? Sedation. Leading to what? Sedation. Now the important thing you need to understand, my dear students, you understood about this so far very well. Okay, now we have some drugs. We have two groups of drugs. One of them is called as benzodiazepines. Benzodiazepines. Okay, now benzodiazepines and one more group of drugs are there, barbiturates. Barbiturates. Okay, so there are two groups of drugs, benzodiazepines and barbiturates. What are these two groups of drugs? Benzodiazepine and barbiturates, they act upon what is that? They both act on which receptor? Act on the GABA receptor. Act on the GABA receptor. But the most important aspect you need to remember is that they act on the GABA receptor, but they have different type of action. What is that? Benzodiazepine. What is that? Increase the frequency of opening. Increase the frequency of opening. What do I mean by this? I'll tell you, people, listen to me. Very easy. Benzodiazepine will go and bind with what is that receptor? GABA receptor. Again, GABA receptor will open, close. So frequently, again and again it will open. Again and again, if it opens, what will happen? Again and again open, again and again chloride ion entry, again and again chloride ion entry, hyperpolarization. Now, barbiturates, what will happen? Increase the duration of opening. Increase the duration of opening. Okay, increase the duration of opening. This is an important aspect you need to remember. One of them will increase the duration. So for a long time, who will work? Barbiturates. Again and again, who will work? That is opening, that is benzodiazepines. Okay, now when you look at these two things, yes, both of them will cause an addiction. Both of them will cause an addiction. So it will also cause addiction, but barbiturates addiction will be more higher. So barbiturates will cause more addiction compared to benzodiazepines. Okay. Now, next important aspect, both of these drugs, when you look at these drugs, they will cause hangover. Yes, they will cause hangover. Yes, benzodiazepines will cause hangover a little bit, but barbiturates will cause more of hangover. These are some differences which you need to remember. Now, when you're looking at these drugs, what are the uses of this anxiolytic and hypnotics? So the most important use is your insomnia. What is that? Insomnia. Okay. So insomnia patients can use, what is that? That is your benzodiazepines. Okay. Apart from insomnia, there is one more thing, that is your delirium tremens. What is that? Delirium tremens. Now, delirium tremens are what? Delirium tremens are seen with the alcohol withdrawal. Now, if there are alcohol withdrawal, during the alcohol withdrawal, patient can develop delirium tremens. Okay. Now, the next important aspect, see, the most important thing you need to understand, apart from delirium tremens, where else we can use them? They can use them in the treatment of anxiety. What is that? Anxiety and even for the panics, little bit. Anxiety and panics. Okay. Now, the next important aspect, see, delirium tremens covers here. Okay. The most important aspect, they're used for the seizures. Seizures treatment also we are going to use, what is that? That is your anxiolytic and hypnotic drugs. Okay. Now let's understand what are the drugs we need to know. Okay. We have benzodiazepines, right? Benzodiazepines, BZD, benzodiazepine, we have drugs such as diazepam. What is that? Diazepam. Okay, we have one more drug that is called as lorazepam. Now again, there are MCQs here. I want you people to understand lorazepam. Apart from lorazepam and diazepam, we have one more drug. What is that? That is your alprazolam. Alprazolam. Okay. Apart from alprazolam, we have one more drug that is only your called as clonazepam. What is that? Clonazepam. Okay. Apart from clonazepam, there is one more drug that is only called as midazolam. Okay. So these are the few drugs. So there is a long list, but these are the widely you need to remember these drugs. Okay. Now listen to me very carefully. Lorazepam is used drug of choice for status epilepticus. Okay, now please understand, diazepam is the drug of choice for status epilepticus. If not in option, not in option, if not in the options, then you can mark midazolam. Okay, so this is the importance you need to understand. Okay, so please listen to me. If that is not their drug of choice is lorazepam. If that is not there, you can go for midazolam. Clinical practice, especially in the government setups, usually the available drug is midazolam. That is what we are going to use. Okay, now diazepam, alprazolam, other things, they are used for insomnia, but diazepam also works as a myorelaxant. What is that? Myorelaxant. What is that? Myorelaxant drug. It also works as a centrally acting myorelaxant drug. Okay. Now, alprazolam and clonazepam usually used for insomnia. Usually used for insomnia. Okay. Now the thing is that, for example, so now listen to me very carefully. When you're learning about what is that benzodiazepines, so diazepam is there, lorazepam is there, alprazolam is there, clonazepam is there, midazolam is there. Among all these drugs, see, we have different drug kept for different uses. Okay, which benzodiazepine is used for the used for the myorelaxation property? Then it is your diazepam. Okay, now most importantly, you need to understand. For example, some patient overdosed. What is it? Overdosed with your benzodiazepine. What will be the treatment? Tell me. So, antidote for benzodiazepine. Let's see. Okay. Tell me, let's see. So, very good. That is your Flumazenil is the antidote for benzodiazepine overdose. For opioid overdose, naloxone. Okay, antidote for benzodiazepine overdose is your flumazenil. Okay, now here only let's see, where do we use this famiprazole? Where do we use? So if you have some difficulty with watching the video, try reloading the video. Okay, it is used for. We'll come to barbiturates. Okay, now tell me, famiprazole is used for antidote for what? Antidote for alcohol. Antidote for alcohol. You might be thinking, yes, for ethanol toxicity we can use famiprazole. For methanol toxicity we are going to use ethanol. Okay, remember. Okay, let's go to the next important aspect. What is that? Let's talk about the barbiturates. What is that? Barbiturates. Now, when I'm talking about barbiturates, we have drugs such as phenobarbital. What is that? Phenobarbital. My dear students, phenobarbital or phenobarbital is a very important drug. I'll tell you why. Phenobarbital, then there is one more drug called as thiopental. That is thiopental. This thiopental is used in the anesthesia and it is also used in one more place. Let's look at here. It is used as an induction agent. Again, clinically not widely used. Induction agent in anesthesia, but clinically not widely used. Nowadays, thiopental is majorly used as a truth serum. Truth serum. What is that? Truth serum. Truth serum is a combination of two drugs. What is that? Hyoscine, that is scopolamine, which I told you. Hyoscine plus thiopental. Okay, so these are the drugs. What is that? For the truth serum. Okay, now phenobarbital is a type of drug which is used for epilepsy, and I'll agree with you people, but listen to me very carefully, my dear students. What is that? Phenobarbital is also used. It is a type of inducer, right? It is a type of enzyme inducer. Okay, so I told you about the use of the midazolam. Midazolam, I have written it here only in the patient with a status epilepticus. We are going to use midazolam if what is not there, lorazepam is not there. Okay. Now, inducer. If it is an enzyme inducer, my dear students, you need to remember it is used for one disease called as Crigler-Najjar syndrome. Najjar syndrome. In the patients with the Crigler-Najjar syndrome, there is a wide range of treatment that includes your phototherapy, etc., etc. Along with that, we can consider use of one drug, that is your phenobarbital. Okay, there are other drugs such as secobarbital and all, so that are not so important. Let's continue to the next aspect. So the next important aspect, guys, we are going to learn about the anti-epileptics. What is that? Anti-epileptics. So anti-epileptics are the drugs which are used in the treatment of epilepsy. So when we are talking about epilepsy, let me tell you about the epilepsy very quickly right here. Okay. Now when you're talking about epilepsy, so epilepsy, before going to epilepsy, you need to understand one thing. What is that one thing you need to understand, guys? See, patient will have a seizure. If there is a repeated episodes of the seizure, then we call it as epilepsy. If there is a repeated episodes of the seizure, we call it as a epilepsy. So it is a syndrome, it is a disease in which repeated episodes of the seizures are there. Now, if the patient is getting seizure, there are multiple causes such as stroke, such as idiopathic causes, such as trauma. Okay. For example, vitamin deficiency, such as calcium deficiency, such as fever, all these things, fever in the children leading to febrile seizure. Okay, in all these cases, we call it as a seizure. Now, seizure, if there is a repeatedly, then we call it as, what is that? Epilepsy. Now, a patient with epilepsy, what exactly you need to understand, guys? We need to treat the patient with epilepsy. So, to treat the patient with epilepsy, understand one thing here. What is that? Guys, there is a neuron. Okay. Now, this neuron will produce one neurotransmitter. What is that? One neurotransmitter. What is that one neurotransmitter it is producing? Let's see. Okay. The neurotransmitter it is producing, let's consider it is producing your glutamate. What is it? Glutamate. Now, this glutamate can go and act upon, what is that? That can act upon its receptor, glutamate receptors. What are the glutamate receptors we have? Receptors such as NMDA and AMPA receptor. Which are those receptors? NMDA and AMPA receptor. Okay. Now, NMDA and AMPA receptor, what they will do? They will allow the entry of calcium ion and they will allow the entry of sodium ion. If calcium and sodium ion comes into a neuron, neuron will get excited. If neuron gets excited, what will happen? Let's see. Let's come back to the epilepsy. So, for epilepsy, you need to understand seizure. So, seizure is what? It is an abnormal neuronal discharge. Abnormal neuronal discharge. If there is an abnormal neuronal discharge, what exactly it is going to happen? Guys, there is an abnormal neuronal discharge because of which there is an excessive excitation of the neurons. So, we need to block that. We need to do what? Block that. Okay. So, excessive activation of the neuron, that is leading to seizure. Okay. So, what you can do? What you can do is that understand if there is an increase of stimulatory neurotransmitter such as the glutamate, or if there is a decrease of what is that? That is your inhibitory neurotransmitter means, see, stimulatory, inhibitory, both of them balance. What should be there? Balance should be there. Now, what will happen? One of them, inhibitory, consider this inhibitory will go down, stimulatory will become more, automatically it might lead to epilepsy. So, the treatment target we are going to play with the neurotransmitter, that is the target. Okay. Now, there is a decrease inhibitory. Now, what is that? They can lead to, what is that? They can lead to seizure. Okay. If they can lead to seizure, now what exactly we need to do? So, we have sodium channels. We can block the sodium channel. If you block the sodium channel, what will happen? Sodium is blocked. If sodium is blocked, no entry of sodium. If there is no entry of sodium, then automatically there is no excitation of the neuron. That is the one way to treat. Then there is one more way. Calcium channels can be blocked. But I want you to understand, guys, let's go back little even more depth. What is that? So this glutamate, if it has to be released, it was stored here inside a synaptic vesicle, Upon this synaptic vesicle, there is a protein called as SV2A protein. There is a protein called as SV2A protein. Now remember, the neuron will get excited. Okay. Now the that is excited electrical activity comes, which will allow the entry of calcium ions. Now after calcium ion entry, it will go and act upon what is that? synaptic vesicle. Now this synaptic vesicle will use the help of this protein called as SV2A. After that only glutamate will be released. Now that will go and stimulate the receptor. This is the summary of the neurons activity. So let's look at the anti-epileptic drugs. So first important thing, what is that? SV2A blocker or inhibitor. SV2A inhibitor. Tell me, what is that SV2A inhibitor we have? So where is SV2A? All of you know that. So what is that SV2A inhibitor we have? What is the SV2A inhibitor we have? Let's see. Take a guess. So SV2A inhibitor, what we have is, my dear students, that is only your levetiracetam. What is that? Levetiracetam. Levetiracetam. This levetiracetam is a drug which is what? SV2A inhibitor. What is that? SV2A inhibitor. Now this is very important because guys, understand, this can be used to prevent the seizure. It can be used to prevent the seizure. Prevent the seizures means a patient comes to you with a head injury. You know that patient can get, what is that? Seizure. So to prevent that from happening, you can give a levetiracetam. What is that? Levetiracetam comes under brand name Levipil. Okay, comes under brand name Levipil. Okay, now, now this levetiracetam, also understand one more thing. So please listen to me. Levetiracetam is a drug of choice for what is that? Pregnancy female with epilepsy, with the epilepsy. So if a pregnant female is having epilepsy, now you can give which drug? Levetiracetam. Levetiracetam, if not in the option, if not in the option, then what you are going to give? If that is not in the option, then you are going to use a drug called as lamotrigine. What is that? Lamotrigine. So remember, the best drug is so today's we are going to use levetiracetam. Earlier we used lamotrigine. Now you can consider them as equally effective, but so we are going to consider this as a better drug compared to that of lamotrigine. This is a story you need to remember. Okay, now now we have something. What is that? That is your sodium channel blocker. Sodium channel blocker. Now, sodium channel blockers, we have drugs, my dear students. Drugs such as one of the most important drug, that is your phenytoin. What is that? Phenytoin. What is that? Phenytoin. Apart from phenytoin, then we have one more thing, that is your sodium valproate. Sodium valproate. There is one more drug, that is your lamotrigine. Just now I told you people. What is that? Lamotrigine. Then there is one more drug, that is carbamazepine. What is that? Carbamazepine. Carbamazepine. Then there is one more drug, that is oxcarbazepine. Oxcarbazepine. Now, when you look at all these drugs, my dear students, what you need to understand? You need to understand there are some important MCQs which are related to each drug. Okay. Now, remember this. Phenytoin. What exactly it will do? My dear students, it will inhibit an enzyme called as collagenase. It will inhibit an enzyme called as collagenase. What is that? Collagenase. Okay. So it will inhibit an enzyme called as collagenase. So since it inhibits an enzyme called as collagenase, it will cause one side effect called as gum hyperplasia. Gum hyperplasia. Now, you people might have read about this phenytoin, which improves, what is that? Which improves wound healing, promotes the wound healing. Again, that is because of the enzyme. What is that? Collagenase. Which enzyme? Collagenase. If they ever ask you a question for you people, the phenytoin causes gum hypertrophy, gum hyperplasia, because of which effect? Because of inhibition of an enzyme called as collagenase. Because of an enzyme called as collagenase. Now, apart from that, guys, let's look at the next important aspect. What is that? You have phenytoin. Now, this phenytoin will cause one more side effects. Let's look at the side effect. Other side effects. It will cause megaloblastic anemia. It will cause megaloblastic anemia. Megaloblastic anemia. It will also cause vitamin K deficiency. Vitamin K deficiency. Now, apart from that, if used in a pregnant female, it can lead to something called as fetal hydantoin syndrome. Fetal hydantoin syndrome. So this can be the side effects which can be caused as a result of fetal, that is your phenytoin. Okay, now if you have a phenytoin overdose, my dear students, what is that? So somebody told ataxia. Now I'll come to that ataxia point. That is, if the patient is having a overdose of phenytoin, then you are going to have ataxia as a side effect or ataxia as a clinical feature. Now sodium valproate. Now sodium valproate also causes some side effect which is very important to be remembered. What exactly is that? That is, my dear students, that is, it will increase the risk of PCOD. It will increase the risk of PCOD, and it will also increase, it will also cause weight gain. 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 Clear? Thank you. Now, let's go to the next aspect. What is that next aspect? The next important aspect, guys, you need to understand what exactly is that. Lamotrigine can be safely used for pregnant female. Agreed? Now, carbamazepine is a type of enzyme inducer. These are the quick review points which you need to know, must and should, from these drugs. Okay. Now, I told you people that let's go for calcium channel blockers. Calcium channel blockers. Now calcium channel blockers, guys, please understand, calcium channel blockers are easy to remember. We have a drug called as ethosuxamide. What is that? Ethosuxamide. Ethosuxamide. Guys, please listen to me. Ethosuxamide. Now, ethosuxamide is a very important drug. If the patient age, if patient with absent seizure, can anybody tell me what is absent seizure? Let's see. Describe absent seizure. Describe an absent seizure. So absent seizure is seen where exactly? Guys, listen to me very carefully. Absent seizures are seen with children. Absent seizures are seen with what? Children. Absent seizures are seen with children. Okay, absent seizures are seen with children, but please understand, okay, patient stops for a few seconds, then comes back. It occurs in kids, loss of consciousness for a few seconds. So please don't tell this loss of consciousness as completely, because loss of consciousness means patient might fall down. So what happens is that, look here, understand, what happens is that, so for example, a small child of, for example, 4 or 5, 6 years age, he'll be sitting in the classroom. Now, he will not fall down. You are right. There is no awareness about the surrounding. That part you are right about the consciousness. But complete loss of consciousness means he should fall down. That is not going to occur. Okay. So what happens here? So a child will be sitting like this. Teacher is telling the class. The child will be like this. He'll be having open eye. He'll be looking at the teacher, but nothing is getting registered. He'll be looking like that only for few seconds. Again, he'll come back to normal. So during those seconds, what happened, you don't know. Okay. Now, how will this come? How will these patients will come? Okay. Now, how these patients will come is very important thing is that, so the poor school performance, mother will bring the child saying that teacher complains about the poor school performance and he's having some, what is that, zone out. He'll be like, in his own world for a few seconds, then he'll come back. Zone out for a few seconds, come back. It might occur up to 35 to 40 times or even up to 50 times a day. That type of seizure we call it as a absent seizure. Okay. Now, when there is this condition, if the age is, you look at the age, if the age is less than 2 years, there is a different treatment. If it is more than 2 years, then what is the treatment? If less than 2 years, you are going to use ethosuxamide. What is that? Ethosuxamide. Okay. Now, if it is more than 2 years, valproate. More than 2 years, valproate. So this is a very important MCQ which is asked. Okay, very nice. So is it just a complete loss of consciousness or loss of attachment with the reality? But the patient psychomotor knows, like, there is no motor symptoms, only and only he'll be having these blackouts. This is a very important question because on the day of exam, the examiner will describe the case and you people will go quiet. So this should not happen. Okay. So let's continue to the next important aspect. What is that? That is your anti-epileptics. But let's talk about the other drugs. What is that? GABAergic drugs. What is that? GABAergic drugs. What is this GABAergic drugs? These drugs will work with the help of GABA system. All of you know one drug which we already discussed, benzodiazepines. Apart from benzodiazepines, We can also use barbiturates. Barbiturates. Apart from this, my dear students, I want you people to understand there are other 2 to 3 drugs you need to understand. So consider this is one neuron, consider this is a second neuron. Okay, now this is which neuron? This is a GABA neuron. Okay, this is a GABA neuron. How this works? How this works? Let's understand. Okay, now whatever GABA is there, it will be released. Okay, GABA is released. Now GABA will do its action of what is that? Stimulation of GABA receptor, allow the entry of chloride ions, which we already know. Now let's go to the next aspect. What happens? This GABA is this GABA is taken up by GABA transporter. GABA transporter. Okay, now GABA comes into the neuron. This GABA can be metabolized into metabolites by an enzyme called as GABA transaminase. So what are the 2 things you need to focus here? Guys, one of them is there, GABA transporter. One more is GABA transaminase. GABA transaminase. So we have a drug that is your GABA transaminase inhibitor. What is that? GABA transaminase inhibitor. Can anybody tell me the name of the drug? GABA transaminase inhibitor. Let's see. Okay, tell me, GABA transaminase inhibitor. What is the name of the drug? Not valproic acid, my dear. Not valproic acid. GABA transaminase inhibitor. The name of the drug is your, what is that? Vigabatrin. Vigabatrin. What is that? Vigabatrin. What is the name of the drug? Vigabatrin. Okay. Remember, what is that? GABA transaminase inhibitor. GABA, here we have GABA, TR for transaminase, IN for inhibitor. Vigabatrin, GABA transaminase inhibitor. Please don't get confused. I knew that most of us get confused between tigabatrin and vigabatrin. Very good. Whoever said vigabatrin, you are right. Vigabatrin. What is that? Vigabatrin. Now, vigabatrin is what? It is a GABA transaminase inhibitor. The name itself has GABA, TR for transaminase, IN for inhibitor. Okay, now how to remember one more aspect? It will cause one side effect. What is that? Side effect. That is visual disturbance. What is that? Visual disturbances. My dear students, visual disturbances. Again, here only look back and understand. VI for visual disturbance. You can remember it. Clear? Now, I'm not talking about some special scenarios here because I want to put those into one place where there is so many MCQs. Okay. Now, GABA transporter is inhibited by a drug called as tigabine. What is that? Tigabine. Clear, everybody? So these are the drugs we have. Okay. Now there are other drugs which acts with the GABA system. We have drugs such as pregabalin, and there is one more drug. What is that drug? Pregabalin, and there is one more drug. That is your gabapentin. What is that? Gabapentin. Okay. Now these 2 drugs are usually used for what? Listen to me. They are neuroprotective. Since they are neuroprotective, they are used for what? Used for neuropathy. Which neuropathy, my dear students? The neuropathy that is your, for example, peripheral neuropathy caused by diabetes mellitus patient. We are going to use this drug. That is your pregabalin and gabapentin. We have other drugs such as vigabatrin and tigabine. So all the anti-epileptic drugs are done. Now we are going to study about some special scenarios. What are those special scenarios? The special scenario number 1. What is that special scenario number 1? That special scenario number 1 is your febrile seizure. So febrile seizure is caused by fever. Okay. So caused by fever seen in children. Okay. Now please understand, to prevent this from occurring, what you need to do? If seizure already present, what you need to do? If seizure already present, what you need to do? If at all, to prevent, what you need to do? So if you need to prevent the seizure, which seizure? Febrile seizure, to decrease the fever, to decrease the fever, to decrease the fever. So basically antipyretic drugs to decrease the fever, so seizures won't develop. Okay, very good. Now, if there is seizure which is already present, then you are going to use what is that? Per rectal diazepam. Per rectal diazepam. Per rectal diazepam. Okay, so please understand if seizure is already occurring as a result of fever, to treat the seizure you are going to use what is that? You are going to use per rectal diazepam. Then apart from that you need to rule out the causes. Of course, what are the rule out the causes? Because if fever is there, fever is causing the seizure, that might be fever itself or meningitis, that is a pediatric approach, I agree. But the thing is that if I ask anybody ask you what is the febrile seizures drug of choice, your answer should be always you need to go for a per rectal diazepam. Okay, per rectal. In kid you find an IV, it is very difficult in an emergency case scenario, so that is why we prefer per rectal. Okay, let's go to the next aspect. What is that next aspect? See, if a patient comes to you with a seizure and fever and there is some neck pain and all, you can rule out meningitis. But the most important aspect is that you need to control the seizure immediately, then you do all the diagnostics. Let's go to the next aspect. Then pregnant female. Your most important pregnancy. Now most important and most confusing for everybody. Okay, understand. Now I'll break this complete confusion of yours in 1 minute. How exactly? Guys, very simple. Okay, what is that? Very simple. That very simple aspect is that, guys, if the pregnant female with epilepsy, that is one scenario. Pregnant female with epilepsy. Then there is one more scenario. The pregnant female who is having a hypertension plus proteinuria plus your seizure. Now, these three things, if they are present, we call it as eclampsia. We call it as eclampsia. Okay, if pregnant female is having just epilepsy, for example, imagine before pregnancy also she was having seizure. Now she became pregnant. Now what is the drug to be given? See, pregnant female before pregnancy she used to get the seizure. Now she became pregnant. After pregnancy we need to change the drug. Okay, so what exactly is that? Pregnant female with the epilepsy, the best ones are levetiracetam. If levetiracetam is not there, lamotrigine. Okay, now the next important, if that is also not there, then carbamazepine. These are the three drugs. Next, eclampsia is there. Then what you are going to give? IV MgSO4. What is that? IV MgSO4, magnesium sulfate. Okay, this is how you are going to treat the patient. Okay, levetiracetam, lamotrigine, carbamazepine. See, guys, actually speaking, levetiracetam and lamotrigine said to be having similar effect in the pregnant female, but you can go for, if all of them are given, the best answer would be levetiracetam, then go for lamotrigine. Got the clarity? Okay. Now, after you understood about the pregnancy, then there is one more important aspect. What is that? If the patient is having a generalized tonic-clonic seizure, GTCS. If the patient is having a GTCS, best drug is valproate. After that, valproate, if that is not there, then you can go for lamotrigine. Okay, so these are the all important aspects which are related to your, what is that? Which are related to your most important aspect of your central nervous system's epilepsy. So we are left out with one topic, that is your antidepressants. Again, many questions were asked, so let me teach you people. Now, before going there, let me tell you people, dopamine. Dopamine in central nervous system, dopamine in the central nervous system. Okay, sorry guys. Now, when you want to understand dopamine in the central nervous system, let's understand it. So please focus your attention here. Dopamine will go and trigger D2 receptors in chemotrigger zone. Will go and trigger D2 receptors in the chemotrigger zone, which will cause vomiting. Okay, so anytime if you are getting vomiting, one of the reason, I'm not telling always, okay, for example, you are going in a, for example, all the weird rides, okay, that is taking you reverse and all that time, that is not because of dopamine, that is not because of chemotrigger zone, that is because of vestibulocochlear apparatus. Okay, so that is the thing. So one cause for vomiting chemotrigger zone is your dopamine. Okay, the next important aspect, dopamine will, if dopamine, what exactly it works, it will if at all dopamine receptor D2 receptors are stimulated, if D2 receptor are stimulated, then it will decrease the prolactin production. It will decrease the prolactin production. That is why we used which drug, that is cabergoline bromocriptine in prolactinoma. Why? Because look here, it will decrease, if you stimulate dopamine receptor, automatically it will decrease the prolactin, it will decrease the prolactin production. Then next important aspect, dopamine receptor, if you get D2 receptors, if they are excessively stimulated, they can also lead to psychosis. That is why we used antipsychotic drugs. Okay, then the next important aspect, so for that so if there is D2 stimulation, that will cause psychosis. The treatment is antipsychotics. If you give a antipsychotics, my dear students, they will cause extrapyramidal symptoms. So I wanted to teach you people with dopamine. That is why I didn't mention about extrapyramidal symptoms in the antipsychotics. Okay, now let's talk about growth hormone. We will come to growth hormone also. Okay, the growth hormone I will talk in endocrinology. Okay, extrapyramidal side effect. What are those side effects? Can anybody tell me what are the side effects? Extrapyramidal side effect. Let's see. What are the extrapyramidal side effects you have, my dear students? Tell me. What? Atypical ataxia. Anything else? Loss of posture. Okay. So tone. Write down the side effects such as guys, it can lead to ataxia. Apart from ataxia, it can lead to akathisia. Okay. The patient can develop tremors. Along with that, perioral tremors and perioral tremors. Okay, now perioral tremors are usually earliest sign of the extrapyramidal symptoms. Okay, now if dopamine receptors are blocked, if D2 receptors are blocked in a place called as thermostat, the area which is responsible for your temperature control, it will lead to a disorder called as malignant. What is that? Malignant. Which malignant? So I knew that all of you will tell what is that? Malignant hyperthermia. No, it is called as malignant. That is why I put it right down. That is called as neurolept malignant syndrome. Okay, neurolept malignant syndrome. It will lead to neurolept malignant syndrome, not malignant hyperthermia. Malignant hyperthermia is having a little bit different story there. Okay, neurolept malignant syndrome. Which malignant? Neurolept malignant syndrome. Okay, so please understand this particular aspect. Okay, so this is a story of your dopamine. Let's go to the next aspect, that is your antidepressants. Antidepressants are going to be very quick because it is very easy. Antidepressants. Now, when you are learning about antidepressants, so there is a theory for antidepressants also. Now, the theory about depression, what exactly it says that, so listen to me very carefully. I have one neuron here, there is one more neuron here. Let's take one neuron right here and one here. Okay, now exactly what I'm trying to tell you people is that this neuron, consider it was releasing serotonin, that is only 5-HT. Okay, this neuron, consider it is releasing norepinephrine. Okay, so basically they used to tell us that, what is that? The people used to, the theory used to tell us that if there is a decrease of norepinephrine and 5-HT, that is serotonin, in where exactly? In the synapses. In the synapses will leads to depression. That was the theory. That was the theory. Okay, what was the theory? It will decrease norepinephrine, serotonin in the synapses. That is why that is causing the depression. Okay, clear? Now, what exactly we started to do? For example, this 5-HT, whatever is released, it usually used to reuptake. What used to happen? Reuptake used to happen. Okay, 5-HT will work on the neuron, agreed. Now, norepinephrine also whatever released, reuptake. Norepinephrine also whatever released, reuptake. What is that? Reuptake. Okay. Now, listen to me very carefully. Norepinephrine, whatever is there, it is also getting reuptaken. Serotonin also reuptaken. So, basically, what exactly we need to do? We need to do is that, for example, SSRI. What is that? SSRI. Basically, they are selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Guys, selective serotonin reuptake inhibitors are very, very important. Why? Because SSRIs are a very important MCQs. So, what are the drugs we have? Drugs such as fluoxetine. Okay, we have drugs such as citralopam. Okay, we have drugs such as, what is that? That is your, most importantly, what is that? That is paroxetine. Okay, now all these drugs, there are other drugs also. So citralopam, acetalopam. Okay, all of these come under selective serotonin reuptake inhibitor, but they're least interested about knowing the names. They will ask you the uses of the SSRIs. Uses of the SSRIs very important for exam. So if you are learning about, if you remember one drug also totally fine. Even if you remember one drug such as fluoxetine or paroxetine, no problem. But the major issue is that they will ask you the uses. What are the uses? Of course, all of you know they're used for the depression. They're used for the depression. If the life was that simple, no problem, because pharma wouldn't be that difficult. Because yeah, antidepressant, depression, antiemetics, vomiting, okay, antibiotics for bacterial infection, that is very easy. No, that is not like that. So listen to me very carefully. There are other uses. Guys, listen very carefully. These are used for psychogenic, premature ejaculation. So, what is the most common cause of PE, premature ejaculation? Most common cause is psychogenic. The cause of psychogenic premature ejaculation is psychogenic. That is the most common cause. So, the treatment will be selective serotonin reuptake inhibitors. Apart from that, they are also used for PTSD. They are also used for obsessive compulsive disorder. They are also used for anxiety. Okay, now what are the few important things? So if at all if you are remembering, I would like you to remember these most 100% have to remember points. So PTSD, OCD and psychogenic premature ejaculation, because all these questions are very important and which are asked. Okay, especially these three important points are asked in last 1 year. Okay, clear? Okay. Now, the next important aspect. So, anxiety itself, you put to GAD, generalized anxiety disorder. Okay. Then next important, we have something called as SNRIs. Which are used for the depression, such as vanlaflaxine. Okay. So, this is there. Now, the most important are your tricyclic antidepressants, guys, TCAs. So, these TCAs, they will also inhibit what is that? Serotonin. And there is one more thing. What is that? Norepinephrine. So you might be asking, sir, serotonin, norepinephrine, SNRIs also there, na? SNRIs also there, na? Okay, you also write if you want duloxetine. Okay, now listen to me, sir. Serotonin, norepinephrine reuptake inhibitor is there. Then what is the difference about TCA? TCA also inhibiting serotonin, norepinephrine reuptake? norepinephrine reuptake. Then the question is, understand these TCAs are named after their structure. Their structure, it will have 3 cyclic structures in its this thing. What is that? In its chemical structure. So that is why we call it as a tricyclic antidepressants, my dear students. What is that? Tricyclic antidepressants. Okay, so listen to me very carefully. Tricyclic antidepressants, we have drugs such as amitriptyline. Amitriptyline. Okay. Apart from that, we have one more drug, that is nortriptyline. Nortriptyline. Okay. Then we have drugs such as imipramine. We have drugs such as imipramine. Okay. So there are big list of drugs. At least you need to remember these few of them. What is that? What is that? That is your amitriptyline, nortriptyline, and imipramine and clomipramine. Okay. Among these three are very important because all of these drugs are very much important as a result of as for the MCQ and other uses apart from the depression. So what are the uses of the TCAs, my dear students? These uses are very important MCQs. One of them is a nocturnal anuresis. Nocturnal anuresis. For the patient with the nocturnal anuresis, especially in the children who is not able to hold their urine, especially after a certain age. So through a certain age, they should be able to retain their urine during the night time, or they should be able to wake up and go to urination. But if they're losing the control and bedwetting is there, for that we can use it, nocturnal anuresis. Then apart from that, the most important, migraine prophylaxis. Migraine prophylaxis. So far I have told you people two drugs. What are those two drugs? What are those two drugs? That is your what are those? That is your nocturnal anuresis and migraine prophylaxis. What is that? Nocturnal 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 anuresis, migraine prophylaxis. For migraine prophylaxis, two drugs, tricyclic antidepressant and propranolol. Okay, then apart from that, sir, where else we are going to use this? So apart from that, tricyclic antidepressants, especially imipramine used for hyperactive bladder. Hyperactive bladder. Okay, so imipramine is used for hyperactive bladder. Hyperactive bladder. Then apart from that, they can be used for anxiety. They can be used for anxiety, but not as a so much important ones. Okay, so these are some important uses which you need to remember apart from the depression. Okay, so this is the story of your central nervous system. So when we studied about central nervous system, there are some important aspects which I want you people to go through from my side. Now quickly listen to me, whatever I'm going to say. These are going to be very important points. If you want, note down the timing in the video. Later also you can watch and make the points, but I want you to listen to me and repeat with me. Okay, so what is the most potent opioid? Fentanyl. What is the most potent opioid? Fentanyl. What is the most potent opioid? Fentanyl. Prototype opioid, morphine. Antidote for opioid overdose, naloxone and naltrexone. Antidote for your benzodiazepine overdose, flumazenil. Antidote for this one is, what is that? Flumazenil. Okay, benzodiazepine will increase the frequency of opening, barbiturates will increase the duration of opening. Okay, now these are some important points. SV2A inhibitor, levetiracetam. SV2A inhibitor, levetiracetam. Calcium channel blocker acting as an anti-epileptic drugs, that is calcium channel blocker in the CNS, that is your ethosuximide. Then what is the side effect caused by phenytoin? Fetal hydantoin syndrome, megaloblastic anemia, and which enzyme is inhibited by phenytoin collagenase? Which enzyme is inhibited by phenytoin collagenase? Okay, what what anti-epileptic drug? Which anti-epileptic drug is used for the treatment of status epilepticus? That is your yes, that is lorazepam. Okay, anti-epileptic drugs for the treatment of status epilepticus, lorazepam. If not there, midazolam. Pregnancy female, lamotrigine. If there is eclampsia, magnesium sulfate. So all these are very important, frequently asked questions. So what is the drug of choice for your, what is that? That is your psychogenic premature ejaculation, that is SSRIs. Which antidepressants are used for, that is your treatment of nocturnal anuresis, tricyclic antidepressant, and prophylaxis of migraine, also tricyclic antidepressant. With this much being said, I want to give you some points here. Write down those points. What is that? So these are not related to antidepressants, but related to overall CNS. There is first important, there is an opioid, tramadol. Tramadol is a opioid, but opioid with inhibitor of serotonin serotonin and norepinephrine reuptake property. Reuptake property. This is a very important MCQ which can be asked for you people in this coming exam. Okay. Then next important aspect, treatment of barbiturates overdose. Barbiturate overdose. What is the treatment of barbiturate overdose? Now, please tell me, anybody. So, barbiturate overdose is there. Okay, there is no antidote. We'll let him die. We'll do. Patient, sir, barbiturate overdose came. There is no antidote. So, let's leave the patient and let him die. We can't do that. So, what is the treatment? So, what is the treatment is that, guys, you are going to do forced alkaline diuresis. Forced alkaline diuresis. So, forced alkaline diuresis is the treatment of your barbiturate overdose. Listen to me. Barbiturates are a type of acidic drugs. What is that? Acidic drugs. Listen to me very carefully here. Acidic drugs. Now, listen to me very carefully. Acidic drugs. Okay. This is your nephron. This is your nephron. Okay. Normally, pH of the urine. pH of the urine is acidic. pH of the urine is acidic. Now, what happens is that I have a patient with overdose. Overdose of which drug? Barbiturate. Now, barbiturate will come into where? Into the nephron. Okay. Once it comes into the nephron, barbiturate drug will get filtered. Okay. Drug got filtered. But the most important point is that it is a type of acidic drug and urine pH is acidic. Now, drug can get reabsorbed very easily. Reabsorbed very easily. Very easily. So, if it is getting reabsorbed, again it is going back to the blood. So, please pay attention. Acidic drug in acidic media gets absorbed. Applying that logic, barbiturate is an acidic drug which can get absorbed in from the urine. Now, what I have to do? I have to change this pH from acidic to alkaline pH. Alkaline pH. So, if alkaline pH is there, so now the pH has changed into alkaline pH. If alkaline pH is there, now will the drug get reabsorbed? No, drug cannot get reabsorbed because the drug is an acidic drug in which media? Alkaline media. In which media? Alkaline media. So, why exactly you are making the urine alkaline? Because to prevent tubular reabsorption. To prevent the tubular reabsorption of the drug. Okay, this is a very important MCQ which can be asked, which was not asked yet. So that means this is a MCQ, new one possible, and be very much ready with it. That is to prevent the tubular reabsorption, we are making the urine into alkaline. Now, diuresis means increase the urine output. We are trying to remove the drug. Okay, so what exactly you need to understand? To prevent the tubular reabsorption, what you are doing? You are making the pH from acidic into alkaline. Which pH? Urine pH. Okay, that is called as fetal Hayden-Toyne syndrome, which is already explained. That is fetal Hayden-Toyne syndrome. Okay, now this is the aspect about barbiturate overdose. Now, apart from this, guys, listen to me very carefully. There are some drugs, MAO inhibitors. Now, if MAO inhibitors, monoamino oxidase, so MAO is an enzyme responsible for the metabolism of serotonin. Okay. Now, MAO inhibitors, if used with SSRIs, what will happen? So MAO is responsible for the metabolism of serotonin. MAO inhibitors, if they are used with SSRIs, so MAO inhibitor, if they are used with the SSRIs, what is going to happen? Let's see. It will lead to a syndrome called as serotonin syndrome. What is that? Serotonin syndrome. This serotonin syndrome is also a very important MCQ that is caused by which substances? MAO inhibitor, monoamino oxidase inhibitors along with SSRI. See, you give a SSRI, more serotonin in the neuron. Now, you inhibit a MAO, even more serotonin. Because of elevated level of serotonin, the syndrome we are going to get is a serotonin syndrome. Clear? So, how to make urine alkaline? My dear student, to make the urine alkaline with the help of one substance, sodium bicarbonate. Don't do anything with your acetazolamide, please, but rather use this particular one, NaHCO3, better option for you. All right. So once you understood about the serotonin syndrome, okay, now let's go to the next important point. What is that next important point from the central nervous system? That is next important point here is that, guys, please pay attention. That is, for example, we learnt about epilepsy and all those aspects, right? That is valproate and ethosuxamide is a very important point. Now, apart from that, now I want you people to pay one most important attention. Benzodiazepines, if used in insomnia, then what will happen? They will cause the treatment of sleep disturbance. Okay. If barbiturate is already reabsorbed, don't worry now. What is the problem? If barbiturate reabsorbed, no problem. It will come into the blood. Again, it will flowing into the kidney. So again, same story. No problem. Now, benzodiazepine, if used in insomnia, can change sleep cycle. Listen to me very carefully. Sleep cycle can be changed as a result of your insomnia caused by your, what is that? That is your benzodiazepine. Sleep cycle can change. Okay. So if sleep cycle can change, what exactly? The drugs used to treat insomnia without, what is that? Without sleep cycle disturbance, they are your very important aspect. Without sleep cycle disturbance, they are your most important Z drugs. That is your Z drugs such as zolpidem, zolpiclone. Okay, so all these drugs are your Z drugs, zolpidem, zolpiclone. These drugs are used for what? For the insomnia treatment itself, but which will not change the sleep-wake cycle. Okay. Now, then next important, what is that? Next important aspect, that is about your insomnia. Clear, everybody? Now, if you understood this so far, so whatever points I told you in the end also, they're very important. I can tell you this much that there will be at least CNS questions will be covered. For example, if there is 4 CNS questions, at least 3 questions usually will repeat from these highlights. I can guarantee, because these are the very high yield points. Okay, not that I have some extra imaginary power or something like that. No, this is based on the analysis of how the questions are asked. So based on that, you need to learn how exactly questions are asked so that you can grasp the point. That is the key to study. Okay, so you need to learn, okay, these are the questions which are asked, means they can repeat this question possible, they can ask about next topic which is right here. That is how we need to learn. Got it, everybody? We were discussing about CNS, done, right? We were discussing about CNS, done. We were discussing about ANS, done. We were discussing about all the other important general pharma aspects. Everything is done. Now, guys, I want you people to pay attention towards one important aspect, that is your heart. That heart related topic, that is your cardiovascular system, is a major chunk of pharmacology. And trust me, this will give you lot and lots of marks, not just from the pharma itself, but also from the other subjects such as internal medicine. Okay. Now, if you know cardiovascular pharma very well, if you know endocrine pharma very well, ANS pharma very well, you can survive all the basic situations which you come across as a doctor. So please understand the importance of pharmacology. You might be thinking pharma, okay, we studied in the in our preclinical subject, that is over. Don't think like that. Pharma is one subject which will haunt you wherever it wants. Okay, what do I mean by this? Any subject can correlate with pharmacology. That much important subject, right? So in that, very important structure is heart. So let's learn about the cardiovascular system. Okay, everybody back? Give me a yes or no. Let's see, everybody, can you hear me? So all of you took a zolpidem and slept off, huh? Yeah, just now you took a zolpidem, you slept off, right? No? Okay, now, guys, please listen to me. So don't take zolpidem. Okay, don't take lithium. Don't take any CNS suppressing drugs right now. Now listen to me very carefully, guys. So when you want to learn about cardiovascular system, so before going to cardiovascular system, during autonomic nervous system, let me ask you one simple question, okay? Now, when you run and come home, why parents told not to drink water immediately? Sir, why are you bringing ANS? So ANS can come anywhere. So please pay attention. So why not to drink water immediately? Why did our parents tell that? Because we didn't have water, sir. That is why parents told not to drink water. Any other reason? No, that is not the reason. First thing. Because when you run, glycogen will come and tell water, don't go into the esophagus. Wow, glycogen is such a bone or some tissue, it will come and stop or what? No, not about glycogen. See, I agree with the hormonal changes and all. No, we are not talking about hormonal changes. Now, listen to me very carefully. That is not about glycogen or anything, glucagon, glycogen, nothing related here. So, what exactly is this? Now, when you run, your sympathetic is active. If sympathetic is active, bronchodilation, and along with that, esophageal sphincter will contract. Esophageal sphincter will contract, means upper esophageal sphincter is closed. So all of you need to understand, when you look at a neck, right? In the neck, the anterior most structure is trachea. Behind the trachea, you have your esophagus like this, right? So now what happened is that trachea is dilated, esophagus is closed. Trachea is dilated and esophagus is closed. Now, when you drink water, water is supposed to go into the esophagus. Since esophagus is closed, now water will directly enter into the trachea, leading to aspiration. Now, you are good, you are correct, because of one reason, that is, there is a risk of aspiration. Okay. Now, the same thing. When you lie down and eat the food, I'll sleep and eat the chicken biryani. If you sleep and eat the chicken biryani, what will happen? Chicken will go, instead of into esophagus, it will go into trachea, leading to aspiration. Got it? Okay. Enough of chicken biryani. Let's come back here. What exactly we are going to learn, guys? Let's understand about cardiovascular system. In the cardiovascular system, let's start with one of the easiest topic. What is that? Anti-anginal drugs. Now, anti-anginal drugs. Now, anti-anginal drugs, I want you people to tell me the definition of angina. What is angina? Till you people tell the definition of angina, let's see, because I want you people to understand the definition. Tell me the definition of angina. Before that, I will not start the drugs. Just take a guess. What is angina? Sir, if this is there, we can call it as angina, like that. Angina means chest pain. That's what we learnt. So first important aspect, that is an incomplete definition, my dear. That is an incomplete definition. Why it is an incomplete definition? Chest pain is an incomplete definition. You people are right, but partially. What exactly happens is that there is an increase of O2 demand, and there is a decrease of O2 supply, leading to pain syndrome. Leading to what? Pain syndrome. We call it as angina. So what is the important key point here? That is decrease of O2 supply and increase of O2 demand is the key point. Okay, very good. Okay, so wherever it is asked, always answer what is that? Increase of O2 demand and decrease of supply leading to pain syndrome, called as a angina. Now angina is divided into, so what is the treatment target? What is the target of treatment? Either decrease the O2 demand. How can you decrease the O2 demand? You can decrease the O2 demand. By what? By decreasing the oxygen demand. This is one way to treat the patient. Then there is one more thing. What is that? Increase the O2 supply. So this is also a way to do what? To do the supply of the oxygen. So here what you need to do? Coronary artery dilation. Coronary artery dilation. So this is a story of your, what is that? This is a story of your angina treatment. Okay. Now, now when you want to treat the angina patient, let's start with one of the most easiest aspect. That most easiest aspect, that first important aspect, the first and most important drugs are your organo nitrates. What is that? Organonitrates. When you are talking about organonitrates, my dear students, organonitrates, what exactly they are going to do, how they are used, what is their importance, let's understand. Okay. Now, I'll tell you people, one of the, see, this angina topic, especially about organonitrates, it is going to be little bit more advanced compared to any revision course which you can find. So that is our motto. What is that? We are doing a revision and giving you the extreme content here. So let's listen to me, understand. Okay. Organonitrates. So when you give a nitrates will go into the body. Nitrates will go into the body under the influence of mitochondrial. There is an enzyme called as mitochondrial aldehyde dehydrogenase under the influence of one enzyme. What is that? That is your mitochondrial aldehyde dehydrogenase. It will get converted into somebody called as NO, my dear students. What is that? NO is what? It is basically a smooth muscle relaxant. Okay. So all of you know that nitroglycerin is used sublingually. It is rapidly onset. All these things you people know. So I'm not going to bother with that. I'm going to tell you people that particular information which is having a clinical significance and understanding to be required. Okay. Now, NO is there. Okay, sir. Now, NO will go and act upon what? Will go and act upon a smooth muscle. Consider this is one smooth muscle. What is that? Smooth muscle. Now, on this smooth muscle, NO will act. As soon as NO acts, it will stimulate an enzyme called as guanyl cyclase. What is that? Guanyl cyclase. Now, this guanyl cyclase converts GTP into somebody called as CGMP. What is that? CGMP. Now understand, so the primary first message was what? NO. After NO, inside the cell, what is formed? CGMP. CGMP will become which type of thing? That is a secondary messenger. It is a secondary messenger. So this particular question was asked previously, what is the secondary messenger of NO? The secondary messenger of NO is CGMP. Very important MCQ. What is the secondary messenger of NO? CGMP. What is the secondary messenger of NO? CGMP. Please don't get confused with CAMP. Okay. Now this CGMP fellow, whatever is there, right? Now this fellow will go and stimulate one substance called as protein kinase G. Protein kinase G. Now this protein kinase G will go and inhibit again same thing, that is only your MLCK, myosin light chain kinase. I told you people, myosin light chain kinase is responsible for contraction of the smooth muscle. Now my protein kinase G did what? It inhibited MLCK. If it is inhibiting MLCK, it will cause a smooth muscle relaxation. It will cause a smooth muscle relaxation. The next important MCQ of the organonitrates is that nitrates, the major action, nitrates action is seen where? My dear students, please listen to me. Nitrate action, the first site of action is veins. The first site of action is veins. The first site of action is veins. Okay, this is a very important. First site of action is veins, followed by that then arteries. So the first and most important aspect, it is veins. Okay. Now, if you give the nitroglycerin, if it acts on the veins, it will cause venodilation. Venodilation. If there is a venodilation, now listen to me very carefully. Venodilation, vasodilation of the veins. Now what will happen? If veins are dilated, blood will it come back to the heart? Now listen to me very carefully. I'm standing like this. Okay. If I'm standing like this, the blood which are gone into the tissue, that is coming back by veins. If I dilate the veins, automatically blood will pool up in the veins. Blood will pool up in the veins. So venodilation, pooling of the blood in the vein, pooling of the blood in the vein, pooling of the blood in the veins. If there is a pooling of the blood in the veins, it will lead to decrease of venous return. Decrease of venous return. Okay. If venous return is decreased, what will happen? Now tell me, will it affect afterload or preload? If venous dilation is there, it will affect afterload or preload. Venous return decreases, that means it will decrease the preload. It will decrease the preload. If it will decrease the preload, automatically the work of the heart. So heart has to pump the blood, right? If heart has to pump the blood, now what will happen is that if less quantity of blood is coming back, heart has to do more work or less work. Heart will do less work. So it will decrease the preload, which will lead to decrease of the O2 demand. O2 demand. This is the first way of nitroglycerin action. Nitroglycerin action. Very good. Okay. Now, it will dilate the arteries. My dear students, anywhere arteries will dilate. If arteries will dilate, arterial dilation, if arterial dilation is there, that will decrease the afterload. It will decrease the afterload also. Now, the most important MCQ is that, what is that? The MCQ is that nitrates, will they decrease the preload? Yes, sir. Will they decrease the afterload? Yes, sir. So both preload and afterload will be decreased, which will lead to decrease of the O2 demand. That is how our nitrates are working in the relieving of the angina. So this is a very important aspect to be remembered. Okay. Now, nowhere you'll find it in the revision sessions, that too for your crisp manner. So use this information very, very well. Okay. Agreed? Now, once you understood about organonitrates, so organonitrates, once you know about this, now let's go to the next aspect of the organonitrates. These organonitrates, guys, let's understand the uses. Okay, now uses of the organonitrates. So I told you people, they're relaxing all the smooth muscle. They're relaxing all the smooth muscle. If they're relaxing all the smooth muscle, the use is angina. All of you know that. You know that. Okay. Now, angina will be divided into stable angina, unstable angina, Prince metal angina. We'll come to that. Okay. Now, they're used in angina. They're used in conditions such as achalasia cardia. Achalasia cardia. Achalasia cardia is a surgical condition where there is a lower esophageal sphincter spasm. In there only you'll find in barium swallow bird-beak appearance. Achalasia cardia. Apart from achalasia cardia, organonitrates are also used in cyanide poisoning. Cyanide poisoning. So these are some important uses of your organonitrates. My dear students, one of the most important aspect, side effects of organonitrates. Again, this is also a very important aspect. Guys, these drugs will produce tolerance very easily. Okay. Apart from tolerance, they will cause one more side effect, that is your headache. Now, all of you used to tell me what is that? Nausea, vomiting, headache are the side effect of all the drugs. But for nitrates, this is very important specific side effect. That is, headache is a side effect of nitrates. Okay. Now, now the next important aspect is that, write down here only, nitrates can lead to dependence. Now, you people might start to ask me, sir, dependence is caused only by alcohol, opioids, such kind of things. Now, how does organonitrates cause? My dear students, organonitrates, if you are using organonitrates for 1 year, now all of a sudden, if you stop the organonitrate usage, your patient will get more frequent angina attacks. That is only your organonitrate dependence. It might not be found in the older textbook, but latest textbook says this. Organonitrates is very evident. The dependence caused by organonitrates is very evident, and this is a very, very important MCQ which can be asked. So, all of the following causes, what is that? That is dependence, except in that nitrates, if they have given, yes, nitrates will cause the dependence. So, search for the different answer. Okay. Now, once you understood about this much, so organonitrates, we have drugs such as glyceryl trinitrate. So we have drugs such as nitroglycerin. Okay. Then we have drugs such as erythritol, tetranitrate. So like this, there are many drugs are there. This is especially long acting. This is a type of long acting drug. Okay. Now, I want you people to understand nitrates, organonitrates. What are the routes? What are the dosage forms? What are the forms of the drugs which are available? One of them is their sublingual tablets are available. Apart from sublingual tablets, there is also transdermal patches. transdermal patches. So transdermal patches, I want you to remember at least 3 to 4 transdermal patches. One of them is fentanyl transdermal patch, rotigotine transdermal patch, nitrates transdermal patch, nicotine transdermal patch. Nicotine, rotigotine, fentanyl, nitrates. These 4 at least you need to remember in the patch form drugs. Okay, next important. Everybody understood about the organonitrates, route of administration, other mechanism of action and everything? Okay, now scopolamine. Yeah, I told you people about scopolamine also. Very good. Okay, let's go to the next important drugs. So the next important drugs, my dear students, beta blockers. What is that? Beta blockers. Now, beta blockers, I want you to understand all the beta blockers which will decrease the O2 demand, which will decrease the O2 demand, Already we know about the drugs, which will decrease the O2 demand. Then we also have calcium channel blockers. Now when you're looking at a calcium channel blockers, my dear students, please understand calcium channel blockers which are used in the heart are diltiazem and verapamil. These are the two drugs which are what? Which are specific to the heart only. These calcium channel blockers, got it? Now these beta blocker and calcium channel blockers, these two do not combine together. Do not combine together. This is an important point. To be remembered. Okay. Now, once you understood about this, now let's go to the next important aspect. What is that? They're called as fatty oxidation inhibitor. What is that? Fatty oxidation inhibitors. So fatty oxidation inhibitors. So tell me guys, what are the fatty oxidation inhibitors we have? Or any importance? Why we need to inhibit fatty oxidation in the heart? So remember, so fats will give ketones. Now these ketones are the main energy source. Main energy source of what? Of the heart. Don't confuse it with the complete body. For the heart, ketones will be the energy source which are derived from the fats. Okay. Now remember, if fat has to undergo oxidation, fat require more O2, fat require more oxygen for oxidation, So for the oxidation of the fat, you require more and more of fatty oxidation. Fatty oxidation require more and more of oxygen, so require more O2 for the oxidation. Now, if fatty oxidation, if they inhibit fatty oxidation inhibition, then what heart will do? Heart will shift to what? Shift the energy source to what? To the carbohydrates. If they shift to the carbohydrates, now carbs require more oxygen or less oxygen? They require less oxygen. For oxidation. That means automatically, what exactly you need to understand? That is O2 requirement will be less. For the heart. Everybody understood? Very good. You are right. Fat require more oxygen for the energy. Okay. So what are the drugs? We have a drug called as trimetazidine. And there is one more drug called as ranolazine. These are the two drugs which you need to remember for the treatment of angina, fatty oxidation inhibitor. So this might be a direct question. How exactly direct question? Which of the drugs work as a fatty oxidation inhibitors? Fatty oxidation inhibitors is a very important question. Okay. Yes, of course, you are correct. I have mentioned ranolazine. Okay. Now, apart from that, there is one more thing. What is that? They are called as rho kinase inhibitor. Now rho kinase inhibitor, understand guys, there is an enzyme called as rho kinase. Which will cause vasoconstriction. If I inhibit rho kinase, it will cause vasodilation, which will increase the O2 supply. That's it. O2 supply. What is that? Rho kinase inhibitor. Rho kinase inhibitor, my dear students, that is your sacubitril. What is that? Sacubitril. Okay, so you need to know the name. Which of the following drug is mechanism is Rho kinase inhibitor? Can be a direct MCQ. You need to understand that is your sacubitril. That is your sorry, not sacubitril. I'm sorry. The name of the drug is fascodil. Sorry, fascodil. I'm sorry. The name of the drug is fascodil. What is that? Fascodil. Okay. So fascodil, you can remember it like fascodil. Okay. It's working on the heart. Fascodil. Okay. So this is the story of your Rho kinase inhibitor and anti-anginal drugs. Once you understood about the anti-anginal drugs, then we are going to next important aspect. What is that next important aspect? Let's learn about antihypertensives. Now, when you're learning about antihypertensives, guys, antihypertensives are a very important group of drugs. So, antihypertensives, again, remember, there will be 1 or 2 MCQs for sure. For sure. Okay. Now, let's learn about first line antihypertensive drugs. First line antihypertensive drugs. So, what are the first line antihypertensives we have? Let's see what are those and what are the uses of those, and let's understand. Okay. Now, when you want to understand about first line antihypertensives, my dear students, first line antihypertensive drugs, the first and foremost group of drugs, thiazide diuretics. Thiazide diuretics. Thiazide diuretics. Okay. Now, the next important group of drugs, we have ACE inhibitors. ACE inhibitors. Okay. Apart from that, we have angiotensin receptor blockers. Angiotensin receptor blockers. Then we have calcium channel blockers. Then we have beta blockers. Beta blockers. So if you know at least these 5 groups of drugs, everything will be easy. So to understand these 5 groups of drugs, let's go and understand one basic way how your body responds to decrease of BP and how we can incorporate our drugs into that particular mechanism. Okay, everybody able to follow? Guys, this is a fascodil, not sacubitril, sorry. Everybody able to follow? Give me an yes or no so that I can continue. Okay. So, let's start. What exactly is that particular aspect? That first and most important aspect, guys, understand hypertension. HTN means hypertension. There is something called as hypertension emergency. Then there is one more thing called as hypertensive urgency. Hypertensive urgency. So, hypertensive urgency and hypertensive emergency. Guys, look here, in both of them, there is an increase of the BP. In both of them, there is an increase of the BP. Okay. The patient is having hypertensive urgency, be it emergency. In that both cases, what will happen? That will be your elevated BP. Along with elevated BP, what will be there? My dear students, one more important aspect. In hypertensive emergency, there is a end organ damage. End organ damage. So end organ damage, what do I mean by end organ damage? Any condition such as stroke, the patient is having elevated BP with a hemorrhagic stroke, for example. Hemorrhagic stroke. Okay. For example, patient is having a aortic dissection. Aortic dissection. Okay. Along with elevated blood pressure, aortic dissection is there. For example, patient is having a retinal hemorrhage. Retinal hemorrhage. Retinal hemorrhage. Okay. Hemorrhage. Now, all these kind of end organ damages, along with the elevated BP, you are going to call it as a hypertensive emergency. So, what do I mean by hypertensive emergency? A patient with a elevated blood pressure came to the hospital with a sudden loss of vision. Sudden loss of vision. You need to think of retinal hemorrhage. Okay. For example, patient came with a severe chest pain and is having a asymmetrical BP and elevated blood pressure. You need to think of aortic dissection. For example, patient came with the symptoms of the stroke and there is a hemorrhagic stroke symptom along with elevated BP, then hypertensive emergency, which is a hemorrhagic stroke. Got it? Now, what is hypertensive urgency? In hypertensive urgency, no end organ damage. Okay. Now, we will come back to its treatment in some time. before coming back to the treatment. So guys, right now whatever I'm going to explain, I request you people not to write anything, just pay your attention to me. Just what I'm going to teach, pay your attention. Done? Okay. If there is a decrease of the BP, if there is a decrease of the BP, what will happen? Okay. Now, if there is a decrease of the BP, automatically what will happen is that there is a decrease of the cardiac output. There is a decrease of the cardiac output. And along with that, there is a stimulation of sympathetic nervous system. So, decreased cardiac output will also stimulate the sympathetic nervous system. Okay. Now, if sympathetic nervous system is stimulated, my dear students, automatically it will stimulate which receptor? Alpha 1 receptor. It will stimulate which receptor? Alpha 1 receptor, which will cause vasoconstriction. Vasoconstriction. Okay. Then sympathetic activation will also stimulate which receptor? Beta 1 receptor. If beta 1 receptors are stimulated, it will increase the force of contraction of the heart. Okay. And if beta 1 receptors are stimulated, I told you people, what will get released, my dear students? What will get released? Tell me. What will get released? Tell me quickly. If there is a beta 1 activation, very good. That will lead to renin release. That will lead to renin release. Okay. Now, if there is a decreased BP, as I told you people, decrease of cardiac output. If there is a decrease of cardiac output, now what will happen to your kidney? If there is a decrease of cardiac output, it will decrease the blood flow, renal blood flow. If blood flow to the kidney is decreased, again it will cause the renin release. So far what I told you people, understand? If there is a BP decrease, what will happen? Decrease of the BP, decrease of the renal blood flow, sympathetic activation, renin release. So far, whatever I told you people, if you people understood, give me an S. Let's see. Have people understood? Give me an S. Or no, maybe if you didn't understand. Okay. So, if you understood so far, let's go back to our understanding. What exactly I'm trying to teach you people here? Guys, what I'm trying to tell you people is that if there is a vasoconstriction, if there is what? Vasoconstriction, what will happen? Vasoconstriction will lead to, what is that? Vasoconstriction will lead to increase of the BP. Okay. Now, if there is a force of contraction increases, that will also lead to increase of the BP. Now, renin, whatever is released, what he will do? He will convert angiotensinogen. He will convert angiotensinogen into somebody called as angiotensin 1. Okay. Now this angiotensin 1 will get converted into AT means angiotensin. It will get converted into angiotensin with the help of angiotensin converting enzyme. Now this angiotensin 2 will go and stimulate angiotensin 2 receptor. Angiotensin 2. I'll write it as a normal number so you can remember. Angiotensin 2 receptors. Okay. Once it stimulates the angiotensin 2 receptors, it will also cause increase of the BP. Because it will cause vasoconstriction. Okay. Now, this angiotensin will not keep quiet. It will also go and stimulate aldosterone. Now, what exactly aldosterone will do? It will retain. What exactly is that? Sodium and water. If sodium and water is retained, more quantity of the blood. If more quantity of the blood, automatically it will lead to what? Elevation of the blood pressure. So far, whatever I told you people, there is a complete story of hypertension. Here only with this, you can understand the complete drugs here itself. Okay. So alpha 1 stimulation, vasoconstriction. Okay. Then there is what is that? ACE will convert angiotensin 1 to 2, which will cause angiotensin 2 receptor stimulation, vasoconstriction and elevation of the BP, and there will be sodium and water retention as a result of aldosterone. So what you need to do? Very easy. Target here, target here. So every place in this particular aspect, if you make a target, the story is ending. What is that? Treatment of hypertension. So that's how we need to understand. If you know this particular mechanism, it will be very easy. So decrease of BP. If BP decreases, cardiac output will decrease. Sympathetic activation. Sympathetic activation will lead to alpha 1 activation and beta 1 activation. If cardiac output decreases, renal blood flow decreases. It will lead to renin release. Beta 1 also lead to renin release. Now, because of alpha 1, beta 1 effect, the BP was increased. Because of renin, angiotensinogen got converted into angiotensin 1. Angiotensin 1 will get converted into angiotensin 2 with the help of an enzyme called ACE. Now, this ACE will convert it into angiotensin 2. Now this angiotensin 2, whatever is there, my dear students, it will go and stimulate the angiotensin 2 receptor, which will cause vasoconstriction and increase of the BP. At the same time, your aldosterone will cause the retention of the sodium and water, which was stimulated by angiotensin 2. That is the end summary. So what and all you can do? Remove the sodium and water. Sir, treatment of hypertension done. Yes. Inhibit angiotensin converting enzyme, treatment of hypertension done. Sir, for example, block beta 1 receptor, renin not released, treatment is done. Okay, don't allow the blood vessel to contract, keep them dilated, your treatment is done. So this is how we need to understand. Everybody able to follow the follow the logic here, what I'm trying to do? See, this is a very important concept. Okay, now let's start with the first group of drugs, thiazides. Thiazides are drug of choice for hypertension management. Now you people might get confused. It is like asthma only. So what do I mean by this? What is the drug of choice for hypertension? That is the only question. What is the drug of choice for hypertension? Then you are going to mark it as thiazides. So thiazides, my dear students, it is a type of diuretic which will cause the loss of sodium and water, so that will decrease the blood pressure. Drugs such as hydrochlorothiazide. Now, why am I not going into the depth? Because there is a reason. We will teach the diuretics with you, the diuretics in upcoming CVS only. Okay, hydrochlorothiazide. Apart from hydrochlorothiazide, my dear students, these drugs such as chlorothiazide. Okay, chlorothiazide. So there is one more drug chemically related to this called as chlorthalidone. All these drugs are thiazide diuretics. Okay, so I'll teach you people about thiazide diuretics. Just wait. Now, so far understand this. Let's go to the next important aspect. What exactly is that? Remember your angiotensin 1. Angiotensin 1 used to get converted into angiotensin 2. Now, this angiotensin 2 used to stimulate angiotensin 2 receptor, AT2 receptors. Now here we used to have an enzyme called as angiotensin converting enzyme. Why am I putting this every time again? Now listen to me very carefully. This ACE is located in your lungs, my dear students. Where it is located? Lungs. Now what am I trying to teach you people here? Look here, in the lungs we have an inflammatory mediator called as bradykinin. Now, bradykinin will undergo degradation also with the help of same enzyme ACE. So, ACE is required for conversion of angiotensin 2 and also for the breakdown of the bradykinin. This is a summary you need to understand here. Okay, now let's understand ACE inhibitor. ACE inhibitor, what is the mechanism of action? They will inhibit an enzyme called as angiotensin converting enzyme. If they inhibit the angiotensin converting enzyme, now what will happen, my dear students? Increase of angiotensin 1. But that is not our problem, angiotensin 1, because it is not a potent. No, nothing to worry about angiotensin 1. But there is also, if you inhibit, there is an increase of bradykinin. Now, if there is an increase of bradykinin, it will cause one side effect. It will cause a side effect, that is your dry cough. It will cause a side effect called as dry cough. Why dry cough? The dry cough is caused as a result of your, what is that? That is your bradykinin. Okay. Since we are talking about the side effect, let me write down here only. In patient, now listen to me very carefully. In patient with C1 esterase deficiency, there is an enzyme C1 esterase. Where it is located? In which pathway it will come? C1 esterase. Let's see. Yeah. So in which pathway C1 esterase will come? C1 esterase, my dear students, C1 esterase will come in one pathway, that is only your complement pathway. That is your complement pathway. Okay. See, in patient with C1 esterase deficiency, in the patient with C1 esterase deficiency, very good. It comes in a complement pathway. Complement pathway is a part of plasma protein. Okay. Now, in that patient, they can lead to a side effect called as angioedema. Angioedema. What do I mean by lead to angioedema? Now, angioedema is nothing but swollen lips, very, very evident, very severe swelling of the lips will be called as angioedema. That is a side effect. Okay. Now, AC inhibitors. My dear students, let's understand the next important aspect. Now, this most important thing is that drugs. We have drugs such as captopril. We have enalapril. We have lisinopril. All the prils, agreed. All the prils are your ACE inhibitors. Prils are your ACE inhibitor. Okay. Now, my dear students, what are the uses of this drug? Uses of this drug, all of you know, one use is hypertension. Along with that hypertension, they are also used in congestive heart failure. Along with the congestive heart failure, these drugs are used in patients with diabetic nephropathy. Why nephropathy? Why do we use it? Why do you think, okay, diabetic nephropathy came, okay, I felt like ACE inhibitor, do I give? No, not like that. Because we use them in diabetic nephropathy, because they decrease proteinuria. Since they are decreasing the proteinuria, we are using them in a diabetic nephropathy, but not in a CKD. CKD is a different spectrum of disease, but CKD is a different spectrum of disease, and diabetic nephropathy is a different spectrum of disease. Remember, a patient with diabetic nephropathy, then you are preferring your, what is that drug? That is your ACE inhibitor. Okay. Now, what is the important take-home message here? The take-home message here: patient with diabetes mellitus and hypertension. Best antihypertensive. Best is ACE inhibitor. Okay. So remember, there, see, that is what I'm telling. See, in CKD patient directly you are not using. You are using them in a diabetic nephropathy patient so that kidneys will not get into CKD. Okay. So for CKD, don't answer directly as a ACE inhibitor. That's what I'm trying to tell you. Okay. Understood about ACE inhibitor? Then next important, they're called as ARBs. What is that? ARBs. The ARBs are what? Angiotensin receptor blockers. Angiotensin receptor blockers. Now, angiotensin receptor blockers, already I taught you people here, angiotensin receptor, it will go stimulate, it will cause vasoconstriction. If I block this angiotensin receptor, no vasoconstriction, automatically BP will decrease. Drugs such as losartan, drugs such as telmisartan. So all the sartans are your ARBs. Okay. Now, for example, patient with gout and hypertension. So question number 1: which drug to avoid? That is question number 1. Which is to be given for hypertension? which drug, that is which, write it as antihypertensive drug. Which antihypertensive drug? Okay, now tell me answer, let's see. So patient comes to you, all these are direct MCQs, okay, beat any exam, every place these are asked, okay. Now tell me, patient with diabetes mellitus and gout is, sorry, hypertension and gout is there, which antihypertensive drug to be avoided, which antihypertensive drug to be given? I'll give something, sir. Already it is too late, we are sleepy. No, not like that. So remember which drug to avoid. Which drug to avoid. So remember the drug to avoid are thiazides. Don't get confused. Drug to avoid is thiazides. Okay. Why to avoid? Because thiazides will increase the urea reabsorption leading to gout. So if a patient who is having gout, if you give thiazide diuretic, gout will become worse. So don't give thiazides in a patient with gout. But where you have to give? You have to give which drug to give? In this case, you have to give losartan. This is having a slight uricosuric property, means it will excrete the urea a little better. That is why. Very good, very good. Okay, you are correct. Losartan to be given, thiazide to be avoided. Very important MCQ. Got it? Okay. Then, once you have understood about ARBs, let's go to the next group of drugs. What is that? Calcium channel blockers. Now, calcium channel blockers, my dear students, understand in smooth muscle. Which calcium channels are there? In the smooth muscles. So in the smooth muscles, we have somebody called as L-type calcium channel blockers. We have something called as L-type calcium channel blockers. Okay. Now, please understand, consider this is one smooth muscle. Now, what I have here, I told you people, what is that? There is a smooth muscle. There is a smooth muscle. To this smooth muscle, I have calcium channels, right? So, what will happen is that calcium will come inside. Now this calcium, whatever comes inside, this will go and stimulate which one? Sarcoplasmic reticulum. What is that? Sarcoplasmic reticulum. What is this sarcoplasmic reticulum? My dear students, sarcoplasmic reticulum is a intracellular calcium storage. Once calcium act here, it will release more of calcium. Now this calcium will cause contraction. Now issue is that in the smooth muscle, which calcium channels are there? L-type. Which calcium channels are there? L-type. Now listen to me very carefully. If you at all you block this L-type, what will happen? If you block the L-type, automatically L-type calcium channel, if they are blocked, it will cause vasodilation. Vasodilation. Now listen to me very carefully. Vasodilation is there caused by what? Smooth muscles. Okay. Now guys, please understand vasodilation. Okay. Now what are the drugs we have? So, drugs acting on calcium channels of smooth muscle. So, this is a very important aspect. Which calcium channels are present in the smooth muscle? This is also MCQ which was asked earlier. That is L-type. So, calcium drugs acting on the calcium channels of the smooth muscle. Smooth muscle, they are called as your dihydropyridines. Okay. Now, among these dihydropyridines, so if you look at dihydropyridine, if I want to simplify it and pronounce, I can pronounce it as dipine. Dihydropyridine simplified into a dipine. So, dihydropyridines are amlodipine. Okay. Apart from amlodipine, we have one more drug, that is your nifedipine. Okay. Apart from nifedipine, there is one more drug. Called as nicardipine. Okay. So all these drugs are your calcium channel blockers. Now, you understood about calcium channel blockers. We understood about the smooth muscle relaxation. They are causing the smooth muscle relaxation. I'm sorry. Now, amlodipine, nifedipine, nicardipine are there. Okay. Now, guys, let's go to the next aspect. Now, what are the uses of the calcium channel blocker? Now, wherever you use calcium channel blockers, my dear students, they're going to cause smooth muscle relaxation. So, all of you know one of them, hypertension. Okay. Hypertension urgency we can use. hypertension, urgency also we can use. Okay, apart from that, next aspect, guys, please understand what exactly is that. So hypertension, apart from that, diseases such as achalasia cardia in a patients with fistula in a node, in there what you are going to is that fistula in a node, there in those patients what you are going to do is that you are going to give it in the form of a cream so that the anal sphincter will relax. In all these places we can use them. Okay, now guys, so if they're causing the smooth muscle relaxation, they will cause some side effect also. Why? Because smooth muscles are present in many places of the body. So if it causes smooth muscle relaxation, what will happen to venous return? Decreases. Whatever blood which is to come from the veins will be decreased. If venous return decreases, they can lead to reflex tachycardia. Reflex tachycardia. Reflex tachycardia. Now, apart from reflex tachycardia, my dear students, they will also cause one more side effect. What is that one more side effect? So, in the body, we have GIT, right? GIT is made out of lots and lots of smooth muscle. If there is a lots and lots of smooth muscle, there what can happen is that your smooth muscle can get extremely relaxed and they can lead to constipation. They can lead to constipation. Okay, apart from constipation, motility will decrease now, my dear, because smooth muscles are relaxed. If smooth muscles are relaxed, what is there to motility? Because if smooth muscle contract only, motility is more. Okay, don't confuse. Okay, now don't confuse yourself. Okay, now constipation. Apart from that, there is one more side effect which can be direct question: ankle edema. Ankle edema. And one more side effect. What is that? That is your gum hyperplasia. Gum hyperplasia. Now, gum hyperplasia can also be caused by ankle edema and gum hyperplasia, specifically caused by amlodipine. Amlodipine. Here, everybody? Here? Okay. Now, we have one more drug here, nicardipine, is used for intracranial hypertension. Intracranial hypertension means there is an elevated blood pressure in the cranium. In that condition, we are going to use this drug, that is nicardipine. Okay, so we are done with the calcium channel blockers. Once we are done with the calcium channel blockers, ARBs, thiazides, all these drugs are done, then we are going to next group of drugs. What are those? They are your beta blockers. Beta blockers. Now, beta blockers will not take much time of yours. Why beta blockers will not take much time of yours? So they're used for both fistula in ano and fissure in ano, no problem. Anyways, excessive contraction of the smooth muscle, you can use it. Okay. Now beta blockers. Now beta blockers, my dear students, what you are trying to understand. Fissure in ano also we use. Okay. Now beta blockers, they inhibit the renin release. They inhibit the renin release. Already know. They inhibit the renin release. If they are inhibiting the renin release, automatically they will decrease the blood pressure. They will decrease the blood pressure. So that is a simple aspect. What is that? Beta blockers will decrease the blood pressure. So this is the story of your first line antihypertensive drugs. What are the first line antihypertensive drugs? Thiazides, okay. Then ACE inhibitors. Then you have angiotensin receptor blockers. Then you have calcium channel blockers, and you have your beta blockers. Clear, everybody? It's used for both. It's used for both. Don't worry. Now, once you understood about this, now let's go to the next aspect. What is that next aspect? My dear students, the next important aspect is that is other antihypertensive drugs. Other antihypertensive drugs. So in the other antihypertensive drugs, I'm not going to waste much time discussing every drug, but let's focus on the drugs which are very much important for the exam. Everybody with me? Everybody with me? Able to understand and focus? Yeah, tell me. Okay. So listen to me. Other antihypertensive drugs. The other antihypertensive drugs, such as first and most important drugs, potassium channel openers. What is it? Potassium channel openers. Now, potassium channel openers are very important drugs. Why very important drugs? Potassium channel openers, how do they work? Working is very simple. So, this is a cell. inside the cell intracellular fluid rich with potassium ion. If I open the potassium channel, all the potassium will come out. If potassium comes out, cell will become more and more negative. If cell becomes more and more negative, it undergoes hyperpolarization. So can it contract? If it happens in the smooth muscle, can it contract easily? No, it cannot contract easily. Okay, so that is the story. So potassium channel opener mechanism is not important, but the drugs and their uses are very important. We have a drug called as minoxidil. Guys, tell me minoxidil, your favorite beard oil. All of you used to buy beard oil, na? That contains of minoxidil only. That consists of minoxidil only. We have one more drug. What is that one more drug? That is your hydralazine. Hydralazine. Again, very important MCQ. Okay. Now, apart from hydralazine, there is one more drug called as diazoxide. Diazoxide. So, three drugs, three important MCQs. Okay. Now, what are those MCQs? Let's see. And what are the uses? Let's see. Okay. Now, tell me minoxidil. Minoxidil is used. Minoxidil will cause one side effect, that is your hypertrichosis, excessive hair growth. Hypertrichosis. If there is a excessive hair growth, we use it in alopecia. What is that? Alopecia. Which type of alopecia? Usually we use it for androgenic alopecia. Which is that alopecia? We are going to use it for androgenic alopecia. Which is that alopecia? We are going to use it usually androgenic alopecia. Androgenic alopecia. So where we are going to use it? We are going to use it in a androgenic alopecia. Androgenic alopecia. Apart from androgenic alopecia, it is applied how? Topically. My dear students, remember that is not systemically. Topical application only. Systemically for androgenic alopecia, which drug you are going to use? Systemically. Systemically, you are going to use which drug? Finasteride. Which is the drug? Finasteride. Finasteride. Okay, for systemic usage, finasteride. For topical usage is your, what is that? That is your minoxidil. Then hydralazine. Hydralazine used in pregnancy hypertension. So pregnancy female with hypertension, three drugs we have discussed so far: hydralazine, alpha methyl dopa and labetalol. These three are used for the pregnancy hypertension. Then diazoxide. Diazoxide is used in one condition called as insulinoma. Insulinoma. It is a tumor which will produce excessive level of insulin. So how exactly the rationale behind its usage we will understand during the endocrine discussion. Agreed? Okay. Now, once you understood about diazoxide potassium channel openers, let's get to the next important, such as alpha blockers. Alpha blockers we already discussed. A patient with hypertension, and BPH, then to decrease the drugs load, we can use just single drug, that is your alpha 1 antagonist. Okay. Then there is one more drug, that is your dopamine agonist, specifically speaking D1 dopamine agonist. My dear students, D1 dopamine agonist, how do you understand this? Please understand, D1 receptor is there, D2 receptor is there. Two receptors are there. D1 receptors are located in the periphery. So in the periphery, if D1, if they are stimulated, it will cause vasodilation, leading to decrease of the blood pressure. Okay. D2 is located where? In the central nervous system. Okay. In the periphery, where exactly, my dear students? Exactly speaking, few of the most important location. One of them is renal vasculature. Okay, and mesenteric vessels. These are the two places, most important places. Mesenteric vessels. Okay. Now listen to me very carefully. D1 dopamine agonist, we have a drug called as, what is the name of the drug? The name of the drug is called as phenoldopam. Phenoldapam. What is this phenoldapam? Phenoldapam is a drug. What exactly is this phenoldapam? Phenoldapam is a drug which is responsible for D1 agonist. Okay. Now listen to me very carefully. Now what exactly happens here is that D1 agonist is a phenoldapam. So this is one of the drugs which can be used in hypertensive emergency. One of the drugs. Okay. Now, apart from that, guys, you need to remember one of the most important, MgSO4. MgSO4, where do we use it? Used in the eclampsia cases. But most importantly, eclampsia we use them. But when you give a magnesium sulfate, magnesium will antagonize who? Antagonize one of the most important substance, that is your calcium. Basically, magnesium will break the activity of calcium. Magnesium will break the activity of calcium. If it break the activity of calcium, so what will happen? Calcium was responsible for vasoconstriction. Now what exactly will happen? Vasodilation. Vasodilation will occur. Agreed? Understood? Now, MgSO4 that will lead to eclampsia. Now, when we need to understand the next important aspect, when you use a MgSO4, you need to do some monitoring. What is that monitoring you are going to do? What is this monitoring you are going to do? What exactly you are going to monitor? Okay, tell me, what exactly you are going to monitor when you give a magnesium salts? Toxicity. Now, listen to me. If toxicity is happening or not, how will you know? I'm giving continuously magnesium IV, magnesium IV, magnesium IV. Okay. But if it is leading to toxicity or not, how will you know? So for that, you need to monitor. You need to monitor something called as knee-jerk reflex. Knee-jerk reflex. You are going to monitor knee-jerk reflex, my dear students. Please understand. BPH, that is alpha blockers such as prazosin, doxazosin, alfuzosin, terazosin. Okay. Now, not TDM, just you are going to do this particular aspect. Knee-jerk reflexes. You are going to monitor the knee-jerk reflexes. So what you'll get out of knee-jerk reflexes, guys? If at all, see, if knee-jerk reflex is absent, what is that? If knee-jerk reflex is absent, that means magnesium overdose has been occurred. Magnesium has reached a maximum toxicity because calcium activity is not there only. If calcium activity is not there, smooth skeletal muscles will not contract. If no contraction, no knee-jerk reflex. More magnesium, less activity of calcium. Less activity of calcium means less of knee-jerk. If less of knee-jerk means skeletal muscles are not contracting, that indicates magnesium toxicity. So how do you treat a magnesium toxicity? Tell me. Actually, if you use the information which I taught you people only, you can answer. I have a patient with magnesium toxicity. What is the treatment I'm going to do? Very good. The antidote is, what is that antidote? Calcium gluconate. Calcium gluconate. So this is the story of your anti-hypertensive drugs. Clear, everybody? Okay. Now, here you write down the drugs related to heart failure. In the patient with a heart failure, what are the drugs you are going to use? Okay, so you need to understand about a heart failure. I'll give a quick review of the heart failure. What exactly is the quick review of the heart failure? You'll see now. Okay, now patient is having a chronic heart failure. If patient is having a chronic heart failure, there is a decreased pumping of the heart. Simple as that. Decreased pumping of the heart. If heart is pumping less, what will happen? Let's see. If there is a decreased pumping of the heart, that will lead to decrease of cardiac output, which will activate sympathetic nervous system. Sympathetic in turn will activate RAS system. RAS system. Now RAS system will stimulate aldosterone production. Aldosterone will cause sodium and water retention. Sodium and water retention. But the problem here is that, my dear student, the problem here is that heart is not pumping only. If heart is not pumping, that will lead to more of sodium and water retention. Then what will happen? Now what will happen is that more of sodium and water means more fluid in the body, but heart is not able to pump it. Now that will lead to edema. That will lead to edema. So this is the cause of edema in your which condition? That is your heart failure patient. Okay. Now, if your heart is not pumping, automatically what will happen? Now, listen to me very carefully. If pumping capability is decreased, that will also lead to decrease of venous return. If there is a decrease of venous return, that will also cause edema. This you can just directly remember. Decreased venous return can also lead to edema. So, a patient with heart failure, one of the complaints is edema. Okay. Now, so whenever patient is having heart failure, heart is not pumping. So what exactly we are going to do? We are going to do first important aspect, the treatment of the heart failure. The treatment of the heart failure, my dear students, we can use beta blockers. We can use beta blockers. Beta blockers will do what? Better filling. Better filling. Okay, beta blockers will do better filling. That is why we can use these drugs. Apart from that, what else we can use, my dears? The next important drugs we can use is ACE inhibitors. ACE inhibitors. Why we can use ACE inhibitor? ACE inhibitors and ARBs. Okay, now AC inhibitor and ARBs, both of them cause vasodilation. If vasodilation is there, now listen to me very carefully. Your heart is pumping. So if heart is pumping, let's draw and understand. Okay, this is your left atria, left ventricle. Okay, now if you cause a vasodilation, vessels are dilated. Now your heart will pump, but will it have more resistance? See, vessels are dilated, resistance is less, pumping can occur very easily. So that will decrease the load on the heart. That is one reason. And second reason is that if you use this drug, no angiotensin 2, and they will decrease the edema also. So these are the reasons. So ARBs. Apart from that, we can also use, my dear students, diuretics. So all these four group of drugs prevent cardiac remodeling. What do I mean by cardiac remodeling? If your heart is working more, heart can undergo what? Hypertrophy. But if your heart is working less, heart will not have these hypertrophic changes. So if no hypertrophic changes, that will prevent the mortality. So these are the drugs which prevent the mortality also, we can call them. Got the logic? So any drug which decreases the load, which will prevent the mortality. Got it? Now, next important aspect, apart from this, my dear students, we are going to use, what is that? That is your digoxin. What is that? Digoxin. What exactly this digoxin does? Listen to me very carefully. The digoxin is derived from a digitalis plant. Which plant? Digitalis plant, which can also be called as foxglove plant. Now, from this foxglove plant, we get a digitalis. Now, my dear students, digitalis, the mechanism of action is very interesting. So, the first mechanism of action, let's understand. It will inhibit sodium potassium ATPase. It will inhibit sodium potassium ATPase. Now, if you consider this is one cardiac myocyte, here I have a sodium potassium ATPase. Sodium was coming out, potassium was going in. It is present in all the cells of the human body with the help of a ATP. Okay. Now what I will do is that I will block this sodium potassium ATPase. If I block the sodium potassium ATPase, automatically sodium will not come out. So that will lead to increase of sodium in the cell, increase of the sodium in the cell. So increase of the sodium in the cell. Now in the heart, there are special pumps. So that special pump, what it will do, that is your sodium and calcium exchanger. So what exactly? The sodium will go out, calcium will come in, means it is a bidirectional. If sodium is going out, calcium will come. If calcium is going out, sodium will come in. So bidirectional. Okay. Now what exactly is that? Now what exactly happens is that more sodium. Now sodium will go out and you have calcium. So increase sodium in the cell. Now that will lead to increase of the calcium. If calcium is increased, better contractility. Better contractility of the heart. So this is how you are going to cause the increased contractility of the heart. But most important aspect, digitalis or digoxin is there. Na? Now digoxin will compete for one location, compete for sodium or potassium, for the potassium site, of sodium potassium ATPase. Okay, so this is a point to be remembered. So for which side they are binding? Very good. They are fighting for same site. Which site? Potassium binding site, my dear. Which site? Potassium binding site. So understand if both are potassium also going there only. See, there is one girl going, two people are interested. Okay, now these two people are competing for the same person. Like that only, there is a potassium site. For that potassium site, digoxin also want to bind, potassium also want to bind. Okay, now what will happen if there is decrease of the potassium? If there is decrease of the potassium caused by hypokalemia, which condition? Hypokalemia. Now if there is a hypokalemia, competition for digoxin will be reduced. If competition for digoxin is reduced, now what will happen? So if there is a hypokalemia, that can lead to digoxin toxicity very easily. Digoxin toxicity very easily. So digoxin toxicity can be caused by hypokalemia. Hypokalemia is caused by many drugs. We will understand in the diuretics. So diuretics will lead to hypokalemia. Now hypokalemia can easily lead to what is that? Digoxin toxicity. So this is the story of your digoxin toxicity caused. Then one next important, now not complete toxicity. The second mechanism of action is that it is a type of vagomimetic in action. If it is a vagomimetic, means heart rate will be increased or decreased, my dear students? Of course, vagus nerve is a parasympathetic nerve. If it is a parasympathetic nerve, automatically it will lead to what is that? Decrease of the heart rate. So it will lead to decrease of the heart rate. If there is a decrease of the heart rate, now what will happen? Bradycardia. Very good. If there is a bradycardia, now what will happen? The duration of diastole is increased. Increase the duration of diastole. Something like beta blockers. If there is an increased duration of diastole, now what happens, my dear students? Now the thing is that if there is an increased duration of diastole, that will lead to better filling. So these are the two mechanisms. Of digoxin. So digoxin is used for very good. Okay. Now the next important aspect is that digoxin related questions. There are some important digoxin related questions. We will understand them now. So let's understand about digoxin toxicity. So the digoxin toxicity clinical features. Okay. Now, what are the clinical features of digoxin toxicity? Let's see. If more digoxin is there in the body, the patient will develop bradycardia. Agree with me? Bradycardia. Why? Because excessive vagomimetic action. Then patient will develop, my dear students, muscle weakness. Which is that condition? Muscle weakness. Okay. Then patient will also develop a condition, that is your vomiting and diarrhea. Apart from vomiting and diarrhea, patient will also develop one more thing, that is only your yellow halos. Now, what do I mean by yellow halos? So, yellow halos is nothing but the patient will tell, sir, I feel like there is some yellow color light around my head. So, he'll feel that there is a yellow color shade of light which is present around the head. That type of explanation will be given. That is only called as yellow halos. Now, if I have a patient with a digoxin toxicity, okay, tell me the treatment. Let's see. I'm not going to rush here. I want you people to answer the treatment. Okay. So, let's see. So around 38 are watching. I want all 38 of you to give an answer. At least 10 answer I need to get. What is the treatment of digoxin toxicity? Tell me, what is the treatment for digoxin toxicity? I'm looking for your comments. NaHCO3, DS-Fab, okay. NaHCO3, okay. Arrhythmic drug, okay. Then any other thing? Digoxin, immune F or digibind, okay. So understand, guys, please don't answer. I request you people, don't by heart it as a digibind. No, not digibind. It is not called complete. There is a complete name. When they gave a complete name, most of the student marked a wrong answer and came. Because of that, if you fail, just imagine how horrible, painful it is. The digoxin antidote treatment is called as digoxin immune, very good, F antibody, immune F antibodies. This is called as a digoxin immune F antibodies. Very good. Digoxin immune F antibodies are the most important treatment. Remember, antidote of digoxin overdose is digoxin immune F antibodies. This is only usually they will call it as digibind. Okay. Now, if digibind is not mentioned in your exam, no problem. Digibind not there, no problem. That is not our headache. What is the main component I need to remember? Digoxin immune F antibody. You need to know this. This is a very, very important aspect, because many people made this mistake. What exactly is that? That is the mistake was made with this one. What is that? If there is a digoxin induced arrhythmia. If there is a digoxin induced arrhythmia, then the drug of choice is lidocaine or lidocaine, okay, or lignocaine. So please remember, if digoxin induced arrhythmia, okay, for that condition you are going to use what is that? That is lignocaine. Not for everything, okay. Remember, digoxin induced arrhythmia is there. The drug of choice is your lidocaine, but don't mark it as a wrong answer by rushing into this thing, okay, because there are many times they gave digoxin immune F antibody full name, and since digibind was not there, many people marked lidocaine and lost the question. This is not some old question. This was even asked in some 1 year back in INICET as well. That much frequent question, okay. So I hope you'll not make any mistakes. Okay. Now, once you understood about this, let's go to the next important aspect. What is that? So let's understand anti-arrhythmic drugs. They are your anti-arrhythmic drugs. So anti-arrhythmic drugs. First, before going into, tell me anti-arrhythmic drugs, what and all you know. Anti-arrhythmic drugs. What are the drugs you know? What and all will happen? Tell me. Amiodarone, very good. Lignocaine, very good. Any other thing? Lignocaine, very good. Amiodarone, very nice. Okay. So let's understand about this, okay? Now, my dear students, anti-arrhythmic drugs are going to be little lengthy. Procanamide, very good. Okay. Now, it's going to be little lengthy. I want you people to bear with me. Can you people do that? Are you people bored of my teaching? Are you people able to understand everything easily? Tell me honestly. Sir, bored means bored. Sir, able to understand means understand. Class 1 to 5. Okay. You're bored. Okay. Okay. Very nice. Happy to hear that. Okay. Anti-arrhythmic drugs. Now listen to me. We will make them very simple. Okay. Guys, antiarrhythmic drugs. First, before going to antiarrhythmic drugs, what you need to know, that is about this particular fellow. Consider this fellow is your cardiomyocyte. Consider this fellow is your cardiomyocyte. At the rest, there is a resting membrane potential minus 90 millivolts. So, in a cardiomyocyte of a ventricle, okay, yes, of course, see, once we are doing a quick review, this is how it works, okay, you need to be strong, you are going to be doctors, okay, doctors should be awake in the mid of the night also, the same attention has to be there, that's what we are being trained for, okay. So if I am sitting and giving you 5 hours of full energy, I want you to try the same thing, all right, you'll do that, okay, Rahman, motivated, जोश है, गुड, 24/7 अवेक रहना है, ठीक है, 24/7 अवेक नहीं रहना है, अवेयर रहना है, अटेंटिव रहना है, बस जरूरत के हिसाब से, अकॉर्डिंग टू द रिक्वायरमेंट. Okay, now listen to me very carefully. So anti-arrhythmic drugs. So how is the Josh? Hi, very nice. Now listen to me what I will do. All of you studied one thing now. Depolarization, depolarization, cardiomyocyte activation, cardiomyocyte signal comes, signal comes, signal. Signal, what is that signal? Cardiomyocyte will get signal from what? So girlfriend will give signal and cardiomyocyte get activated or what? No, right? So cardiomyocyte will get activated with the help of entry of sodium ions, my dear students. What happens? Sodium ion comes inside. Now once sodium ion comes inside, cell will become more positive and more positive. It will reach up to a point called as minus 55 millivolts. It will reach up to a point called as minus 55 millivolts. During this minus 55 millivolts, it will lead to opening of more sodium channel. Opens even more sodium channel. If it opens even more sodium channels, it will allow the entry of more and more sodium. The first thing what happened, signal generation means sodium ion entry. So that led to minus 55. After minus 55, it opened more and more sodium channel. The cell will become more and more positive. Cell will become more and more positive. So let's take one graph here. Okay, the cell was at rest it was minus 90 millivolts. Okay, now at this minus 90 millivolts, I opened the sodium channel. Because of that, sodium entered. Sodium is a positive ion, cell became more positive. It came up to, sir, minus 55. Okay, now after minus 55, even more sodium channel opened. Even more sodium channel opened. More sodium came in. If more sodium comes in, the depolarization will reach to a peak. So sodium channels will reach to a peak. After they reach to a peak, the sodium channel will close. Once sodium channel will close, cell is more positive. Our bodies tend to what? Go back to its original state. So body will try to go back to its rest. So during that effort, what it will do? It will open up a potassium channel. Now intracellular fluid consists of more potassium. So potassium will start to go out. As potassium start to go out, what will happen? The cell will become, what is that? Cell will start to become negative. But because of this sodium ion entry, potassium exit, entry, exit, that created somebody here, my dear student, that is called as voltage. Now, what exactly this voltage will do? It will allow the entry of calcium ions. So, calcium is coming in, potassium is going out. I didn't close the potassium yet. Focus here. Calcium coming in, potassium going out, calcium coming in, potassium going out. So if they are looking at one positive coming in, one positive and going out, the voltage will remain unchanged. But at one point, calcium channel will also close, but potassium channel will remain open. Okay, if potassium channel will remain open, potassium is going out, cell will come back to its original resting state. Okay, now what exactly I'm trying to tell you people here? See guys, in cardiovascular system, the information which I taught you people is very, very valuable. Don't neglect it. Okay, so why am I teaching you people this much? So I can go just like, I can skip into anything. I can just tell class 1 to 3, then story is over 4, and okay, some 4-5 lines because it is a review, but I don't want to do that. I want to do the justification for your time. Okay, so look here, you need to understand. This phase is called as phase 0 initially. Phase 0. Then next, when it is coming down, first time, phase 1. Then we call it as a phase 2. Then we call it as a phase 3. When it come back to rest, phase 4. Okay. So phase 0 is only called as, see, the original polarity was minus 90 millivolts. It went to some different positive voltage. Whatever original polarity was there, that was being lost. We call it as depolarization. depolarization. Okay, then you had phase 1. Phase 1 is called as early or initial repolarization. You'll understand what is repolarization, just give me a minute. Okay, then phase 2, there is no change. If there is no change, very good, already you people told, what do we call it as? Plateau. What do we call it as? Plateau phase. Okay, then phase 3. Phase 3, what is happening? Notice here, it is coming back to its original state. Means what happens is that it is coming back to its original state, means regaining its own polarity. We call it as repolarization. We call it as what? Repolarization. Repolarization. Now understand the next aspect. What is that? Phase 4. Phase 4 is that resting membrane potential. So totally phase 0, 1, 2, 3, 4. 0 is caused by sodium ion entry. Phase 1 is caused by potassium ion exit. Very good. The next one, very good. The next one is plateau, calcium entry, potassium exit. Third one is potassium exit, called as repolarization. The last one is resting membrane potential. Resting membrane potential. Now, why did I teach you this? My dear students, during this period, here, this particular area, this particular timing, we call it as absolute refractory period. What is that? Absolute refractory period. Okay, now during this absolute refractory period, you give any energy, you give any extra voltage, heart will not respond. So if heart is under absolute refractory period, give any extra voltage, it will not respond to that much. If you remember, rest will become easy. Okay, so what we are going to do, when you're talking about arrhythmia, what can cause arrhythmia? Such as ectopic beat generation. Ectopic beat generation. Now, ectopic beat generation means normally signal generates from SA node, everything was in sync. Okay, remember, you are right about refractory period. Remember the absolute refractory period, because there is something called relative refractory period also. In physiology, you will learn. Okay, now if there is a ectopic beat, abnormal beat generation from an abnormal location, now what will happen is that normally SA node was generating the signal. Instead of SA node, some abnormal tissue is generating the heartbeat, because of which the person developed a arrhythmia. Now what you need to do, so to treat arrhythmia, to treat what is that? Arrhythmia, you need to do only one thing. Either increase absolute refractory period, your problem is solved, or you can do one more thing. Decrease the absolute refractory period, your problem is solved. Just remember this much. This is enough for you. Sufficient. Okay, either increase, decrease, your problem is solved. Okay, so let's solve the problem. So when we want to solve the problem, how exactly we are going to understand? So guys, antiarrhythmic drugs are divided into, what is that? They are divided into class 1 antiarrhythmic drugs. Class 1 antiarrhythmic. So when you are learning about class 1 antiarrhythmic drug, all the class 1 antiarrhythmic drugs, they will block sodium channels. They will block sodium channels. They will block the sodium channels. Okay. Now we have class 1A drugs. We have class 1B drugs. Class 1C drugs. Okay. Very good. Tell me why we have class 1A, why we have 1B, why we have 1C. Tell me. So all of them are blocking sodium channel. Story is over now. Sodium channel blocking property are called as class 1 drugs. But why we divided them into 1A, 1B, 1C? Tell me. Sodium channel configuration or any other extra reason is there? There is one more important aspect. What is that? The other effects, see, not just sodium channel, there are potassium, there are calcium, there are other channels, right? So along with that sodium channel blocking, they also block some other channels. Very good. So class 1A drugs, they block the sodium channel and also they block the potassium channels. Now class 1B drug, they block the sodium channel and open potassium channels usually. Open potassium. Got the logic? Then class 1C, they block only sodium channels but no effect on the other drug. Very good, very good. Okay. Now So first, let me teach you a technique to remember the drugs. Then we will go into some graphs. Okay, what exactly is that? The first thing, my dear students, what exactly is that? Listen to me. We have a drug called as disopyramide. Disopyramide. Okay, you have one more drug called as quinidine. We have one more drug called as quinidine. Okay, then we have one more drug called as procainamide. Procainamide. Okay, then very good, very good, very good, very good question. Very good, Rahman. All of you are correct. Okay, now class 1B drugs. Class 1B drugs. So there is one more drug called as lignocaine. Lignocaine. And there is one more drug called as mexiletine. Mexiletine. Okay. Now the last group of drugs. Last group of drugs. There is flecainide. Flecainide. There is one more drug called as propofol. Propofol. Okay, now why am I talking about these drugs only? Guys, there are other drugs also, but if you remember these important drugs, you can survive very easily. And to remember these important drugs, I have a technique to remember. So that technique is, this is a story of a person who went to England. Consider somebody went to England. Okay, now this fellow went to England. When he went to England, what is the currency of England? What is the currency of England? What is the currency of England? Tell me. Guys, come on, it's a general knowledge. GBP, what is you call simple as that? Pounds. Simple as that, pound. So, he went, he gave a pound, he gave 1 pound. He gave 1 pound. Along with that, when he gave 1 pound, he asked for one more pound. So, he gave double pound. He gave double pound, 2 pounds he gave, and bought a quarter of whiskey. Bought a quarter whiskey. Quarter alcohol. Bought a quarter alcohol. Okay, so he gave what? Double pound for 1 quarter. He gave double pound for 1 quarter. After that, he drank the alcohol. He drank the alcohol and now he's hungry. Now he's hungry. When he's hungry, he went for what? McDonald's. Okay, when he went to McDonald's, what is the most common thing you are going to buy? Burger. So he asked for a burger. In the burger, he asked for extra. What is that? Lettuce and mayonnaise. He asked for lettuce and mayonnaise. Okay. So now leave about the drinking part. Okay, now leave about the drinking part, leave about McDonald's, but he got hungry, he went to McDonald's. There he went and bought a burger. When he got a burger, what did he ask for? He asked for extra lettuce and mayonnaise. Lettuce and mayonnaise. Okay, now, after that, my dear students, what happens? Let's see. So, what happens is that you need to understand some interesting aspect. What exactly is it? Guys, 1 second. I'm having some difficulty here. Yeah, I'm able to see your comments. Okay. So, if you follow so far, now listen to me very carefully. What is that? Lettuce and mayonnaise. He asked for a burger. In that, more of lettuce and mayonnaise. After he ate burger, he wanted more of food. But he was not able to eat one complete burger. He went and asked the server, "Give me fries, please. Give me the French fries. Fries, please." So this is a mnemonic. This is a mnemonic. One person went and got a quarter. He drank that quarter. D for disopyramide. Look here. D for disopyramide. Pound. P for procainamide. Q for quinidine. First group of drugs done. After he drank the quarter, what he did? Went for a burger. L for, in that he wanted more of lettuce. So L for lettuce, lignocaine. M for mayonnaise, mexiletine. Okay, then he asked for French fries. So flecainide, fries, propofol, please. So how do you remember? Person got a double quarter for a pound. Okay, or double pound for a quarter. You can remember either way. Double quarter for a pound or double pound for a quarter. Okay, he gave double pound for a quarter. He got alcohol, drank, then French fries, before French fries, lettuce, mayonnaise, then fries, please. This is a technique to remember. This is a technique to remember. Will you remember now? Okay. Shall we do this again? Double pound for a quarter. D for diisopyramide. P for prokenamide. Okay. Q for quinidine. Done. Then he went to eat the food. That is that burger. In that he wanted more of lettuce, lignocaine. M for mayonnaise. That is your mexilitine. Lettuce and mayonnaise. Then 1C, your what is that? Flecainide and propofenone. Will you remember these drugs now? Double quarter for a pound, double pound for a quarter, or then lettuce mayonnaise fries, please. Done. Everybody got the logic? This is a technique to remember. Okay. Who will remember all those many drugs? Na? That is why. Okay. Now, my dear students, let's talk about graphs of each drug. Class 1A drug. Now, class 1A drug, understand this is a normal conduction depolarization in the heart. Okay. Now, what happened? Sodium channels are blocked. Sodium channels are blocked means phase 0 will get, yes sir, delayed, of course. Phase 0 will get delayed. So, phase 0 got delayed. Okay, sir. Then it was going normally. But you are delaying which phase? Phase 3. If you delay the phase 3, so it will become like this. Now, if you notice the new graph which I have drawn with the red color, what happened here? Overall, there is an increase of absolute refractory period or treatment is done. Never ever forget. Very good. Okay. Got it? Then let's go to the next one. What is that next one? Class 1B drug. Same, original depolarization curve was like this. Okay. Now what exactly it does, my dear students? So sodium channels are blocked. Phase 0 is delayed. It was going, rest was going normally. But phase 3, if you open potassium channel, phase 3 will occur earlier. Phase 3 will occur earlier. So it will become like this. It will become like this. The new graph, if you notice here, again there is a decrease of absolutely refractory period. Your treatment is done or done. That's it. That is why I told you people about sodium potassium channels of the heart in the starting itself. Okay. Now, class 1C, consider this is the original graph. Okay. In this original graph, they are blocking which channels? Sodium channels. They are blocking which channels? Sodium channels. Rest everything is going normally like the old one. If you notice here, there is a decrease of the absolute refractory period. That is why we are treating arrhythmia. 1C. Done? That's it, sir. Antiarrhythmics. So much scary drugs. They're not scary at all. Come on. Very easy. Okay. So once you understood about class 1 drugs, let's go to the next group of drugs. The next group of drugs are, let's learn about class 3 antiarrhythmic drugs. Sir, have you gone mad? What about class 2? We'll come to class 2. Just wait and watch. The technique is very important. Okay. Class 3 antiarrhythmic drugs. Class 3 antiarrhythmic drugs, they are the blockers of potassium channel blockers. They block which channels? Potassium channels. They block which channels? Potassium channels blockers. Okay. So what are the drugs? Let's see. Tell me the drugs, guys. Let's see. Okay. Tell me the drugs. Let's see anybody if you can remember. Already people told one drug. What was that drug? What was the drug you told? Amiodarone. Remember? Amiodarone. We have a drug called as amiodarone. Amiodarone. Okay. Amiodarone. Apart from amiodarone, there is one more drug. That is your... See, this is the point here. Though it is a beta blocker, though it is what? Beta blocker, it works as a class 3 antiarrhythmic also, called as sotalol. Called as sotalol. Okay. Now, apart from sotalol, there is one more drug called as vernaculant. Okay, so there are many of them. At least remember these 3 drugs: amiodarone, sotalol, vernaculant. Vernaculant is a antiarrhythmic drugs which is used in trials and etc. recent times. So it is becoming very important drug. Okay, so remember these 3 drugs. Now what happens, guys? Watch the magic here. The original graph. Okay, to this original graph, what did I do, sir? I blocked the which channels? Everything is going like this only normally. I blocked which channel? Potassium channel. So this phase will become prolonged. So if you notice, yes, you treated arrhythmia, increase absolute refractory period. Increase the absolute refractory period. Okay, now remember one more aspect. This amiodarone blocks almost all almost all channels, sodium, potassium, calcium, every channel it can block. Okay, now let's continue the next aspect. What is that, my dear students? This amiodarone is a very important aspect. Why? Because amiodarone can lead to it. This drug contains iodine. The drug itself contains what? Iodine. If it contains iodine, it can lead to side effects. It can lead to side effects such as hyper or hypothyroidism. It can lead to either of them, hyper or hypothyroidism. Hypothyroidism. Apart from hyper or hypothyroidism, there is one more thing. What is that? That is your hyper or hypothyroidism. There can be patient can develop a cataract. Sorry, not cataract, corneal precipitate. What is that? Corneal precipitate. Corneal precipitate. Corneal precipitate leading to blindness. Okay, peripheral, what is that? Peripheral neuropathy, it can lead to neuropathy, peripheral neuropathy. It can also lead to lung fibrosis. So all these things can occur as a result of using of amiodarone. These are the most important side effects you need to remember. Okay, so this is what is about amiodarone. Once you learnt about amiodarone, my dear students, let's go to the next aspect. What is that next aspect? So class 2 antiarrhythmic drugs. Class 2 antiarrhythmic drugs, they are your beta blockers. They are your beta blockers. Basically, they are going to block what is that? That is that is in SA node. They are going to block in the SA node. They're going to block in the SA node, will lead to decrease of the heart rate. Especially what exactly they're blocking. Let's see, my dear students. In the SA node, how depolarization will occur. So consider this is one SA nodal cell. This is one SA nodal cell and we are having a graph here. Okay. Now what happens is that the cell will be at rest. Okay, but there are something called as IF channels. There are something called as IF channels, which will allow the entry of small amounts of sodium without any depolarization, without requiring anything. So from the rest, it will be rising slowly like this because of IF channel. It will reach one point. It will reach one point called as threshold potential. Threshold potential. As soon as it reaches the threshold potential, my dear students, it will allow the entry of calcium ions. What will happen? Now, as soon as it reaches, it will allow the entry of calcium ions. So it will reach a peak. It will reach a peak. After that, calcium channels will close. Once calcium channels will close, the cell will come back to its original state. Again, the same story will repeat. Slowly it will rise. Suddenly calcium will come in and the same story will repeat. Each of these particular thing is equal to that of 1 beat. Is equal to that of 1 beat. Is equal to that of 1 beat. Now, how exactly it is coming back? Of course, repolarization, potassium exit or potassium efflux. Exit or potassium efflux. Okay, so this is the story of your SA nodal depolarization. Okay, now, now, where there is a repolarization is occurring, what do we call that state as? Repolarization is occurring, we call it as a phase 3. Okay, now do we have a phase 0 here, guys? Do we have a phase 0 here? Tell me in SA node, do you have a phase 0? So calcium entry depolarization is occurring. Calcium entry depolarization occurs, that means which stage is that? Depolarization is occurring, which stage is that? So that is only your phase 0 and phase 4. Okay. Now listen to me very carefully. So please understand these are the phases. Okay. Now please understand, leave about the phases also. It's okay, learn from the physiology. But the thing is that beta blockers prolong this phase. Beta blockers will prolong this phase. Once they prolong this phase, automatically what will happen? Beat generation will be slower. Prolong this initial phase. Okay, yes, of course, phase 1 and 2 absent. Phase 1 and 2 are absent. Okay, so this is your phase 4. Beta blockers prolong phase 4. Phase 4. phase 4. This is only your phase 4. Okay, it will prolong the phase 4. Then the last group of drugs what you have are, that is your class 4 anti-arrhythmic drugs. They are your calcium channel blockers. Calcium channel blockers. Now these calcium channel blockers, my dear students, what are the calcium channel blockers we have? The calcium channel blockers are diltiazem, and verapamil. Okay, now this diltiazem and verapamil, exactly they are working where? Here I told you people, which is that phase? Phase 0, phase 0. If calcium channels are blocked, automatically see, normally SA nodal depolarization was something like this. If you block the calcium channel, this will be okay. But calcium channel blockage will lead to slow down because it will take more time. If it takes more time, automatically number of heart rates will be decreased. Number of heart rates will be decreased. So that is what is done by your calcium channel blocker. So class 2 and 4, they are working where exactly, guys? They are working exactly in the SA node. Okay, now the problem is there. What is that problem? There are MCQs related. Before going there, before going to MCQs, you might be asking, sir, other antiarrhythmic drugs. Sir, other antiarrhythmic drugs, I'll put it into the MCQs, all the important aspect. A patient is having atrial fibrillation. Atrial fibrillation. What is the best drug? For atrial fibrillation, beta blockers are equally effective to that of calcium channel blockers, my dear. Equal to that of calcium channel blockers. Then, if at all patient is having a ventricular fibrillation or ventricular flutter, which is also called as ventricular tachycardia, that is ventricular flutter. Okay, in that condition, what you are going to do? The first treatment is defibrillation. First treatment is defibrillation. Okay, then if I ask you people, during defibrillation, we are going to do what is that? That is only advanced cardiac life support. Advanced cardiac life support. During the advanced cardiac life support, we are going to use amiodarone. During advanced cardiac life support, we are going to use amiodarone. Okay. Apart from that, if I ask you what is the single best drug of choice, you can also use lignocaine. You can also use lignocaine. Okay, so to prevent this from occurring, see, during resuscitation, during cardioversion and during your cycles of resuscitation, you are going to use, my dear students, amiodarone. Later, to prevent, what you are going to use? Lignocaine. You are going to use lignocaine. Now, apart from ventricular fibrillation, let's go to the next aspect. If the patient is having a PSVT, for PSVT, we are going to use IV adenosine. But for PSVT, not just IV adenosine, other treatments are also available. What are the other treatments we are going to do? Other treatments which we are going to do for these people are like this, my dear student. The first treatment, what is that? PSVT, IV amiodarone. Apart from that, there are other things, other treatments such as carotid massage. Okay, there is one more thing we can also advise the patient: Valsalva manure. Okay, these things and other drugs we can consider are beta blockers. But the first and the most important best drug of choice, always your answer is adenosine. Other things are here. Your best drug of choice is adenosine. Okay. Now, if I ask you people, the best antiarrhythmic for WPW syndrome, Wolff-Parkinson-White syndrome, we are going to use one drug called as, my dear students, flecainide. For example, if I ask you people, what is the treatment for, that is only your treatment for Digoxin induced arrhythmia. Digoxin induced arrhythmia. See, digoxin induced arrhythmia, the treatment is your lignocaine. Treatment is your lignocaine. Very good. Very good. All right. So these are some important aspects which you need to remember. Okay. Now, these calcium channel blockers are they derivative of dihydropyridines or non-dihydropyridines? See, in antihypertensive, I told you about dihydropyridines. Remember? So these are only called as non-dihydropyridines. Clear? So this is a story of your antiarrhythmic drugs. Antiarrhythmic drugs. So you treated heart failure, you treated angina, you treated what is that? Arrhythmia, you treated all the possible hypertension, etc. So this is a story of your antiarrhythmic drugs. So somebody might be asking me, sir, is it only enough for every exam? Yes, I can say for every UG level survival or UG level exams, for everything, for even MCA, for any other exams, for your PG also, all the basic questions can be covered related to antiarrhythmics from here itself. So this is the information which you should know. Done, my dear students? Understood, everybody? Understood? Okay. So, shall we continue? Shall we continue? Let's see. Yes, no? Yes, okay. Yes, yes. Wow. What about others? Very good, very good. Peace. Then we are continuing, okay? So we are going to do one small system, very easy system. Okay, I'm not going to torture you people. I know that. After cardiology, anything which comes to brain, don't, reflex, everything, overhead syndrome only. But let's make it simple. Okay, that's natural. Okay. I only told you people 45 minutes is the span and I'm teaching you people. You people might be thinking, see, this is a review, you need to adjust. Okay. And those who are thinking, sir, my girlfriend is waiting for me to text with me. So leave all those for a day and listen to the class. Okay, it's fine. Now, in quick review of pharmacology, nobody is going to teach you in this depth. This is very clearly I'm telling. Okay, so please. All right, chala. Let's start. Understand? Very easy, sir. Very easy system. GAT. What is that? GAT. Okay. Sir, I want to do Babu Shona. You can do all your Babu Shona later. Okay. Right now, GAT. पेट पूजा करते okay. That's true. Okay. Now, guys, in the GIT, that's very easy. The first and most important thing, I want you people to understand those drugs which are used for the peptic ulcer disease. Okay. For treating of the peptic ulcer disease. So, let's understand drugs for the peptic ulcer disease. So when you want to understand about the drugs for the peptic ulcer, guys, it's very easy for you to understand. So what are the drugs we have for peptic ulcer? Okay. So this is what I wanted to hear. Not just PPIs. Okay. There are other things also. Now listen to me. What exactly happens here? So drugs for peptic ulcer. What are the causes for the peptic ulcer? Causes for the peptic ulcer. Some of the leading ones. H. pylori. H. pylori. Then drugs such as NSAIDs and steroids. Most important ones, okay, I'm talking. Then apart from that, other risk factors such as lifestyle, etc., all of them. Okay. Now, when you need to understand that, my dear students, let's take stomach. Now, inside the stomach, we have hydrochloric acid. Now, hydrochloric acid is not touching the stomach. Hydrochloric acid is not touching the stomach. Rather, there is a mucus barrier. This mucus barrier prevents the hydrochloric acid from damaging the stomach. Okay. Now, listen to me. Let's understand. So, let's learn about acid production. Acid production is done by Yeah, acid production, how does it occur? Done by your parietal cell. Done by your parietal cell. How exactly it happens? Let's see. So how exactly it happens is that, guys, normally the parietal cell looks like this, something like this, okay? This is the normal shape of a parietal cell approximately, but we are going to make it into simplified fashion. So let's take a parietal cell. This is a parietal cell. Okay. Now in the parietal cell, right next to parietal cell, there is some other cells, my dear student. They are only called as ECL cells. ECL cells. Okay. Now listen to me very carefully. You eat food. Food will stimulate parasympathetic nervous system. Parasympathetic nervous system will release acetylcholine. Now acetylcholine will act upon the enterochromaffin like cell and also act upon your parietal cell. In the parietal cell, which receptor is there? M1 receptor is there. Okay. Now, apart from that, food will also lead to the production of gastrin. Now, gastrin will act upon the gastrin receptor. Gastrin receptor. Okay. Now these enterochromaffin cells will produce histamine. Now, histamine will act upon your H2 receptor. Act upon your H2 receptor. Clear, everybody? Enterochromaffin like cells. Okay. Don't confuse. Now, gastrin receptor will allow the entry of calcium. M1 receptor will allow the entry of calcium, and H2 receptor will convert ATP into CAMP. Now, if you notice here, calcium, CAMP, calcium, all these three things will activate a protein kinase. Protein kinase. Now, this protein kinase will trigger the protein synthesis. Protein synthesis. Now, this protein will come and sit on the cell membrane. This protein will come and sit on the cell membrane. So this protein will pump. What exactly is that? It will pump the hydrogen from inside of the cell to outside of the cell. And it will take which ion? Potassium ion into the cell. Now this hydrogen ion will combine with the chloride ion, leading to your hydrochloric acid formation. Clear? Okay. Now, what exactly we are going to do? So, we need to decrease the acid secretion. The first drugs are your proton pump inhibitor. Proton pump inhibitors. Now, what are these proton pump inhibitor? So, proton pump inhibitors are the drugs, your prazole, such as pantoprazole, pantoprazole. We have rabeprazole, rabeprazole. We have lansoprazole. We have esomeprazole. All the prazoles, which are what exactly they are doing? They are blocking this particular stage, proton pump, proton pumping. We call this stage as only they are the last stage of acid production blocker. Then we have H2 blocker, H2 blocker, H2 blockers such as ranitidine, ranitidine, nizatidine, nizatidine. Then we have one more drug, that is your cimetidine, cimetidine. Okay. Now, cimetidine, there is one important MCQ you need to remember. It will cause a side effect, that is your gynecomastia. I told you people yesterday. Okay. This is a very important MCQ, gynecomastia causing drug. Then digoxin will also cause. Gynecomastia also caused by digoxin added. Also caused by your digoxin. Okay. Now, apart from this, there are some M1 blockers, which I taught you people already. M1 blockers, such as your pirenzapine and tilenzapine. They are also decreasing the acid production. Okay. Now, what exactly you need to focus here, my dear students? We need to focus treatment of H. pylori. Treatment of H. pylori. So, this is a very important MCQ. Okay. Usually, we are going to use something called as triple therapy. Triple therapy, and there is one more thing called as quadruple therapy. Quadruple therapy. Now, what is the difference between these two? Triple therapy will consist of two antibiotics, and one proton pump inhibitors. One proton pump. Quadruple therapy is what? Two antibiotics, and one PPI along with that one covering agent. What is that? Covering agent. Now, covering agent, the classic covering agent, you need to remember. What is that classic covering agent? That is your bismuth subcitrate. Bismuth subcitrate. Okay, this is the aspect. Now, if I'm telling antibiotics, so two antibiotics, what are the antibiotics we can use? So I'm going to give you a list of 4 antibiotics. So what are those antibiotics? Write down, that is only your amoxicillin. Okay, then there is a clarithromycin, clarithromycin. Then we can also use tetracycline. Okay, anybody can tell me any other drug? That is metronidazole. Very good. That is your metronidazole. So among these 4 antibiotics, any two. Among the 4, what is that? Any 2 antibiotics along with that 1 PPI, then it is a triple therapy. To triple therapy, if you combine, what is that? That is your covering agent, bismuth subcitrate, then we are going to call it as a covering agent. That is only covering agent called as quadruple therapy. Okay, so this is the story of your H. pylori treatment. All right. Okay, so if you know this much, there are some small things about treatment. See, I need to quickly review about treatment of vomiting. Along with treatment of vomiting, diuretics and the rest of the topics we will have to discuss, that we will discuss tomorrow. Is that okay for everybody? I know that. So these drugs has to be completed. That is the purpose of doing it very quickly. But the thing is that I want you people to understand these are the most important things to be remembered. So with this much being said, we will conclude here for today. So please tell me, have you people able to get all the information properly, assimilate all the information? Now, whenever you get a doubt, please drop it in the comment section. No problem. I'll clarify it. Okay. Now, let's start, right? So, yesterday I told that we will be doing the other systems as well. What are the other systems? Very good. Let's start with the most important system called as endocrine system. What is that? Endocrine system. Now, endocrine system, before going to endocrine system, from yesterday, whatever I taught you people, I will do a quick review of some points, some 6 to 7 points. You need to remember all those 6 to 7 points. There can be 2 MCQs from here only, especially from the topic of hypertensive, antihypertensive drugs. So what are those things? I told you people, what is the drug of choice for a patient with BPH and hypertension? Alpha blockers. A patient who is having diabetes mellitus and hypertension, drug of choice is the AC inhibitor. A patient who is having diabetes mellitus and diabetic nephropathy, again drug of choice is AC inhibitor. Now, for example, we talked about a patient who is having what is that, gout and hypertension, then we are preferring the drug as losartan, right? Which drug is not given in a patient with gout? That is thiazide diuretics. Okay. Now, let's start with the endocrine system. So when you want to learn the endocrine system, we have one organ called as hypothalamus. Now this hypothalamus will release some hormones which will control the regulation of pituitary gland. Okay. Now listen to me very carefully. Hypothalamus will stimulate the hormones, will release the hormones which will go and stimulate the pituitary. Now, when you look at a pituitary gland, now before going into pituitary gland, let's understand the basics of the pituitary gland. So when you look at a pituitary gland, now how does a pituitary would look something like this approximately? So pituitary gland would be divided into 2 divisions, majorly 2 divisions, but when we are speaking anatomically or histologically, we divide it into 3 divisions: anterior pituitary, intermediate and posterior. But overall you need to remember anterior pituitary, and there is something called as posterior pituitary, right? Now, when we need to understand about anterior and posterior pituitary, see, hypothalamus majorly regulates your anterior pituitary, guys. Majorly regulates your which pituitary? Anterior pituitary gland. But when you look here, posterior pituitary, this is a little bit different story. Let's start with that different story itself, right? Now, understand the first and most important aspect. So, posterior pituitary will store some hormones. Which are those hormones? Posterior pituitary will store some hormones. Which are those hormones? Those posterior pituitary hormones are, stored hormones are your vasopressin, and there is one more hormone, that is your oxytocin. Now, when we look at a pharmacological point of view, we have a different approach here. See, I'm not going to get into the physiology since it is a quick review session. So I'm going to teach you people some important aspects from the pharma side. Okay. Now, let's start with the vasopressin. Normally, vasopressin is also known as AK, also known as, what is that? That is your ADH, that is your antidiuretic hormone. Antidiuretic hormone. Now, this antidiuretic hormone, what it does is retention of water. Retention of water. All right. So retention of water is done by your antidiuretic hormone. Okay. Now look here, guys. What exactly I'm trying to teach you people is that now vasopressin, normally what happens is that, so vasopressin analogs are there. Vasopressin analogs. Vasopressin analogs. What are these vasopressin analogs? These are some artificial chemicals which work similar to that of vasopressin. Now, when you look at a vasopressin analogs, my dear students, we have drugs such as desmopressin. Okay. Now, we have one more drug called as telepressin. What is that? Telepressin. Okay. There is one more drug called as lipressin. If you notice here, all of this vasopressin itself, okay, all the drugs will have some common name, pressin. What is that? Pressin. Exactly, vasopressin, what exactly it does? Some of the most important, retention of the water, and also causes vasoconstriction. Vasoconstriction. So these are the important aspects of your, what is that? Of your vasopressin. Now, desmopressin, telepressin, lipressin. Now, where do we use them? Just imagine, I have a patient who is not having vasopressin. See, his body is not producing vasopressin. Now, what is my treatment? Give him artificial vasopressin. That's it. So, exactly what I'm going to use? Desmopressin, that is a vasopressin analog. It is used for diabetes insipidus. Which type? That is only called as central type of diabetes insipidus. What do I mean by central type of diabetes insipidus? See, it's very simple. ADH is produced from the central nervous system that will come and act on the kidney. If there is a pathology in the kidney, we call it as a nephrogenic diabetes insipidus. If there is a decrease of ADH production, we call it as a central diabetes insipidus, where there is a less amount of vasopressin, we are giving extra vasopressin, we are going to call it as a central diabetes insipidus. Okay. Now, for central diabetes insipidus, the drug used is a desmopressin. Okay. Now, apart from that, my dear students, there is one more MCQ oriented point. This is also a drug of choice for one disease, for something called as von Willebrand disease. Now, what is this von Willebrand disease? It is a disease in which what happens is that there is a reduction of the von Willebrand factor, okay, which is responsible for the stabilization of the factor number 8. But you people might be thinking, sir, what does it have to do with, what is that? Your clotting pathway. So, there is no direct mechanism, but it is said that it will increase the production of von Willebrand factor. He said that it will increase the production of von Willebrand factor. That is why we are going to use it. Now, telepressin and lipressin, widely where do we use them? Widely we use them in the treatment of esophageal, esophageal varices bleeding. What is this esophageal varices? Now listen to me very carefully. When a patient who is having a chronic liver disease induced by alcohol or any other things, if there is a chronic liver disease and a liver cirrhosis, what happens is that there is a dilation of the veins in the esophagus. Because of the dilation of the veins in the esophagus, those veins might rupture anytime. If there is a rupture of those veins, that person can end up into bleeding. During the resuscitation of the esophageal varices, we are going to use these drugs, telepressin and lipressin. But most importantly, desmopressin is used for what? Central diabetes insipidus. This is the most important points which you need to remember from the vasopressin analogs, which you should always remember. Okay. Now, once you know about this, my dear students, let's go to the next aspect. What is that? Oxytocin. Oxytocin. Now, what is this oxytocin story? Now, oxytocin story is very easy. Oxytocin story is very easy. What is that? Oxytocin, normally what is a function of oxytocin? The function of oxytocin, all of you very well know, it is responsible for uterine contraction. It is responsible for the uterine contraction. Okay, so if female is undergoing labor, during the labor uterus will undergo contraction with the help of a hormone called as oxytocin. Okay, now when you're talking about oxytocin, whenever it is working, it is lead to uterine contraction. So where do we use it as a drug? Where do we use it as a drug? We use it as a drug in which type of condition? It is used in the condition called as atony of the uterus. What is that? Atony of the uterus. If uterus of the female is not contracting, to contract the uterus of the female, we are going to use it, and also used for augmentation of the labor. Augmentation of the labor, but not for the induction, but augmentation of the labor. So if you need to promote the labor activity better when it is already happening, then you can give oxytocin, but not for the induction, of the labor. The next important aspect here, write down, there is one important aspect you people will always need to remember, that is called as lactogenesis. And there is one more term called as lactokinesis. Now understand, during breastfeeding, mother has to feed the baby, so milk has to be secreted. For the synthesis of the milk, you are needing one hormone called as prolactin, my dear students. What is that? Prolactin, my dear students. And apart from that, lactokinesis means for the movement of the milk from the acinus into the nipple means if milk has to come out from the breast, that movement of the milk will occur with the help of oxytocin. Again, this is a very important MCQ, which is lactokinetic agent, which is lactogenic substance. Okay. Now, the next important aspect is that oxytocin. Can anybody tell me oxytocin? Is there any other biological role of oxytocin? So don't forget this. Oxytocin's biological role, that is the most important role, is what is that? That is hormone of love. Hormone of love. What is a hormone of love? That is your oxytocin. So this finishes your posterior pituitary. Important aspects. Okay. Now, my dear students, we have one more thing. See, oxytocin will act on the receptor and it works. But there is something called as oxytocin antagonist. And there is one more thing, that is your progesterone antagonist. So these two are very important, progesterone antagonist and oxytocin antagonist. Now, oxytocin antagonist, we have a drug, but it is not a drug of choice for anything. The name of the drug, remember, that is only called as atosiban. Atosiban is what? Oxytocin antagonist, but it is not a drug of choice for anything. Yes, we have that drug. Now, progesterone antagonist, don't get confused. That is your mifeprostone. What is that? Mifeprostone, which is used for the MTP, medical termination of the pregnancy. During MTP, we use this drug, mifeprostone, along with the combination of misoprostol. You'll study the dose administration from the gynecologist. Okay. Now, once we understood about this, let's go to the next hormone, that is your growth hormone. My dear students, growth hormone, you need to understand what is that. From the hypothalamus, there is somebody coming, that is only your growth hormone releasing hormone. That will go and stimulate your anterior pituitary. Now, anterior pituitary will produce growth hormone. Now, this growth hormone will stimulate what is that? Growth hormone receptors. Now, this growth hormone receptor will produce something called as insulin like growth factor. factor. So it will produce insulin like growth factor. Now this will induce the growth in a human. Okay. So if your bones, etc., everything, if it has to grow, you require one hormone, that is your growth hormone, that acts by a what? That is acting by a insulin like growth factor 1. Insulin like growth factor 1. Okay. Now, what exactly happens is that there are two diseases. There is something called as acromegaly. Acromegaly. Okay. Now, acromegaly is what? It is seen in the adult patients. It is seen in the adult patient where there is an increase of the growth hormone. If there is an increase of the growth hormone, you will develop the symptoms such as the growth of what is that? Growth of the jaw, protrusion of the jaw. There is excessive cartilaginous growth. Now, my question, for me, I got this very interesting question. Okay. I was teaching growth hormone. I told him I told my students excessive growth of the cartilages. Okay. One student from behind, he raises his hand, all of a sudden he'll ask, sir, penis does not have a bone. Okay. Now, if there is more growth hormone, will it enlarge penis? And this is a serious MCQ also. If I ever ask you people, if more growth hormone, will it enlarge penis? Now, there is no enlargement of the penis because penis is made out of some tissue called as cavernosa and corporal tissue, which is more like a blood vessel, not a cartilage. So growth hormone increase does not enlarge the penis size. One myth busted for you people. Okay. Now what I can do? I can do the treatment of acromegaly. How can I treat the acromegaly? How can I treat acromegaly? We are going to use something called as, we can use somatostatin. Now, this somatostatin is what? See, you have a somatostatin. You need to focus on the word here. Statin means which will stop the effect of the growth hormone, which is produced by the body itself and also artificially also manufactured. Got it? Now, there is somatostatin is there. Its analog is there. Its analog. What is the name of the analog? Octreotide. Okay. Now, somatostatin analog, we have octreotide. Then we can use one more drug that is only called as, my dear students, pegvisomant. Okay. Pegvisomant is what? It is a growth hormone receptor antagonist. Again, this is one of the important MCQ, the mechanism of action of pegvisomant. But pegvisomant has one drawback. When you use a pegvisomant, it is like a drinking a peg. After a person drinks a peg, what will happen? Very good. After a person drinks a peg, what will happen? He will do all these things and he will develop, what is that? He will not be able to see the things properly, like that only. So pegvisomant will cause, this is a technique to remember. Okay. So this is a technique to remember. Pegvisomant causes visual disturbances. Yesterday also I told you people, what is that? There is one drug which causes visual disturbance from the anti-epileptics, that is vigabatrin. What is that? Vigabatrin? That is a GABA transaminase inhibitors. Okay. Now, let's go to the next important aspect. So, if there is a acromegaly, we are going to treat this person. Okay. Now, let's go to the next aspect. You people might be asking me, sir, for gigantism patient, why can't we use it? For gigantism patient, we need to rule out the cause for this. Okay. Because most of the time it is due to craniopharyngiomas. So, we need to go for a surgical treatment also. That is the important aspect. Okay. Very good, Ashwan. That is vigabatrin. Correct. Okay. Now, let's go to the next aspect. What is that, my dear? The next important aspect, somatostatin we understood, pegvisomant analogs we understood. Then the next important aspect, for example, patient is having a dwarfism. Means what? He is having a growth retardation. Or short growth. That time what we are going to use? We are going to use something called as GHRH, growth hormone releasing hormone analogs. So those analogs are somatropin. There is one more thing, that is somatorelin. Okay. So what is that? Somatropin and somatorelin. But I want you to remember at least this particular aspect, pegvisomant and octreotide. Octreotide is what? Somatostatin analog. Okay. If they ask you which somatostatin analog is used, then you are going to mark it as a octreotide. Here everybody? Now, Now, I will give you people one task. What is the task? What is the difference between acromegaly and gigantism? Now, you people will tell me gigantism is seen in children, acromegaly is seen in adult. But why do we have to classify it differently? Is there any reason? Find it out. If not, I'll tell you at the end if somebody will remind me that. Okay. Now, we understood about the dwarfism. Now, once we understood about the dwarfism, now let's go to the next important aspect. What is that next important aspect? We are done with the important related to growth hormone. Once we understood about growth hormone, my dear students, let's learn about prolactin. Okay. Now, prolactin is what? Understand prolactin. Prolactin is regulated by one substance, that is only prolactin inhibiting hormone, that is your dopamine. That is your dopamine. Now, prolactin inhibiting hormone is dopamine. Now, this dopamine, if there is an increase of the dopamine activity, that will lead to decrease of the prolactin. So, why we should know? Because, my dear students, you need to understand different treatment. There are different strategies of the treatment. I'll tell you the different strategies of the treatment for any other gigantism and any other thing. That is not a treatment strategy, but the treatment strategy will vary upon the cause of it. Okay, if there is a tumor, yes, you are going to go for tumor. So that is not the reason, but there is one more thing. Okay, now let's get to it. Now, dopamine will do what? Prolactin decrease. Okay, now we have a conditions called as, what exactly happens if there is a increase of prolactin caused by diseases such as prolactinoma. So it is a tumor which produces the prolactin. If there is a prolactinoma, what will happen? There is an increase of prolactin. It will inhibit something called as HPO axis, hypothalamo pituitary ovarian axis in the female, and it will also inhibit hypothalamo pituitary testicular axis in the male. So both of the axes are inhibited, means female will not be able to ovulate, male will not be able to generate the testosterone. Now what will happen because of that? It will lead to infertility. Okay, now understand one important aspect in gynecology also. You'll get to know any infertility, first thing you're going to rule out is prolactin or prolactin level. Okay, now what is the treatment for the prolactinoma? The treatment for the prolactinoma, what we can do? Dopamine agonist. If you stimulate the dopamine receptor, automatically there is a decrease of the prolactin level. Dopamine agonist drugs are your bromocriptine. We have drugs such as cabergoline. Okay, now among these two things, remember, cabergoline is the drug of choice because of its duration of action. It is a type of long acting. Okay, so you are telling about the growth hormone, right? So I'll clear that growth hormone thing. Very important aspect. What is that? The complete growth plate is fused in a adult. In the adult, there is no bone growth which can occur. After the fusion of the growth plate, if there is a more growth hormone, it will lead to acromegaly. But in the children, growth plate is not fused, so bones will also grow, so the growth will be symmetrical. That is why we call it as a gigantism. Okay, that is the reason. Now let's go to the next aspect. Bromocriptine is there, dopamine is there, dopamine agonist is there. Okay, now my dear students, I want you to understand one of the most interesting fact here is that there is a surgical treatment also for prolactinoma. The surgical treatment in the prolactinoma is your gamma knife and transphenyidal resection surgery also there. Okay, now the next important, if the pregnant female has any condition with hyperprolactinemia, any condition with increase of prolactin, you can use bromocriptine and cabergoline. For the tumor prolactinoma, cabergoline. For other condition, you can consider bromocriptine. Done? Let's continue. Now the next important aspect, once you understood about the prolactin, let's go to the next important organ, that is your thyroid gland. My dear students, during the thyroid gland, you need to understand what is that. That is a very, very important step. What exactly is that important step? Listen to me very carefully. Now, we have some hormone from the hypothalamus called as thyroid releasing hormone. It will go and stimulate the pituitary. It will go and stimulate the pituitary. Pituitary will produce your thyroid stimulating hormone. Now, this thyroid stimulating hormone will act upon the thyroid gland. Will act upon what? Thyroid gland. Thyroid gland. Now, this thyroid gland will produce T3 and T4. Will produce T3 and T4. So, this is how it is working. Okay. For this T3 and T4 production, you require a process called as a organification of iodine. Organification of iodine. Organification of iodine. So, this organification of iodine is done with the help of an enzyme. Done with the help of an enzyme called as thyroid peroxidase. Thyroid peroxidase. Okay, so simple as that. For the production of T3, T4, you require one hormone. What is that, sir? That is your thyroid peroxidase. Okay, why am I teaching you people this? Okay, so any patient who is having a thyroid related disorder, he will have any two of these possibilities. One of them is hyperthyroidism. Hyperthyroidism. Okay, then there is a possibility that hypothyroidism. For the patient who is having a hyperthyroidism, the causes for hyperthyroidism, I'll tell you the most common cause you need to remember, that is a Graves' disease. It is a type of autoimmune disease. It's a type of autoimmune disease. In this autoimmune disease, what happens is that there is a long-acting stimulatory antibodies to the TSH receptor. If you want to write down, there is a long-acting TSH and there is a long-acting antibody to the TSH receptor which will stimulate the TSH receptor in the Graves' disease. So during this condition, what we are going to do? We are going to inhibit TPO, thyroid peroxidase, thyroid peroxidase inhibitors, thyroid peroxidase inhibitor. The drugs we have are carbimazole, and there is one more drug called as methimazole. What is that? Methimazole. What is that? Methimazole. And there is one more thing, that is your propyl thiouracil. Propyl thiouracil. So these are the three drugs we have. Okay, now what and all you need to know from pharmacology side. Now I'll tell you people the first and most important thing, this propyl thiouracil is a very, very important one. What is that? Because it will cause some side effects. It will cause some side effects. What are those side effects? Can anybody tell me? So all of you might be knowing, that is agranulocytosis. Agranulocytosis. Yesterday I told you people one more drug will cause agranulocytosis, that is your clozapine. That is your clozapine. Apart from that, it is causing one side effect, that is black box effect, we call it as black box effect. This is the most dangerous side effect, that is your hepatitis. Hepatitis. These are the two side effects which can be produced as a result of your propyl thiouracil. But the most important aspect is that if a pregnant female comes to you, definitely MCQ will come. MCQ will come. So let's see, if a pregnant female with a hyperthyroidism, pregnant female with a hyperthyroidism. Now, the pregnant female with a hyperthyroidism, what exactly we are going to do? Now, listen to me very carefully. Pregnant female who is having a hyperthyroidism, what we need to do is very, very easy to understand. So, understand, if there is a first trimester, okay, if she is a first trimester pregnant female, then the drug of choice is your PTU, my dear students, that is propyl thiouracil, because of one thing, it is not having major effects on the fetus. That is why we are using it in the first trimester. What is that? Drug of choice is propyl thiouracil. After first trimester, then you can use carbimazole. You can use carbimazole, or you can use methimazole, methimazole. So these are the two important aspects I want you people to remember. What is that? Carbimazole and methimazole. These are the two side effects, two drugs which are very important for you people to understand. Why they are important to understand? Because these are the drugs which can be asked as a MCQ. The first trimester drug of choice is propyl thiouracil. This question has been asked again and again, so please be ready with it. Okay, now, so all of you know about this. Then let's go to the next aspect. What is that, my dear students? If there is a hypothyroidism, 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 what we are going to do? If there is a hypothyroidism, then we are going to do is very simple. What exactly is that for the hypothyroidism treatment? The treatment is very simple, guys. What exactly is that? The treatment is your levothyroxine, that is L-thyroxine. What is that? L-thyroxine. L-thyroxine. Now, L-thyroxine is a type of analog of T4. It is the analog of T4. Very good, L-thyroxine. Apart from L-thyroxine, nowadays we have one more drug that is only called as thyronine. Thyronine. It is a T3 analog. It is a T3 analog. T3 analog. Now, this thyronine is a T3 analog which is used for emergency situation. Which is used for the emergencies. Okay. It is not used for long-term management, but thyronine is used for what is that? That is for the T3 analog which is used for the emergencies. Okay. So this can be asked as a MCQ. That is little bit latest into the syllabus. Okay. Now let's go to the next aspect. What is that? We understood about the thyroid gland. Once you understood about the thyroid gland, let's go to the next important aspect. What is that next important aspect, my dear students? That next important aspect which you need to learn, must and should, is your which gland? Adrenal gland. What is that? Adrenal gland. We are going to learn about corticosteroids. What is that? Corticosteroids. So corticosteroids is a major and massive topic which will come in many places, but I will give you all the important points which will cover everything needed to know. But I want you people to pay very much attention when I'm telling you people, learn this point, learn that point. When I tell this, you need to be very, very attentive. Okay. Now, what exactly is that? Corticosteroids. Understand, you have your adrenal gland. You have your adrenal gland. In the adrenal gland, you have two regions. This is your adrenal medulla. You have adrenal cortex. Okay. Now, this adrenal cortex is responsible for the production of corticosteroids. This adrenal medulla is responsible for the production of mineralocorticoids. And also it is responsible for the production of testosterone. Now listen to me very carefully. We have some important aspect. What is that? That is three layers: zona glomerulosa, zona fasciculata, zona reticularis. These are the three layers of the adrenal cortex. So zona glomerulosa. Okay, zona glomerulosa will produce your mineralocorticoids, my dear students. What it will produce? It will produce your zona glomerulosa will produce your mineralocorticoids. Okay, glucocorticoids are produced by zona fasciculata, and zona reticularis will produce this testosterone. Okay, now understand, this particular gland is controlled by your one thing. What is that? In the hypothalamus, it will produce something called as corticotropin releasing hormone that will go and stimulate your anterior pituitary. Your anterior pituitary is going to produce what? Your anterior pituitary is going to produce your ACTH. Now this ACTH, my dear students, will stimulate which layer? The layer is, it will stimulate the fasciculata layer. If it's stimulating the fasciculata layer, it will produce your glucocorticoids or corticosteroids. This is how your body is working in the process of making of corticosteroids. But the thing here you need to understand, we have something called as, from outside we have steroids. We call it as a exogenous corticosteroids. So basically exogenous glucocorticoids. Exogenous glucocorticoids. Now, when you look at exogenous glucocorticoids, my dear students, please understand some important aspect. What exactly is this important aspect? See, exogenous glucocorticoids, they are given from the outside of the body. So, what are the mechanism of actions of these steroids? So, this works similar to that of steroids in the body. This works similar to that of steroids in the body. So, mechanism of action, the first and most important, they are anti-inflammatory. They are anti-inflammatory. If they are anti-inflammatory, how exactly they will anti-inflammatory? Because they will inhibit one enzyme, that is only your phospholipase. There is one enzyme called as phospholipase. It will inhibit an enzyme called as phospholipase. Because of that, they will produce anti-inflammatory effect, and because of the same reason, they are also anti-allergic drugs. Okay, so why? Because they inhibit the phospholipase. So what is the role of this phospholipase? You can understand there is something called as phospholipids. Now these phospholipids will break down into arachidonic acid. Now this arachidonic acid will produce prostaglandins and leukotrienes Okay, now prostaglandins are responsible for the inflammation, and your leukotriene are responsible for the allergy. Okay, now where does our phospholipase come? Here, phospholipase. Now, if I inhibit this phospholipase, phospholipid will not get converted into arachidonic acid, so no inflammation, no allergy. No inflammation, no allergy. Here, everybody, this is how you need to remember. Now, apart from that, guys, what and all it will do? Other things. Other things are, it is immunosuppressive in nature. Immunosuppressive in nature. Immunosuppressive in nature. Why? Because they will increase leukocyte, means WBC, leukocyte apoptosis. Since they are causing the leukocyte apoptosis, means if leukocytes die much quickly and faster, automatically what is going to happen? Leukocytes are dying. If leukocytes are dying, immune system will go down. If it is immunosuppressive in nature, because of which there is one side effect. If your immune system become weak, you will get opportunistic infections. Okay, then one more use is there, because you can suppress the immune system, they can be used during the organ transplant. Got the logic? Here, everybody? Okay. Now, the next important aspect, what is that? The next important aspect of this drug, these drugs, my dear students, they will cause, what is that? They will cause increase of the blood glucose. By what? By gluconeogenesis. By gluconeogenesis. What is gluconeogenesis? Synthesis of glucose from a non-carbohydrate source. We call it as a gluconeogenesis. They will increase the gluconeogenesis in the liver, leading to elevated blood glucose. So automatically they are contraindicated in diabetes mellitus. Even if used, maintain the sugar level. So that is what during the COVID time there was a lot and lots of steroids used. So all the time steroids used, we need to advise our patients, or even we need to advise our young doctors to do what? To make sure that patient, if he's a diabetic, make sure to maintain his blood glucose level. That was the reason, because gluconeogenesis. And my dear students, they will also increase the blood pressure by what? By sodium and water retention. Now, if you people think about this, you people might understand, sir, yesterday you told us something, aldosterone also does the same thing, right? Yes, like aldosterone. Aldosterone is what? Mineralocorticoid. Glucocorticoids can work like a mineralocorticoid. This is also important point to be remembered. This is also a very important point to be remembered for you people. Okay. Now, Now, the next important, so you understood about sodium water retention, okay? Now, let's go to the next aspect. Guys, these steroids, for example, whenever you look at a steroids, they will cause increased activity of osteoclast. If they increase the activity of osteoclast, automatically they will lead to what? They will lead to one problem called as osteoporosis. So if you use these drugs for a longer period of time, osteoporosis can occur. Okay, now they will also cause, my dear students, fat redistribution. So if they are causing a fat redistribution, means they will accumulate the fat in one area from another area, leading to what is that? That is your central obesity. Even we can use a specific androgenic obesity or android obesity. We can call it as a android obesity. Now, apart from that, basically all the fat will accumulate. Where exactly? In the upper parts of the body, especially in the trunk and the face and the neck. So because of that, the face of the person, if you use this drug for a longer period of time, it will become, all the fat accumulated will become round. So we call it as a moon face. My dear students. And exactly, fat can also accumulate in the back of the neck, leading to something called as buffalo hump. Now, if you look here, what is that I'm trying to tell you people? Because of the fat redistribution. So, if there is a more of glucocorticoids from the body itself, are endogenous glucocorticoids more? Same effect. Exogenous glucocorticoids are more? Same effect. Okay. So, it is only called as Cushingoid behavior. Let's go to the next aspect. So let's understand some uses of the glucocorticoids. They are anti-inflammatory. Means they are used in the inflammatory diseases. Such as osteoarthritis, rheumatoid arthritis. For example, if a patient is not having an adrenal gland, see, surgically I removed both the adrenal glands. In that patient, I need to give what? Steroids. So basically, what is that? Replacement therapy. Okay. Apart from replacement therapy, for example, if adrenal gland is not working, we call it as a Cushing syndrome or Addison's disease. It is called as Addison's disease. They are used in the Addison's disease. Okay. Apart from Addison's disease, they're used in many other conditions. Agree with you people. So based on the requirement. Okay. For example, we use them for the treatment of keloids. Okay, we use them for the treatment of allergy. So the uses of the steroids become a wide range. The side effects of the steroid is very important. What is that? My dear students, side effect of the steroids, already you know, osteoporosis. Then there is a infections, that is opportunistic infections. Okay. Apart from opportunistic infections, then there can be peptic ulcer disease. Because there is no protection to the stomach, because there is no arachidonic acid synthesis. Now, apart from that, steroids can also lead to one of the most important and interesting aspect. What exactly is that? That is your fat redistribution. So I told you what happens in the fat redistribution. What happens here? That is android obesity, moon-like shape, moon-like face, and a buffalo hump. Okay. Now, apart from that, steroids, my dear students, these steroids are very interesting drugs in the eye. They will cause two side effects. What are the two side effects? One of them is glaucoma. Another one is cataract. But the problem here is that they will ask you when cataract will come, when glaucoma will come. Then what will you say? So glaucoma will come, my dear students, if the drugs are applied directly in the eye, if there is a topical usage, topical use, then we are going to get glaucoma. Topical use, then we are going to get what? Glaucoma. If there is a systemic use, if there is a systemic use for a longer period of time, they can lead to your, what is that? That is your cataract. Okay. Other uses, such as you can use them in ulcerative colitis, Crohn's disease, though other drugs are there, along with them we can combine them. These drugs are used as a chemotherapeutic agents also. Okay. Now, let's continue to the next aspect. What is that next aspect? Guys, the next important aspect about the steroids, guys, steroids, when you are using them, so you need to do something what is called as dose tapering. From pharmacology side, it is very important. Dose tapering must be done. Dose tapering must be done. What do I mean by dose tapering must be done? Now, listen to me very carefully. You give a steroid to a patient for 10 days. For how many days? 10 days. So 10 days he took the steroids. If he's taking the 10 days of steroid, now what happens? Let's go back and see what happens here is that. So, if you remember, if he's taking the steroids for 10 days, if he's taking the steroid for 10 days, basically you are giving the corticosteroids from outside. Now, the steroids will go and give negative feedback to ACTH. Negative feedback to anterior pituitary means there is a decrease of ACTH production. Now, listen to me very carefully. If you use it for 10 days and stop them suddenly, if they're suddenly stopped, if suddenly stopped due to this negative feedback, continuously your steroids are telling not to produce, what is that? Not to produce the cortisol. If there is no cortisol, suddenly if you stop, do you have ACTH? No ACTH. No ACTH. Suddenly patient will develop acute adrenal insufficiency. So when the person develops acute adrenal insufficiency, treatment will be what? Again, you're going to give IV steroids. So to avoid this acute adrenal insufficiency, rather than stopping the drug all of a sudden, dropping the drug all of a sudden, we will drop it slowly. Means we will reduce the dose day by day, so that your body has time for the adaptation. So that is why dose tapering must be done. Clear? Anywhere if you hear a term tapering means what? To decrease the dose slowly. Okay. Now, yes, you are right. Intraocular pressure increases. That means it is causing glaucoma. Glaucoma is nothing but elevated intraocular pressure. Very good. Let's go to the next aspect. What is that next aspect? The drugs, steroid drugs we have. So what are the drugs we have? All the steroid drugs are divided into three groups. They're called as short-acting drugs. They're called as intermediate acting drugs. Then there is something called as long-acting drugs. What are the three groups? Short-acting, intermediate-acting, and a long-acting drug. Now, among these things, short-acting drug, we have something called as cortisone. We have one more drug, hydrocortisone. What is that? Hydrocortisone. So, short-acting drugs are used for what? Emergency. Okay. Then we have intermediate drugs. We have a drug called as prednisone. We have one more drug called as prednisolone. Okay. We have one more drug. What is that? Methylprednisolone. Okay. Apart from methylprednisolone, see, prednisolone and methylprednisolone, they both are available in the form of a tablet. If you can't remember, it's not so much to be worried. Okay. Now, prednisone, methylprednisolone. Apart from that, Budenoside is available in the form of inhalation, for the treatment of asthma, for the treatment of bronchial asthma. It is available in the form of a inhalating agent. Okay. Now, long-acting drugs. We have a drug called as dexamethasone. Now, apart from that, we have one more drug called as betamethasone. Okay, beta-methasone and dexamethasone. We have one more drug called as paramethasone, but I want you to understand what is this dexamethasone. Dexamethasone is used for what? It is used for the preterm labor. During the preterm labor, we use this dexamethasone to cause the fetal lung maturation. Okay, usually the preferred drug is dexamethasone, but sometimes we can also go for betamethasone, nothing to worry. Okay, this is a story of your, what is that? Steroids, my dear. What is that? Steroids. Understood? Okay, once you understood about the steroids, let's go to the next important aspect. What is that next important aspect? That next important aspect is your, what is that? That is the most important topic, that is diabetes. Which diabetes? Diabetes mellitus. Diabetes mellitus. So when you're talking about diabetes mellitus, guys, understand the diabetes mellitus topic. It is very easy for you people, but you need to learn a lot of information here, and I'll teach you all the important aspects which are required for your exam. Okay. Now, when we are learning about diabetes mellitus, so we have type 1, diabetes, we have type 2 diabetes. So type 1 diabetes and type 2 diabetes mellitus. Here, what happens in type 1 diabetes mellitus? What is that? Insulin dependent. Means what is that? There is a decreased insulin. But in type 2 diabetes mellitus, there is sufficient amount of insulin. But the problem is that insulin resistant. Okay. Now insulin resistance is there. Along with that, sufficient amount is there for what? Basal level of insulin is there, but postprandial is totally different. Postprandial insulin will be affected. Apart from the postprandial insulin, there is one more problem here, that is relative hypoinsulinemia. Okay. Now, in both of these conditions, there is an increase of blood glucose. Our treatment is what is that? Treatment is your, what is that? That is your to decrease the blood glucose. So the first group of olden group of drugs, they are your biguanides. What is that? Biguanides. In the biguanides, we have drug called as metformin. Along with metformin, we have one more drug called as fenformin. Very good, Yashwant, you're right. Okay. Now we have a drug called as metformin and fenformin, but metformin is a widely used drug, and there is a lot of important MCQs related to biguanide metformin. So the first important, how does this drug work? Mechanism of action. The mechanism of action, it will inhibit hepatic glucose synthesis. So it will stop the synthesis of the glucose from where? From the liver. So once glucose from the liver production is reduced, automatically blood glucose level will be reduced. That is the point you need to understand. So what happens here? There is a decreased level of blood glucose as a result of what? Inhibition of very important hepatic glucose production. Means this drug will go and tell the liver, hey liver, you don't stop, you don't produce more glucose. Like that only it is working. But the problem here is that there are some side effects. What are the side effects caused by metformin? Metformin will lead to something called as megaloblastic anemia. It will lead to a problem, megaloblastic anemia. Okay. Apart from the megaloblastic anemia, is there anything else? Yes. If used in a patient with what is that? Renal failure. If used in a patient with a renal failure, then automatically, my dear students, it will lead to something called as lactic acidosis. So these are the few important points you need to remember from the side of metformin. Okay. Now apart from that, it will affect the weight. Agree with you. But the most important ones which you need to know is megaloblastic anemia and lactic acidosis. acidosis. Okay. Now, once you understood about this, let's go to the next important drug. What are those drugs? They're called as sulfonyl ureases. Sulfonyl ureases. Now, these sulfonyl ureases, we have many drugs, my dear students, but what exactly they are going to do? These drugs will increase the insulin production. Will increase the insulin production. Okay, now if they're increasing the insulin production, now you might be thinking, sir, they're more used in which condition? Diabetes mellitus type 1 or type 2? They're used for type 2, but still they're increasing the insulin production and also improve the resistance by increasing the sensitivity. They also slightly increase the sensitivity to insulin. They will increase the sensitivity to insulin as well as your, what is that? They will increase your insulin production. There are drugs such as tolbutamide. We have such as glicazide. We have drugs such as glimepiride. So remember, glimepiride, very commonly used drug, glimepiride, along with metformin. Okay, then apart from glimepiride, we have one more drug. What is that? Gibanclamide. Actually, if you are speaking, if at all we were learning, like, full syllabus, there are 2 generations we could have gone into that one. Okay, but you need to remember at least this ones. Okay, tolbutamide is one drug which undergoes zero order kinetics. But only substance which undergoes truly zero order kinetics is followed by only one drug. What is that? One substance in the body. Tell me. Truly zero order kinetics is followed by only one substance in the human body. Which is that substance? I taught you people already. That substance is your alcohol, my dear students. What is that? Alcohol. Okay. Now, let's go to the next important aspect. What exactly is that? Guys, we eat food, right? Food consists of starch, basically. Now, this starch, my dear students, under the effect of an enzyme called as alpha glucosidase, under the influence of an enzyme called as alpha, that is alcohol. The answer is alcohol. Very good. Ethanol. Very good. Okay, now listen to me very carefully. Starch under the effect of alpha glucosidase, what will happen is that it will, my dear students, what will happen? It will convert into glucose and it will get absorbed. Now, exactly what we are going to do? We are going to inhibit the alpha glucosidase. The alpha glucosidase inhibitor drugs such as acarbose, maglitol, and we have one more drug called as ogilibos. Okay, so these 3 drugs will inhibit the alpha glucosidase. Now, because of this drug, listen to me very carefully. Alpha glucosidase is inhibited. Now, glucose is not formed. Glucose is not absorbed. If glucose is not absorbed, automatically blood glucose levels are less. But the issue here is that if you notice, all this starch, whatever is there, now this starch will enter into the feces, leading to flatulence, excessive flatulence. Okay. Now, the question is that when do we take this drug? When to take this drug? Okay, options I'll give you. Option A, before meal. Option B, after meal. Option C, between food. Option D, none of the above. Okay, so when you look at this, yes, gas, that is only flatulence will be the side effect. So when do we take this drug? Understand, between the food means what? Means whenever person is eating the food. So if you tell this patient what you need to do, you ask the patient to take this tablet. How exactly? You'll ask him, okay, while eating the breakfast, eat half of your breakfast, take the tablet, then finish the breakfast. not postprandial, not before meal, nothing. With the food, between the food, like if he's having 2 idlis, we will ask him after eating 1 idli, take the tablet, then you do what? Then you complete the second idli. Like that only we need to advise the patient. Okay, so please don't get confused. Clear, doctors? Very good. The next important, this is the MCQ what you can get from this particular group of drugs, most likely if you get also. Okay, then let's go to the next group of drugs. What is the next group of drugs? There is one more drug called as amylin analog. What is that? Amylin analog. Okay, now when you're talking about amylin analog, my dear students, it will decrease amylin. Normally it will decrease the blood glucose. Okay, it will decrease the blood glucose. The drug what we have is called as pramlintide. Okay, so this pramlintide is what? Listen to me very carefully. This pramlintide is a amylin analog. If you notice here, the drug itself will contain amylin in its name. Okay, pramlintide. Okay, now pramlintide is a amylin analog. It is used for which condition? Used for both of the diabetes, both type 1 and type 2 diabetes mellitus. Both type 1 and type 2 diabetes mellitus, it can be used. Clear? So this is your amylin analog. Okay, now there is one more drug, sir. What is that? My dear students, we have something called as incretin mimetics. Okay, now if you need to understand incretin mimetics, you need to understand incretin. So what exactly incretin does? Incretin, my dear students, it will increase the insulin production. It will increase the insulin production and decrease the blood glucose. This is a function of your incretin. Now if you use an incretin analog, what is that? Incretin analog, then what will happen? Let's see. Okay, now incretin is there. Incretin is also known as GLP, glucagon like peptide 1. GLP-1. Okay, now listen to me. We have incretin. Now this incretin is metabolized into its products, by one enzyme called as dipeptidase. Dipeptidase 4, DDP4. We can also call it as a DDP4, my dear students. So now listen to me very carefully. Normally body will produce incretin. Incretin is produced from which cells? From physiology you should answer this, from the L cells. Incretin is produced from the L cell. Now incretin will increase the insulin production and decrease the blood glucose. But in the body, incretin is metabolized by an enzyme DDP4. Now you can do few things. What is that? You can do one thing. What is that? Incretin mimetics. Incretin's analogs. So if you are using incretin analogs, can anybody tell me incretin analogs? So we have a drug called as exenatide. What is that? Exenatide. And we have one more drug called as liraglutide. So these two drugs, exenatide and liraglutide, these are the incretin analogs. We can do one more thing. What is that? DDP4 inhibitors. These DDP4 inhibitors are your gliptins, my dear students. What are those? Gliptins. Okay, now if you want to understand, now please understand. So we have exenatide, okay, we have liraglutide. Okay, now listen to me. DDP4 inhibitor, gliptins. The drugs are vildagliptin. Okay, then we have drugs such as sitagliptin. Okay, then apart from sitagliptin, then vildagliptin, we have one more drug, that is saxagliptin. That is your saxagliptin. Okay, all of these gliptins, they can ask you directly mechanism. Okay, now both of these drugs can lead to one side effect. What is that side effect? Can anybody tell me? Can cause pancreatitis. Pancreatitis. Okay, so both of these drugs, gliptins, okay, ritagliptin, yeah, all the gliptins, okay, sita, okay. Now, listen to me very carefully. The both drugs can cause pancreatitis, my dear students, okay. Both of these drugs can cause pancreatitis, okay. Now, once you understood about this, let's go to the next important group of drugs. There can be a very important MCQ. What is that? My dear students, we have SGLT2 inhibitors. SGLT2 inhibitors. Now, SGLT2 inhibitors, how do they work? I'll tell you people, listen to me. If you consider this is your nephron, right? In the nephron, what happens is that whatever glucose which get filtered into the nephron, it used to get reabsorbed with the help of SGLT2 in the kidney. With the help of SGLT2 in the kidney. Now, if I block this SGLT2, automatically glucose will go into urine. Which will lead to decrease of blood glucose. Okay. At the same time, more glucose in the urine. This is the story you need to remember. Okay, so basically we are stopping the reabsorption of glucose. They will do what? Inhibit glucose reabsorption. From where? Reabsorption from can anybody tell me? From the proximal convoluted tubule of the nephron. Okay. Now, these SGLT2 inhibitors, the drugs we have are your one of the most important aspect. What is that? They are your dapagliflozin. Okay, dapagliflozin. Okay, so we have one more drug, that is canagliflozin. Okay, now all the gliflozins, dapagliflozin, canagliflozin, all these drugs will cause SGLT2 blockade. Yes, present only in the kidneys, but SGLT1 is present only in the intestine. Okay. Now, once you understood about this, my dear students, please understand the next aspect. What is that next aspect? The side effects of this drug. What is that side effect? Increase of the glucose in the urine. Okay, if there is an increase of the glucose in the urine, that will lead to more glucose in the urine, means more bacteria can get accumulated in the urinary tract, or more bacteria can grow in the urinary tract, leading to urinary tract infections. And genital infection is a very common side effect caused by SGLT2 inhibitors. This is a very, very important aspect. Very good. Understood everybody so far whatever I told you, people? Understood? So the last and most important drugs which I want to teach you people, glitazones. Okay. Now glitazones belong to a group called as thiazolidinediones. Even if you can't recall the name, I want you to remember this much. What is that? Glitazones. Okay. So what is this glitazones? The classic example, we have a drug called as pioglitazone. The mechanism of action is what? They are insulin sensitizers. What do I mean by insulin sensitizer? How do they act? I will teach you people how do they act very easily. Listen to me very carefully. If you take a cell, inside the cell there is a nucleus. On the nucleus, we have some receptor called as PPAR receptors. Now, PPAR receptor, I told you, paroxysmal proliferative activator receptor. Paroxysmal proliferative activator receptor. Now these PPAR receptors are divided into two types, PPAR alpha, PPAR gamma. Now these PPAR alpha receptors, which drugs exactly act? They are fibrates. The drugs which act on the PPAR alpha receptors are fibrates, which decrease the fat or cholesterol level in the body. Now, these glitazones, if PPAR gamma is stimulated by which drugs? Glitazones. Now, this PPAR gamma stimulation will lead to what? PPAR gamma stimulation will lead to insulin sensitivity. Insulin sensitivity. So this is the story of your anti-diabetic agents, all the important MCQs related to it. Here everybody? So this is a quick review of your endocrine system. So let's take a small break of 5 to 6 minutes, about 5 to 6 minutes. Then we will come back and continue with our chemotherapy and antibiotics. All right, guys, welcome back. So we discussed about what is that? Diabetes mellitus. Okay, apart from diabetes mellitus, we discussed about steroids, thyroidism. Okay, then apart from that, we discussed about other drugs as well. Now, once we're done with that, let's get into one of the most interesting and important aspects. So everyone back? Okay, so let's get into the topic. The name of the topic which we are going to discuss is your antibiotics. My dear students, antibiotics is a very important and understand antibiotics for clinical practice will become very important for you people. Why? Because clinically speaking, there are so many antibiotics which you might require for the usage, which have there is a very objective things which happens with the antibiotic also. See, there's a rational treatment. Along with the rational treatment, there are some objective things because there is something called as concept of P drug. P drug. So because of this concept of P drug, there are some cases which some drugs might vary. Okay, but you need to understand the antibiotics. Now, when we need to understand the antibiotics, so please understand first what happened. I had a fungus with me. Listen to this story. I had a fungus. Okay? This fungus was sitting quietly here like this. Fungus was sitting quietly here. Now what happened is that to this fungus, whatever sitting quietly, some bacteria came and infected the fungus. Look at this. Bacteria came and infected the fungus. Now fungus got very irritated. How can you infect me? Fungus will produce some chemical. Fungus will produce some chemical. Now this chemical will go and kill the bacteria. Look at this. Fungus will go and kill the bacteria. So the chemical, whatever it came out from here, this was an antibiotic. So that is how the antibiotic discovery started. So the first antibiotic penicillin was from the fungus itself. So there are some antibiotics which are naturally produced usually from fungus. Now, I'm trying to tell you people is that antibiotics are the chemicals which might try to kill the bacteria, Now, when we need to understand the bacteria, when we need to understand the bacteria killing agents, these are your antibiotics. So please guys, see, it's very easy to understand. There are types of antibiotics. What are those? There are antibiotics. They're called as cell wall synthesis inhibitor. So cell wall synthesis inhibitor. Now cell wall synthesis inhibitors. What are these cell wall synthesis inhibitor? So cell wall synthesis inhibitor are any such antibiotics which will stop the bacterial cell wall growth. If bacterial cell wall growth is being stopped, okay, now that is going to automatically kill the bacteria, leading to a effect called as a bactericidal effect. Bactericidal effect. What is that? Bactericidal effect. So bactericidal effect can be achieved from your, which is that cell wall synthesis inhibitors, right? When we need to understand the cell wall synthesis inhibitor, in the cell wall synthesis inhibitor, the first group of antibiotics we have are penicillins. What is that? Penicillins. So penicillins, my dear students, we have some penicillins which are naturally derived penicillins called as natural penicillins. Natural penicillins. Natural penicillins, we have drugs such as penicillin G, okay, penicillin G. Now this penicillin G and also some penicillin V, these both are considered to be what is that? Natural penicillins, okay. Now apart from that, we have some penicillins which are orally used. Those orally used penicillins, the orally used penicillins are your aminopenicillins. These aminopenicillins, the drugs are amoxicillin. Then we have one more way called as ampicillin. Okay, so these antibiotics, what are these? These penicillins orally used are aminopenicillin, and aminopenicillins have amoxicillin and ampicillin. So there are other types of penicillin, but majorly I'm focusing on which are majorly widely used in our clinical practice and exam, since it is a review point of view we are going on here. Okay, now apart from that, see, penicillin, whenever you learn about antibiotics, you have to know about something called a spectrum. spectrum. Spectrum means to what range of bacteria this antibiotic can kill. So the antibiotics can kill all the microorganisms in the existence. Possibility number one, the bacteria can kill only gram-positive bacteria. The bacteria can kill only gram-positive and gram-negative bacteria. So based on its effect on different microorganisms, we divide the spectrum. The spectrum of these antibiotics they usually kill the gram-positive. Okay, so gram-positive bacteria, we have, what is that? Gram-positive bacteria can be killed. And most importantly, cocci can also be killed. So cocci such as, for example, meningococci such as, for example, meningococci. Apart from meningococci, we have one more thing, that is gonococci. Okay. Now, when you understand about the penicillins, so you need to focus on some of the basic important aspects. What are those basic important aspects? My dear students, this penicillin's mechanism of action is very easy to understand. They inhibit, first most important thing, the cross-linking in the cell wall. Basically, if the cell wall of the bacteria has to be produced, there should be a proper cross-linking of the substances in the cell wall. If there is no cross-linking, there is no formation of the cell wall. If there is no formation of the cell wall, so that will be what? Yes, it will be posted here. Okay, so then what will happen? Bacteria will not be growing, whether it will die, rather it will die. Now, cross-linking of the cell wall will be inhibited. The second aspect is that something called as a penicillin binding proteins. Now, this penicillin binding proteins is what? In the every bacteria, there are some aspects of the bacteria itself where penicillin will go and sit, and it will stop the growth of the cell wall. See, penicillin will go and bind to a place called as a penicillin binding protein, which is present in the bacteria, and stop the cell wall synthesis. This is also one more mechanism. One more mechanism of the penicillins. These are the two important mechanisms. Okay. Now, next important aspect, guys. The uses of the penicillins. I am going to tell you few uses, and apart from that, as you study specific infection, the antibiotics will be added according to that also. Okay. Now, we are going to learn about the uses. They are used for meningococcal infection, then they are used for gonococcal infection. They're used for one more aspect. What is that? That most important aspect, my dear students, in the treatment of syphilis. Okay. Now, in the treatment of syphilis, after penicillin usage, there will be what? There will be, can anybody tell me? There will be something called as Herxheimer phenomena. Basically, what is this? This phenomenon is a simple thing. This is a type of immunological response to the penicillins during the treatment of syphilis. We call it as a Jarisch-Herxheimer phenomena. Actually pronounced as a Harish-Herxheimer phenomena. Okay. Now, apart from syphilis, they are also used in the patient with rheumatic fever, my dear students. Rheumatic fever. So rheumatic fever is usually a pediatric condition, but to prevent, what is that? That is your autoimmune diseases in the further, and other destruction. We are going to apply this antibiotic as well. Especially in the rheumatic fever, we use a penicillin called as benzathine penicillin. This benzathine penicillin is used intramuscularly. Okay. Now these are few uses about penicillins. Okay. Now there are some facts also you need to remember. Penicillins usually paraenteral route of administration. Most of the penicillins should be used paraenterally except for few orally used penicillins. Okay. Now, usually paraenteral. The next important aspect, they have wide therapeutic index. Wide therapeutic index. Okay, so this is some interesting things to be known. Okay, so once you understood about the penicillin, then there is one more penicillin, that is your methicillin. There is a penicillin called as methicillin. What is that? Methicillin. Now this methicillin fellow, what he's going to do? Now what he's going to do is that this methicillin is not used clinically. Clinically we are not going to use it, but rather used in the laboratory for what? Laboratory to determine, to find out something called as what is that? Resistance of what is that? Of the Staphylococcus aureus to methicillin. If the bacteria that is Staphylococcus aureus, if it is resistant to methicillin or not resistant to methicillin, to find out that we are going to use methicillin. Now what is the use? Now understand, if the Staphylococcus aureus, whatever we checked, if it is sensitive to what? Methicillin. If it is sensitive to methicillin, means if it is getting killed by the methicillin, then we are going to treat the patient with penicillins. Okay, now for example, you find resistance, then my dear students, we call it as a MRSA, methicillin resistant Staphylococcus aureus. In that condition, drug of choice will be your vancomycin. Now this vancomycin again is a type of cell wall synthesis inhibitor. Now this vancomycin is a drug of choice for MRSA. Now vancomycin also used for one more condition, for something called as pseudomembranous enterocolitis. So for the pseudomembranous enterocolitis also, the drug is your again vancomycin. Everybody clear so far? So here we discussed about few antibiotics. What are those? That is your vancomycin done, penicillins are done. Let's go to the next aspect. My dear students, next aspect, there is something called as cephalosporins. Now cephalosporins, I'm not going to waste much time. Cephalosporins, I will tell you all the facts which you need to know. Now listen to me. Cephalosporins are 5 generations. Okay. Now in that, most commonly used are your third generation cephalosporins, such as cefixime, okay, ceftriaxone. Now, when I'm trying to tell you people cefixime and ceftriaxone, understand ceftriaxone is the drug of choice. This is a very controversial question. Drug of choice for what is that? Empirical treatment. What is that? Empirical treatment of meningitis. Empirical treatment of meningitis. For the empirical treatment of meningitis, what is the drug? That is your ceftriaxone. Remember this particular. Empirical treatment means what? You might be having, sir, what is empirical treatment? Now, you get a patient who is having what is that? Meningitis, right? Now, meningitis, you can have a clinical diagnosis, but before finding the cause, there are two aspects. Before finding the cause, after finding the cause. After knowing the cause, specific treatment will be given. But before finding the cause, what is the treatment you are going to give? Ceftriaxone. Very good. Now, cephalosporins, I agree. Cephalosporins and penicillins, both of them will have some common point. Have something called as beta-lactam ring. So, this both antibiotics works with the help of a ring called as beta-lactam ring. Without this beta-lactam ring, these drugs cannot work. So, cephalosporins and your what is that? That is your penicillins. Now, if you look here, cephalosporin and penicillin, they will also show one more thing called as cross allergy, my dear students. What is that? Cross allergy. Now, what do I mean by a cross allergy? The cross allergy, I mean to say that if person is allergic to penicillin, that means he is high likely that he is allergic to cephalosporin also. This type of allergy is only called as cross allergy, and the same way cross resistance also work. If the bacteria is resistant to one antimicrobial agent, that can be resistant to another microbial, then we call it as a cross resistance. Same way, one antimicrobial agent, the person is having an allergy, the other one also he'll get allergy, called as cross allergy. If resistance also same way, then we call it as a cross resistance. Okay, now now my dear students, after you understood about cephalosporins, the cephalosporins again they're used for gram positive. Okay, then they're used for cocci, and they're available both in the form of tablets, they're available in the form of injections. They're also used for one more infection called as bacterioids. Okay, once we understood about that, let's go to the next aspect. What is that? Guys, remember, after you gave a beta lactam antibiotic, now bacteria, will it keep quiet? Now bacteria, it will not keep quiet. Bacteria will produce an enzyme called as beta lactamase. It will produce an enzyme called as beta lactamase. It will produce an enzyme called as beta lactamase. Now this beta lactamase break the beta lactam ring. So if it break the beta lactam ring, automatically will your antibiotic be useful? No. For that purpose only, what we can do, my dear students, we can inhibit. What is that? That is your, yes, okay, we can inhibit. That is your, what is that? That is your most important aspect. That is your beta lactam, that is beta lactamase inhibitor, such as a clavulanic acid. Apart from the clavulanic acid, we have one more drug that is called as tazobactam, my dear students. What is that? Tazobactam. Now tazobactam and clavulanic acid, they're used for what? A combination with what? Combination with other antibiotics. Other antibiotics. Which antibiotics? Of course, beta lactam ones. Okay, now you people might have noticed one classic example you might have found, that is your, what is that? Amoxicillin plus clavulanic acid. This combination is only called as, we call this combination as augmentin. Okay, so what is an augmentin, my dear students? This is your augmentin related story. Now, apart from that, my dear students, I want you to understand some of the most important aspects related to these antibiotics. That important aspect, once we are done with that, then we have one more type of antibiotics. What are those type of antibiotics? Let's see. So, we learned about vancomycin, we learned about cephalosporin, we learned about inhibitors. Then we have one more thing in the cell wall synthesis inhibitor called as azithromycin. Remember these names, that is enough. Azithromycin. Okay, streptogramins also fall in this case. Streptogramins also fall here. Then apart from that, we have one more type of antibiotics called as carbapenems. What is that? They're called as, my dear students, carbapenems. Carbapenem. Okay, now carbapenems. This carbapenem will fall. Carbapenem. Apart from that, we have carbapenems. We have drugs. What are those drugs? We have drugs such as meropenem. We have one more drug called as imipenem, and dorepenem. What is that? Doripenem. These are some antibiotics to be remembered. Okay, now once you know about this, let's go to the next important aspect of antibiotics. They are called as protein synthesis inhibitors. Now protein synthesis inhibitors, they are what type of antibiotics? Usually they are a type of bacteriostatic antibiotics. They are your bacteriostatic antibiotics. Now, when you want to understand about the bacteriostatic antibiotics, what are the bacteriostatic antibiotics we have? We have the antibiotics which will inhibit 30S subunits. So these 30th subunits of ribosome. So ribosomes are responsible for what? Protein synthesis. If you inhibit the 30th subunit of a ribosome, automatically the bacteria will not be able to do the protein synthesis and bacteria will not be able to replicate. So stop the growth of the bacteria. We call it as, what is that? We call it as what is that? We call it as one of the most important ones, called as 30th subunit and protein synthesis bacteriostatic inhibitors. Okay, so somebody says, what is that? Macrolides. Very good. Macrolides does not come under 30th subunit inhibitor, rather macrolides come under a 50th subunit inhibitor. Got it, my dear Ishan? Okay, so let's look here. Okay, now, what do we have? We have a drug called as aminoglycosides. We have drugs called as aminoglycosides. Now, aminoglycosides. Can anybody tell me some aminoglycosides? The aminoglycosides, we have drugs such as gentamicin. Okay. Apart from gentamicin, one more antibiotic I want you to remember, that is your streptomycin. What is that? Streptomycin, gentamicin and streptomycin. Okay. Now, this gentamicin, streptomycin, okay. Thank you. Now, look here, gentamicin, streptomycin. Why these two drugs I am focusing? One of the most important question here is that ototoxicity. Ototoxic drugs. What is that? Ototoxic drugs. Ototoxic drug means toxic to your inner ear. And one more thing, this ototoxicity is also caused by one more drugs called as loop diuretics. What is that? Loop diuretic. Okay. Now, streptomycin is what? It is a type of second line injectable anti-TB drug. Injectable anti-TB drug is a type of injectable anti-TB drugs. Okay. Now, apart from this 30th subunit inhibitor, next group of antibiotics we have, that is your tetracyclines. What is that? Tetracyclines. Now, what are these tetracyclines? Tetracyclines are very important ones. Tetracyclines are widely used for what? Vector-borne diseases. For what? Vector-borne diseases. Okay, for the vector-borne diseases, we are going to use the tetracyclines. Tetracyclines such as, we have a drug such as doxycycline. Okay. Apart from doxycycline, we have a drug called as demiclocycline. What is it? Demiclocycline. Then apart from that, the direct drug is there, that is called as tetracycline itself. Okay. So these are the three antibiotics we have. But the most important aspect, my dear students, demiclocycline earlier used for your, what is that? Earlier used for SIADH. Okay, earlier used for what? Syndrome of inappropriate ADH production, but now we don't use it. Rather, we use V2 antagonist called as Waptans. Okay, now aminoglycosides. See, calcium channel blocking effect is this. There are other effects which are very non-significant when you're looking at an aspect of a exam-oriented point of view. Okay, especially in a MCQ point. Now, tetracyclines, where we use, we know, vector-borne diseases. But there are some important factors. They are contraindicated in which patient? In the children and pregnant female. If you use in the pregnant female, what will happen? If used, baby will develop. What are the problems? Baby will develop problems such as, that is yellow tooth and skeletal defects. So same problem, because of the skeletal defect, we avoid them in the children also. Okay. All right. Now, once you know about tetracyclines, let's go to the next group of antibiotics. Clear about aminoglycoside part here? Okay. Now, let's go to the next aspect. What is that next aspect? The drugs which inhibit the 50s subunit of the ribosome. The drugs which inhibit the 50s subunit of the ribosome. We have drugs such as macrolides. We have drugs such as Macrolides. Okay. Now, apart from macrolides, we have another drug called as slindamycin. Slindamycin. Apart from that, we have drugs such as linezolid. So all these drugs, linezolid, all these drugs are what? They are your, what is that? 50S subunit inhibitor. So macrolides such as your azithromycin, such as your clarithromycin. Now these antibiotics are widely used for respiratory tract infection. Okay. Now linezolid is a type of reserved antibiotic. We don't just use it for every patient, but linezolid is rather reserved antibiotic. Okay. Then we have erythromycin. This is a very important antibiotic. Why? I'll tell you. Because erythromycin is a type of antibiotic which is safe in children. And also erythromycin interact with can anybody tell me interact with one of the most important drug, that is your thiophyllin. Interact with which drug? Thiophyllin. This is a story of your 50S subunit inhibitor. So after protein synthesis inhibitor, we have drugs such as DNA synthesis inhibitor. So DNA synthesis inhibitor, the classic drugs we have fluoroquinolones. What is it? Fluoroquinolones. Now, when you are talking about fluoroquinolones, these fluoroquinolones are very important ones. Why? You'll understand there are so many important and interesting MCQs related to this also. Okay. Now, when you want to understand about the fluoroquinolones, my dear students, fluoroquinolones, drugs such as ciprofloxacin, then there is ofloxacin, then there is levofloxacin. Okay, then there is one more drug, moxifloxacin, which is not widely available in India. Okay, now fluoroquinolones, my dear students, fluoroquinolones, their mechanism of action is very important. What is the mechanism of action of fluoroquinolones? They inhibit DNA gyrase. Now, DNA gyrase of human or a bacteria, DNA gyrase of the bacteria. Okay. Now, the uses, they're used for many conditions, many infections. One of the infections you can remember, in cholera also we can use this drug. Okay. Now, but the most important aspect is that this ciprofloxacin is called as urinary fluoroquinolone. Levofloxacin is called as respiratory fluoroquinolones. Means for the respiratory infection we prefer levofloxacin, and for the urinary infection we prefer ciprofloxacin. And there is one MCQ which is being frequently asked in all the exams, that is the side effect. The side effect caused by these drugs are your tendinitis. Now, tendinitis occurs in which type of population? In the children. If you use this drug in the children can develop the tendinitis. That is a side effect which can be caused as a result of, what is that? As a result of using of this drug. What is that drug? That is fluoroquinolones. Okay. So this is the important aspects which are related to your one of the antibiotics. What is the topic? Antibiotics. So this is the most important things which you need to learn from the antibiotic in the topic, in the point of view as a revision. Now let's go to the next aspect. The next aspect is anti-cancer drugs. My dear students, listen to me very carefully. Anti-cancer drugs are one of the important one, but how do we learn anti-cancer drug? So please don't remember anti-cancer drugs the uses from pharmacology, because the uses of anti-cancer drugs is wide range, not just something like, okay, some small aspect, okay, 1-2 lines are there, it will get over, not like that. The anti-cancer drugs are combined used, means there are some drug regimes, there are some drugs combination has to be used, okay, there are some newer agents. So all these things might vary, but there are some pharma related, very, very important MCQ related aspects which I want you people must know. Let's learn about those. Okay, now anti-cancer drug, along with the classification, I'm going to discuss the drugs also. We have anti-cancer drugs. So all these anti-cancer drugs act on where? Act on the cell cycle. Usually act on where? Cell cycle. So in the cell cycle, in different stages, they will act. But one of the first and most important drugs we have called as alkylating agents. Alkylating agents. Now in this alkylating agents, we have many drugs. What is that alkylating agents? So in the alkylating agents, my dear students, we have drugs. The drugs such as one of the most important called as cyclophosphamide. Cyclophosphamide. Now, when you're talking about cyclophosphamide, listen to me very carefully. This cyclophosphamide is such a drug. Cyclophosphamide is such a drug. It will cause one side effect. It will cause one side effect. The name of the side effect is called as hemorrhagic cystitis. So the most dangerous side effect of cyclophosphamide, one of those side effects which is frequently asked, is your hemorrhagic cystitis. So the treatment for your hemorrhagic cystitis induced by your cyclophosphamide is called as mesna. Okay, very good, called as mesna. Okay, now please listen to me. This cyclophosphamide is such a type of drug which will cause hemorrhagic cystitis because of its toxic metabolite. The toxic metabolite. Why hemorrhagic cystitis occurs? Because acroleon is a type of metabolite. This metabolite causes hemorrhagic cystitis. The next important drug which is there here, that is called as melphalan. Then we have one more drug called as chlorambucil. Okay, so these drugs are your, what is that? That is your alkylating agents. In this, there is one more drug, my dear students, that is only called as busulfan. Now this busulfan will cause one side effect, that is your pulmonary fibrosis. So yesterday I told you people one drug causes pulmonary fibrosis. What is that? Amiodarone. Along with that, you need to remember this one. What is that? This is your busulfan. Clear, everybody? So once you understood about this, the next important group of drugs which I want to discuss are anti-metabolites. Now what are these anti-metabolites? Now these anti-metabolites are a group of drugs which is having inhibition of cell cycle, but from a different aspect. What is that different aspect? The first and most important one we have called as a folate antagonist. Basically, listen to me very carefully. If your cell has to synthesize any DNA, any RNA, for that you require a folate. That folate, if it has to come from folic acid, if it has to convert into folate, it requires some stages. For that we require one enzyme. What is that? Dihydrofolate reductase. Now, dihydrofolate reductase is inhibited by your drug called as methotrexate. The mechanism of action of methotrexate is what? Inhibition of dihydrofolate reductase. Okay, now this dihydrofolate reductase is inhibited. The methotrexate is very much myelotoxic drug. It is a type of myelotoxic drug. There are uses of methotrexate. It is used in multiple places such as rheumatoid arthritis. There are some skin autoimmune conditions. Of course, in the cancer. Okay. Now, apart from that, Apart from that, there is anything else? Thank you. Then is there anything else? Yes, there is one more aspect. This methotrexate is used during, what is that? Ectopic pregnancy. During the ectopic pregnancy. See, ectopic pregnancy might require surgery, but there is one determining factor, level of beta HCG. Based on the level of beta HCG, if it is lower level, we can prefer methotrexate also here. Okay, clear? Okay. Okay, let's continue to the next aspect. The next important aspect, what is that? Once you understood about that, there is one more aspect. What is that? Purine antagonist. We have something called as purine antagonist. Purine antagonist. Now, what is this purine antagonist? Now, this purine antagonist, my dear students, the drugs such as 6-mercaptopurine. Mercaptopurine. Okay. Apart from 16 mercaptopurine, there is one more thing. What is that 16 mercaptopurine? And there is one more drug called as azathioprine. Azathioprine. Okay. Azathioprine and your and your 16 mercaptopurine. Everybody able to follow? Okay. So now, once you know about this azathioprine and 16-mercaptopurine, then we are going to go to the next group of drugs, that is pyrimidine antagonist. Pyrimidine antagonist. Pyrimidine antagonist. Now, this pyrimidine antagonist drugs, we have few drugs. What are the drugs we have? We have a drug called as 5-fluorouracil. 5-fluorouracil, and there is one more aspect to it, that is only called as cytarabine. What is that? Cytarabine. So these are the two drugs which you need to remember from, what is that? From the pyrimidine antagonist. Okay, let's go to the next important drugs. What are those, my dear students? See, the drugs, next group of drugs, there are lots of drugs here. You are not going to remember everything at one go. Okay, so one go, but you can remember them with the time. Okay, now let's go to the next important drugs. They are called as vinca alkaloids. Vinca alkaloids are your plant derivatives. These are the alkaloids. The drugs are vincristine and vinblastine. Vincristine and vinblastine. Now, vincristine, vinblastine are widely used, but one of the uses I can tell you is rhabdomyosarcoma. It is also used for rhabdomyosarcoma treatment. Okay. Now, my dear students, we have one more important aspect. In the human, we have topoisomerase. Topoisomerase 2 inhibitor. We have a drug which is inhibiting the topoisomerase. The name of the drug is called as etoposide. Etoposide. What is that? Etoposide. You can look at it as, you can look at it as topoisomerase inhibitor. Topoisomerase inhibitor. Here. Okay. Now, apart from that, my dear students, the next important drugs, the antibiotics. There are some antibiotics with anti-cancer property. Now, since they are having a nice anti-cancer property, we use them directly for anti-cancer treatment itself, such as adriamycin. Apart from adriamycin, then there is one more drug, that is mitomycin. Then there is one more thing, mitomycin C. There is one more thing called as doxorubicin. Now, this doxorubicin is a very important MCQ, because they will ask a question, what exactly is the dangerous aspect to it? This doxorubicin is a type of cardiotoxic drug, guys. Cardiotoxic. What is the drug? Cardiotoxic drug. Okay. Now, apart from this, there are some other drugs. Other drugs, please understand, we have drugs, that is platinum derivatives, you can call it as. These platinum derivatives, all of them will have drug name platin in them, that is such as cisplatin, we have one more drug called as carboplatin. Carboplatin. Now these platinum drugs, the side effects, they are very much, since it is a heavy metal derivative, they are nephrotoxic, my dear. What is that? Nephrotoxic drugs. They are your nephrotoxic drugs. So this is the important aspects which you need to remember related to anti-cancer drugs. Okay. Now apart from that, in the cancer we use other drugs. What are the other drugs which we use in the cancer? The drugs which are related to hormones, especially in the gynecological cancer, such as GnRH agonist, and there is one more hormone related, that is 5 alpha reductase inhibitor, which I already taught you people, that is finasteride. Clear everybody? So with this much being said, we will conclude the class here. Okay. Hope the pharma revision was useful for you people. In a span of 10 to 12 hours, I have tried to given you the complete overview of the pharma, and I have given you the most important high yield MCQs. Okay, so if you learn and remember all the antibiotics, all the anti-cancer drugs, all the, for example, endocrine system, and for example, all the important points in all the topics, just important points which I highlighted, even if you remember them, you should be able to solve most of your questions. Most of your questions will be solved from here only. This much I can assuredly guarantee you people. All right. See, this much is sufficient. See, once if you have studied, yes, for revision, it is sufficient. In the time span you have, if you have, there is about 1 to 1.5 months, this is sufficient for you. So, if you don't have anything else, see you people in the next upcoming sessions. Thank you so much. Thank you so much for being with me, for paying attention, and see you people next time. Bye-bye. Thank you.